Assalamu alaikum. Good morning, everybody. I'm Dr. Amna Khalifa Al-Hadari. I'm consultant and head of nephrology department in Dubai Hospital. I would like to thank you all attendees for this meeting and wish all of you the best of this educational meeting. Kidney transplant was a dream in Dubai Hospital. We went through several challenges. Finally, we were able to achieve our target and started it in Dubai Hospital. Fortunately, I was part of this team and the journey continues. And this meeting will be part of our journey. So today, I would like to welcome Dr. Hcl Expression. He's the founder of kidney transplantation in UAE. So Dr. Hcl Expression, please start your first lecture.
Thank you very much, Dr. Amna. Thank you. It's a great privilege to be invited to this great meeting, and I look forward to working with all of you.
Please share your slides.
Can you see my slides? Can you see my slides?
Yeah.
Okay. Thank you. So now in these few minutes, I would like to highlight our experience in UAE in supporting setting up kidney transplantation programs. So as you know, kidney transplantation, if we think about solid organ transplantation, we are only meeting 10% of the global demand. This means that 90% of people who require organ donation, unfortunately, don't find it and lose their life. And of course, the largest program in volume is always kidney transplantation. So there is a huge demand on kidney transplantation worldwide. And when it comes to the survival advantage, I'm sure the rest of the speakers will talk through lots of details. But in short, I think kidney transplantation provides better quality of life, longevity, survival, even if it comes to senior people or elderly. And that was the basis for us to be very supportive of establishing many kidney transplantation programs to hopefully meet the demand. In terms of how many transplant programs or centers we have in UAE today, so we have in Abu Dhabi, SKMC, Sheikh Khalifa Medical City, part of Abu Dhabi Health Services company. We have pediatric and adult kidney transplant. We have Cleveland Clinic Abu Dhabi has an adult kidney transplant program in addition to the multi-organ. And then we have under the umbrella of MBRU, both MediClinic in Al Jalila, in Dubai, they offer pediatric and adult kidney transplantation. As Dr. Amna mentioned, we have Dubai Hospital, part of the DHA in Dubai, offering kidney transplantation, and also Al Qasimi Hospital, part of Ministry of Health and Prevention in Sharjah, offering kidney transplantation. As I highlighted briefly, I think transplantation provides not only survival advantage, but also in terms of health economics, it saves the health system costs. And with the great burden of disease and the increasing CKD burden, as well as end-stage renal disease, I think it's key that we enable kidney transplantation to be offered widely. Now, how did we take this journey? We did not reinvent the wheel because we are part of the GCC, though. So the Gulf countries cooperation, we are part of the annual GCC transplantation group meetings. And we also have a unified directory of regulations for organ transplantation in the GCC. So rather than we reinvent the wheel, we had adopted a unified GCC criteria for enabling or opening new programs. and I can briefly take you through some of these principles. So I think, as you will hear for the rest of the day, you will see that there are so many great talks about, how do we maintain the well-being and the safety of patients who end up receiving a kidney transplantation, from preventing infections, from having the right approach to treating rejection, and so on and so forth, as the rest of the program. So what we do, and we adopted this, that is applied in Saudi Arabia and also the rest of the GCC, that we have these criteria. We work with the particular hospital that is thinking of opening a program, and we provide them with all the requirements, the criteria. And in essence, this is quite basic, that whether it's here or in the US or in Europe, usually a certificate of need or a demand for such service needs to be established, that the program has solid plans to expand the program and also ensure that they have the right staff. So some details about transplant nephrologists, surgeons, the nursing staff, transplant coordinators. And our advice here is to go with the established ratio, because it's easy to start a program and then one may get difficulty in securing additional funding. So it's better from the get-go or from the beginning to establish a care coordination ratio. So similar to dialysis, when we anticipate that every 3 or 4 dialysis patients, they need a nurse to take care of them or to put them on and off dialysis, the same applies. So every 150 to 200 transplanted patients, they need a nurse or a care coordinator, so that as the program grows, there are dedicated dietitians, social workers, so the whole team, because we know it's not only the surgery, it's the comprehensive care that an individual needs to receive in order to maintain the longevity of the transplanted kidney. There are some additional requirements, as you can see, and we will share, I think we can share these details. These are applied in Saudi as well as other GCCs, and also for us in UAE. And these are details that address access to laboratory services, radiology, drugs, immune suppression, etc. And if I take you to the last page, which is very important, is that not only we look at commissioning or accrediting a program to open kidney transplantation, we also are very keen to monitor what's happened afterwards. So many countries decide what's the minimum number of transplantation that a program needs to start doing in order to maintain the license. So I kept it open as an XYZ per year, but different countries, I think we have to make sure that the minimum number of transplants are done to ensure the volume-based competencies, in that we are not doing just a handful of kidney transplants a year, which will not be good for the team because they may lose their skills, and also for the patients, because it's better for patients to be taken care at a high volume center. Now, the other detail is that if you read about 6.23, is that the transplant center, as well as the health system that they are part of, they need to document and demonstrate that they are participating actively in the deceased organ donation, and that their ICUs are fully referring and active. So we apply this, for example, where I work in Abu Dhabi. If the Saha hospitals, and we have a group of 13 hospitals, were not actively participating, I think in due time, we have the right to perhaps question if we should allow Saha to have a kidney transplant program, but not participate in deceased organ donation. And this is good for everybody. So these are some details that we anticipate, and also to have graft survival details reported on a regular basis, patient survival, as well as an annual outcome book or report to be sent to the Federal Ministry of Health and Prevention about the activity of that transplant program. We know for many of us, this is the start of the journey, so we have a long way to go, and as you know, this is a pandemic year, but I think programs are, despite that pandemic, are continuously evaluating patients, trying to prepare them to go on the list. Now, what about deceased donation? I'll tell you a little bit that in UAE, we have a defined unified protocol that enables hospitals to refer potential donors so that we are not only setting up too many kidney transplants without adequate volume. So we have these protocols in Arabic and English, and we have the teams are already operational. The other thing is I will take you through that it was not too long ago, 2017, when we started our first deceased donation, and this was from Al-Qasimi Hospital in Sharjah, where our first donor became a 5-organ donor. 2 kidneys were transplanted in UAE, and the additional organs, lungs, liver, and pancreas were transplanted in neighboring Saudi Arabia. Now, since then, this slide is a bit older, but we have now 34 deceased donors, resulted in more than 115 lives saved. Of course, the majority are kidney. And these are the details when UAE started its heart, lung, liver, pancreas, an expansion of the kidney transplantation. And we look forward in working with all the centers to improve organ donation rate. Now, we are in the beginning of the journey for deceased donation. As you can see from the slides, countries are ranked according to the donation per million population. So whereas we are a bit starting and our numbers are slow, but if we look at it from a different angle, you see that in terms of the number of donated organs per deceased, meaning that for every single donor, we seem to be having a good rate of donation. And this is because we maximize the organ donation opportunity per deceased, and we also share within the region about organ sharing. Now, I will just say a few more words before I conclude this short talk, is that I think transplant programs need to go, in dialysis and renal programs need to go way beyond just measuring transplant outcomes, patient survival, graft survival. In this great paper by a Canadian group by Greg Knoll and Joseph Kim from Toronto, where I trained, I think they highlight in detail, and I think this was the basis for the Canadian consensus guidelines about quality metrics and quality standards of measuring the successful addition of kidney transplantation to a program like UAE. So this great paper, I strongly advise that we all read it. And in fact, we may use it at the national committee to try to rate how much are we participating in this. Now, in brief, this paper highlights the domains of the healthcare quality as defined by the Institute of Medicine in terms of, the care, whether it's a kidney transplantation or any other service, needs to be safe, effective, patient-centered, timely, efficient, and equitable. And then they try to apply all of these principles to kidney transplantation and specifically define what could these measures be in terms of denominator and numerator, to say, well, these are the criteria that an individual program has to, like the percentage of CKD patients and dialysis patients who have been documented discussion about the transplantation, and so on and so forth. So these criteria will ensure that we are not only commissioning kidney transplantation program, but also that we are subjecting the dialysis programs to the responsibility of ensuring that every patient is getting their the right of being listed, of being discussed, so that they can consider. And they go on and on to address each of these major principles about the timeliness, about the effectiveness, etc., and how efficient and safe it should be, and as it's applied to kidney transplantation. So In short, I think UAE is glad that we have now commissioned 6 transplant programs, maybe 6 centers and 7 programs, 2 pediatrics. But we are looking forward to working all of us together to make sure that these transplant centers serve the maximum number of people who need this service. And with that, I end my talk. Thank you very much.
Thank you, Dr. Ali, for an excellent UAE experience. I would like to introduce our second speaker, Dr. Hatem. Dr. Hatem is the director of Dubai Cord Flood and Research Center. He's head of DCRC Laboratories, HLA and Stem Cells Processing Labs of Dubai Health Authority. Welcome, Dr. Hatem. You can start and share your slides, please.
Assalamu alaikum. Thank you for giving me this chance to participate in this prestigious meeting. It's my pleasure and my privilege, actually, to talk about what we are doing in the laboratory for the assessment of donor and patient for the transplant. So I will talk about the immunological assessment of the transplanted patient or donors. Can you see my slide, please?
Yes, yes, we see.
Okay. Let us start with the introduction about this. So, following the first successful kidney transplantation, which was in 1954, the field of organ transplantation has undergone a remarkable development, leading to an even greater understanding of underlying immune mechanism that control graft outcome. As Dr. Ali previously said, it's a matter of quality of life for the patients. Okay, so they need to understand exactly what the transplant is and what is doing for the patient. It's not as a treatment, but it's concerned about the quality of life. So you need to monitor this patient always to keep him in a good life manner. The past decade or more has witnessed great advance, not only in the antibody detection technique, but also their removal strategies. And together, these have helped in achieving a steady improvement in organ transplant. This is what we are witness now. Now the transplant are very good controlled. Accordingly, kidney transplantation is now well established routine treatment strategy of patient with the end-stage renal disease and those waiting on dialysis. Of the various factors that influence graft function following transplantation, development of the antibodies in the recipient, either in pre or post-transplant, is a major factor leading to graft rejection. So this is the main obstacles and the main problems always in the transplant is to monitor the antibody because it's the main factor of rejection and losing your organ after you implanting it. And it should be irregular intervals. This is an important prerequisite. According to each protocol and each country, they have their own standards for monitoring these antibodies. Before we are talking with the antibodies, of course, the antibodies are anti-HLA antibodies. So we will just give a brief about the HLA itself, which is the major histocompatibility complex in humans. The superlocus contain a large number of genes related to the immune system function in humans. This group of genes reside in chromosome number 6 in the left arm of chromosome number 6 and encode cell surface antigen presenting protein and many other genes in this region. The proteins encoded by certain genes are also known as antigens as a result of their historic discovery. The historic discovery, when they did antibodies, they found that antigen as factor in organ transplantation. HLA class 1 and 2 are the main classes concern the transplant communities, not because there is HLA also class 3 for pharmacogenomics, but for the transplant people, they concern about the class 1 and class 2, which they were classified according to class 1 and class 2. There is a letter for this, which is called HLA, B, and C. This is class 1. And class 2, it's DR, DQ, and DP. where the DR is a little bit different than the others. It will contain alpha and beta chains. It contains 4 beta chains with 1 alpha. Always when we are writing the result or in the nomenclature, we are call it HLA-DRA1 and the numbers which is represent the locus and the gene. 4 beta chains, only 3 possible in the person. 1 is DR, it will be coded as DRB1, and then you will find the number near to it, including what DRB was. And DRB3, 4, 5, this is called associated group. Before they're calling it DR50 and 51, 52. And DQ, it's contain alpha and beta chain, whereas DQ alpha and DQ beta. And then we have also the DB, and recently the people more interesting in DBs and even typing it now, but we are typing it with high resolution. And it's believed that it cause sort of rejection. So now the people also typing DB, and it's concerning us in the antibody, especially in single antigen antibody, you'll find a lot of DBs because people are not typing it. Then when you match or when you transplant patient with different in DB, it will start giving some antibodies. This is the diagram of the HLA of chromosome, left arm of chromosome number 6, where you find class 1 and class 2 and class 3 as well. There is a big debate in kidney transplant to do much or not. But with the advent of a potent immunosuppressive agent and impressive improvement in graft survival along with the falling rejection rate, now there is not a lot of rejection rate actually. In renal transplant patient, the debate over to HLA match or not to match has further been intensified during the last few years. The accumulated data suggests that better HLA matching not only leads to better graft survival or lower grade of sensitization for retransplant, and of course reduce the incidence of development DSA, but also it's very important that it's because it's associated with the administration of lower dosage of immunosuppressive agent and decreased incidence of side effect of immunosuppression. Of course, immunosuppression will have a lot of side effects, so better HLA match will decrease this side effect of the immunosuppressant because, of course, you are not giving a high dose of this. Okay. Then the most important things in renal transplantation or mostly of the transplant is the antibodies, the HLA or anti-HLA antibody. And this, the HLA antibodies, according to them, you are keeping your organ or not. Because based on the time of occurrence, allograft rejection have been categorized as hyperacute, and it's happening on table at the serial says it's here after hours, and this is now it's eliminated because people doing CDC cross-matching or flow cross-matching, so there is rare to have a hyperacute rejection. Then acute rejection, this will happen days to months, and chronic rejection, which will take months to years. It has long been recognized that the presence of performed donor-specific antibody, which is donor-specific, that means we have antibodies against the HLA of the donor in high titers in kidney recipient as associated with hyperacute rejection, which is now extremely rare due to the adoption of pre-transplant CDC cross-matching. Nevertheless, pre-existing antibody or those developing de novo following renal transplantation are an important cause of acute rejection, particularly if these are donor-specific. Others have also shown a strong association of HLA-DSA with the development of chronic rejection. The major antigenic stimuli that lead to the formation of HLA antibody recipient are blood transfusion, pregnancy, and previous transplant. And this is the 3 main factors we should consider it when we select our donors, and we have to know the situation of the patient before selecting the donor, because the high BRA or the antibody formation is due to blood transfusion mainly if the patient has gone through a lot of transfusion, pregnancy, and this is for the female. And if the patient is ex-transplant, then we are expecting to have antibodies highly. Then we have to type these antibodies and to look after is it DSA or not. The first real major breakthrough that laid the basis for antibody detection in the field of solid organ transplantation came with the introduction of complement-dependent cytotoxicity, which is a method done by Terasaka and McLean. The CDC assay has been adopted universally, and this has greatly helped to overcome the initial challenge of hyperacute rejection. But even the assay is very, very nice assay, but it has several limitations. And one of the most important limitation is the lower of its sensitivity, which is lead people to go for flow cytometry, was introduced in the early 80s and was not only 10 times more sensitive than CDC assay, but also provided crucial information on the cell types, because there you can sorting the cell and doing your cross-matching in B and T cell against which the antibody was directed. This is by the traditional flow cytometry technique. The advent of based after the flow cytometry, not after, with the barrel of the flow cytometry, then we came with the Luminex, which is mainly detecting the antibodies also. The advent of bead-based solid phase immunoassay system using the Luminex platform has significantly increased the pool of highly sensitized patients requiring either life-related donor or awaiting in the deceased donor kidney transplant history. The technique provides a unique opportunity to perform virtual cross-match. Virtual cross-match, that means it's not a physical cross-match as we are doing in the CDC. That means there is a serum of the patient and cell of the donor. Virtual cross-matching, we are doing a profile of the antibody against the profile of the donor, the antibody of the patient against the HLA of the donor. So you can expect the result of this cross-matching and how the transplant will be. And mainly this technique, they are using it for the deceased donor because you don't have time to do fully cross-matching, and it's easy to be done, but it's need expertise people so as to decide on which acceptable and not acceptable for the transplant. The past decade has been seen an increasing interest in understanding the antibody basis of graft rejection, and accordingly, a flurry of published literature has become available on antibody-mediated injury or in allograft recipient. The basis of this new interest or newfound interest has been attributed to greatly reduced rate of acute cellular rejection due to discovery of novel and more potent immunosuppressive drugs. This success, along with the recent technical advancement in detection and characterization of HLA antibody with a greater degree of sensitivity and specificity, has highlighted the relative importance of antibody-mediated rejection. It's now accepted that the presence of pre-transplant HLA class or class 2 donor direct antibody DSA are a definitive impediment to successful kidney transplantation. A lot of studies have documented that the combined presence of both anti-HLA class 1 and 2 antibodies lead to more frequent rejection episodes than those having either of these antibodies alone. Although the current methodologies provide reasonable high degree of sensitivity in antibody testing, the moot question concerning their exact clinical relevance in terms of graft survival remain unanswered, because there is a difference between in vivo and in vitro, as all of you know. So still, it's need interpretation. It's need clearly to interpret your result always when you are doing it, and to correlate it with the clinical data and a lot of things you need always to look after. The significance of donor-specific antibodies detected by Luminex-based SAP single antigen beads in recipient with negative T-cell cytotoxicity cross-match need special mention. Sometimes you will detect some antibodies with negative, even the T-cell cytotoxicity cross-matching is negative, and then you will find also the beads are positive because of the matter of what's called sensitivity. Several studies have revealed a negative impact of DSA detected by Luminex-based SAB assay on allograft outcome, while anti-HLA antibody detected through the CDC test are an absolute contraindication for transplantation. DSA detected by assay other than CDC represent varying degree of risk. It's again, it's a matter of judgment. So a method for detection of these antibodies for the patient or the donor, many years have passed as the introduction of complement-dependent cytotoxicity since 60s as the first technique for the detection of HLA antibodies in the recipients prior to transplantation. Since then, methods to detect them have evolved from purely cell-based CDC cross-matching, flow cross-matching. This CDC mainly will call it as a cell-based cross-matching, and flow cross-matching with it's a mix actually, cell-based and bead-based. Now we have flow DSA. Cell-based technique to solid phase assay with increasing degree of sensitivity and specificity. The evolution of techniques has played a big role in achieving greater success for organ transplant, because we can call it a transplant in a tube, because you are doing actually virtual surgery in the lab. So cell-based assay, we can talk a little bit about CDC cross-matching, which is the golden standard. Even it's old-fashioned, but still is the golden standard of the many transplant. The study by Terasaki revealed that, the study was done in 1969 actually, revealed that 80% of recipients transplanted with a positive CDC cross-matching experienced hyperacute rejection. There's no doubt about that, while the rest, which is 20%, had an uneventful post-transplant course, whereas only 5% of recipients with the negative CDC, it's a negative CDC cross-match, suffered early graft loss, even it's a negative. This study not only made the CDC testing mandatory, but also exposed its limitation in terms of sensitivity and specificity, because it cannot detect the lowest titer of the antibodies, or antibodies in very lower titer. It's CDC cannot detect it. To improve the sensitivity, certain modifications such as addition of anti-human globulin to enhance the binding affinity, wash step to remove low affinity of antibodies, prolongation of incubation time allowed binding of low avidity antibodies have been used from time to time, but this still with limited successes. So simply the test of CDC cross-matching is a matter of adding the serum of the patient and mix it with the cells of the donor, and this is the serum of the patient. It represents the immune defense, and the cells of the patient, sorry, the donor, it represents the kidney which you are going to transplant it. Positive cross-matching, that means suitable, it's not suitable for transplant, this donor, and negative cross-matching, that means the patient is suitable for the cross-matching, provided that you have to do a very sensitive testing beside the CDC. That's why people now doing flow cytometry and CDC in the same time. CDC, it's employ lymphocyte target to detect complement fixing antibody, and this is one of the cases. it should be complement fixing, transplant in a test tube, binding of antibody target antigen on cell membrane, induce conformational change in antibody molecules, exposing the FC fragment that bind to complement. Complement cascade is activating, leading to membrane damage and cell lysis. So the test is dependent on cell lysis, and this is one of the big disadvantage of this test. It's a matter of cell viability. If the cells viability, it's the cells are very good and viable, very good and viable, that means viability is more than 90%. That means you can perform the test and you will get, because the result is cell death or cell lysis. For then the quality of the cells, it's very important, and this is one of the major disadvantages of this test. Is an essential pre-transplant test as identified before antibody responsible for hyperacute rejection. We are doing it as a donor cross-matching and autologous cross-matching in the same tray. It's depend on, again, in the laboratories they are doing it. They have certain way to do it. But for us, we are doing it donor and cross-matching and autologous cross-matching. The donor cross-matching is called, this is to employ serum from the recipient versus the cells from the chosen prospective donor. The test is intended to detect the presence of performed antibody in the recipient donor to donor HLA antigen. Autologous cross-matching, this test employs serum from the recipient tested with the recipient own cells. That means it's auto. Antibody detected in this test are termed autoantibody. It's highly recommended to be performed when the patient first time evaluated for transplantation, because if the auto cross-matching is positive, there is a high probability that any donor cross-match performed with that serum will be a positive, and determination must be made whether or not there is additional activity in the serum that is specifically anti-donor. This is how the test is done. This is we called it Terasaki trace. actually according to scientist Tarasaki, Dr. Tarasaki Patel. A patient serum will add it, then we'll add the lymphocyte of the donor, which is B lymphocyte and T lymphocyte. We can do cross-matching for B and cross-matching for C. Now we have new reagents. It's not new actually, but modification happened, and you can isolate B lymphocyte alone and T lymphocyte alone. Then you will add anti-human IgG so as to enhance the reaction. After that, you will serve several incubation. Then you will add rapid complement, and then you will read under the microscope. And this is another one of the disadvantage, because the reading is scaling from 1 or 2 to 8 according to the cell death. 2 is negative. That means you will see everything is green because of the dye you are using. It's a fluorescein dye, which is reflected with the UV light as green cells. If it's red, that means it's positive. So you will count the cell and do your percentage. 2 is negative, 4 is doubt negative, 6 is doubt positive, and 8 is positive. So it's subjective to the one who is reading the microscopy or how he is evaluating it. And this is one also of the disadvantage, because if it's not clean negative or clean positive, it needs some experience to give your opinion. In interpreting cross-matches, a basic understanding of Hcl expression is required. Class 1 molecules are expressed on all nucleated cells, while class 2 molecule expression is restricted to cells such as antigen-presenting cells. For example, dendritic cells, macrophage, and B cells, importantly, for transplant rejection pathophysiology. Both class 1 and class 2 can be expressed by vascular endothelial cells. So, most rejection response are thought to be due to difference in HLA between donor and recipient, with the HLA match antigen serving as the target in antibody-mediated rejection. Non-HLA antigen, of course, may generate rejection response, but in general, this thought to be less common. And this now there is a kit if you doubt about non-HLA rejection, there is a kit for 81R angiotensin 2 type 1 receptors and myosin and a lot of non-HLA antibodies. They discover it now. There are important differences in HLA expression between T and B cells, which influence the interpretation of the cross-match. T cells do not constitutively express HLA class 2. So the result of T cell cross-match generally reflect antibody to class 1 only. This, when we are reading the cross-matching, if the positive is T cell, that means it's class 1 only. B cell, on the other hand, express both class 1 and class 2. So if the positive B cell cross-matching, that means it could be class 1 or class 1 and class 2, or class directed class 1, or both of them, because it's expressed class 1 and class 2. That means if it's positive, B cells cross-matching positive, maybe it's class 1 only, it's giving the positivity, or class 1 and class 2. Hence, if the T and B cell cross-matching are positive, the interpretation is that there may be either single or multiple HLA class 1 DSA antibodies, or mixture of HLA class 1 and 2 DSA antibodies. While a negative T cell cross-match in the setting of B positive cell cross-match suggests either there is R1 or more class 2 donor antibodies, but no class 1 antibodies, that there is a low level of DSA antibody class 1 antigen with greater lysis of B cells relative to T cells. This often due to the fact that B cells express higher level of HLA class 1 than do T cells. When class 1 complement fixing HLA DSA antibodies are present at a significant level, one would expect both T and B cell cross-matching to be positive. By the way, if the T cell negative, cross-matching negative, and B cell is giving, T cell is T cell positive and B cell is giving negative, you need to repeat the test. The flow cytometry lymphocyte cross-match is a standard technique. This is, as we said, we move from the CDC cross-matching, looking for more sensitive technique, so that they develop the flow cytometry cross-matching, which is conventional cross-matching. And nowadays, but is not doing in the most of the center, or all centers, they are not doing it, which is called flow DSA, which is more convenient because It's giving cross-matching against the DSA or the donor antibodies, but because of the test cost and things, it's not routinely done in all laboratories. But the conventional one, the flow cytometry of site cross-match, is a standard technique for evaluating the compatibility of potential kidney transplant recipient and donors. Recipient serum is incubated with a donor lymphocyte, and the latter are analyzed in a flow cytometry for the presence of bound IgG antibodies. An increase in the level of IgG binding compared to the negative control indicate the presence of donor-specific antibodies, which may lead to deleterious graft function. A fluorescein isocyanate conjugate rapid anti-human IgG antibody was used to detect bound IgG following incubation of donor lymphocyte with the patient serum. R5-erythrin conjugated anti-human CD19 and quantum red conjugated anti-human CD3 monoclonal antibody were used to detect T and B cell population respectively. A major advantage of the flow cross-matching is that the antibody reactivity can be independently and simultaneously evaluated on donor T and B lymphocyte. In addition, because the flow cross-matching is a semi-quantitative measure of antibody binding, it can be less subjective than visual assessment of cell death in complement depending, because you are reading a graph, so it will not be a conflict between two to read a graph. The graph is a graph. After that, or in the same time, Luminex was developed. It's a semi-quantitative based array system in which polystyrene microbeads are coated with profiled HLA class 1 or class 2 antigen for detection and characterization of class 1 and or class 2 antibodies in human serum. There are three principal versions of the test. The test is called PRA or single antigen. The Luminex is the machine which you are using for this. It's the same like flow cytometry, but it has two laser, one detection laser and one reading laser. And it's very, very nice machine, easy to use and giving a very, very strong what's called the result. There are three principal versions of the test, namely pooled antigen, phenotype panels, and single antigen or single antigen bead. In the order of increasing resolution, the pooled panel antigen, or we call it mixed test, are typically used as a preliminary screening test to detect the presence or absence of class 1 and class 2 antibody. That means that the set of the bead is coated with class 1 as a class 1 and coated with a class 2 as a class 2. Then when you apply your serum to these beads, the reaction will happen. Then the Luminex machine will read it's positive or negative. Positive for beads of containing class 1 and positive or negative for beads containing class 2. That means you will know this patient has antibody against class 1, but from which you don't know because it's a screening test. It has no specificity in that. The second system involves phenotype panels that are able to detect antibody in their specificity against HLA class 1 and HLA class 2. That means the beads are coated with HLA class 1 allelic, or it's antigenic, it's the beads coated. Then with either class 1 or class 2 antigen derived from a single individual cell line. And there are more than one HLA specificity present on each bead. But the problem is there were more than, you can find A beads contain a lot of A's, a lot of B's. Okay, the other one is containing a lot of C's like that. So it's still, it's need more expertise to analyze it, because when giving the result, you need to be very careful in analyzing it. But the third one with the single antigen beads, this beads, any bead is coated with a certain one, which is allelic recombinant, HLA class 1 or 2 molecule. This enables accurate identification of antibody specificity and provide the highest degree of HLA antibody resolution, and this is we call it single antigen. So in this case, when you apply your serum, it will give you positive exactly for what antibody you need exactly. Luminex assay is a highly sensitive and specific for all the three versions, and enable precise identification of antibody specific and the donor HLA profile. Each bead bears single cloned allelic class 1 or class 2 HLA antigen. SAB assay permit detection of both epitope specific as well as allelic specific antibody that had previously been impossible. It does provide information in the virtual cross-match. So this we can do virtual cross-match here with the single antigen. The mean fluorescence intensity, or MFI, of the bead is a measure of the degree of saturation of total antigen present on the bead by antibody and is used as a surrogate marker for the level of antibody titer. The cutoff MFI value are subjected to each laboratory or each study variability. Most centers consider HLA-DSA with greater than 2,000 are significant and greater than 5,000 are highly significant. This is how the Lumix, as we said, working. The first laser is detecting the beads. It will tell the Lumix this bead is class 1 beads. Then after you apply the reaction complete with the BE and fluorescein, the other laser will hit the bead again and will tell the Lumix this bead is positive for that antibody. This is how we are reading the fusion or the HLA, the antibodies. You can read the MFI and read the single antigen and giving the result. This is how the workflow outlook. We are doing screening, then you are doing panel, then after that you will go to the latest one with the specific antigen. This is a determination how we are, or the method we are using. As you can see, the CDC and Luminix SAP. The CDC cannot detect any antibody unless it will be very high antibody, and the DSA detected by Luminix, it will detect it in a lower as much as now. Although the Luminix beads antibody detection system has been widely accepted worldwide, it's not free of limitation. For example, disparities in antigen quantity across different beads and conformational change in HLA antigen during purification and coating with the bead may lead to discrepancies in result of phenotype assignment. And for the SAB assay, it's possible that the conformational change in HLA antigen can be lead to the lower risk of false positive due to exposure of cryptic epitopes or false negative because of failure of HLA DSAs to bind to the distorted molecules, and this can be due to manufacturing. The discrepancies could be further aggravated due to the presence of IgM antibody, complement component, or the prosoome phenomena, all of which can interfere with the MFI values. To conclude this, the de novo development of DSA has adverse implication on renal allograft function and can be the first sign of ongoing damage. A lot of studies involving sequential sera testing have revealed that antibodies are generally produced long before the observed elevation of serum creatinine or development of rejection episode. The appearance of antibodies in terms of time elapsed following transplantation is a critical factor of prediction of allograft survival. That means we said we have to check antibodies of our transplant or our transplanted patient in intervals periodically, so as we can what's called predict what will happen to the graft as by time, so to avoid any graft lost. Thank you.
Thank you, Dr. Hatem, for an overview of immunological assessment. I think we are running 10 minutes late of the program now. So we'll start with Dr. Fakhriya's lecture, and then we'll keep the question just before lunch, before the next session. So I would like to introduce now Dr. Fakhriya Al-Alawi. She's a senior specialist registrar in nephrology in Dubai Hospital. And she's going to brief us about the patients with multiple comorbidities. Are they fit for the transplant? So Dr. Fakhriya, the floor is yours.
Thank you, Dr. Amna. You can hear my voice?
Yes.
Good morning. Assalamu alaikum. Assalamu alaikum. Good morning, everyone. Today, my topic is a little bit different. It is a general topic we are facing in each transplant center. I know that each transplant center want their patient to be perfectly well, healthy, apart of renal disease, of course, so they will avoid any comorbidities post-transplant. But are we justified to avoid patient with multiple comorbidity? This is my talk today will be. Definitely, everyone knows that renal transplant is the best available option for patients with end-stage kidney disease. It can improve the quality of life, it can reduce their morbidity and mortality. However, not all patients are suitable for kidney transplantation, since we have to select our patient very carefully to identify factors which might limit patient survival and graft survival, thereby to keep the transplant for those who really fit, and to avoid transplanting patients who might get harmed by transplantation. Definitely, this process requires multidisciplinary approach. So today my talk, this is my agenda. I will speak about elderly population, if they are fit for transplantation or not. I will speak about patients with high risk of cardiovascular disease, heavy smoker, patient with pulmonary disease, obese patient, and people with history of claudication. And if the time allow me, then I will speak more about patient who might have recurrent disease and patient on lifelong anticoagulation like lupus and others, and patient with a previous malignancy and patient with concurrent psychiatric illness. So what about elderly population? Some centers, like, they will save transplant for young or middle-aged population, and they might take away the elderly population. But are we justified to avoid elderly population in most of the transplant centers? Well, it is well reported that elderly patients, they have longer hospitalization after transplantation. They have a greater mortality risk secondary to cardiovascular events. They have more infectious episodes after transplantation, and usually it is bacterial infections. However, elderly population, it is well reported that they have few acute rejection episodes, but in the long term, in the US renal registry data, they demonstrated that elderly population are prone more than other people to develop chronic allograft nephropathy. Many people, they might say, okay, if we have a live donor, let's save it to a younger populations. But as I mentioned, because elderly biologic might have a shorter survival. But despite this fact, transplanted and elderly population who are aged above 60 and 70 years old, it is still much better to have a transplant if you compare them to those who stayed longer on maintenance dialysis. And it is well reported that those elderly who get a transplant, they will have a survival benefit, and they survive like 7.4 better than those who stayed on dialysis. So, in fact, for elderly population, you have to consider a biological age, not a chronological age. Definitely, you cannot get a transplant for patients who are bound to bed with a tracheostomy, big tube, who has multiple comorbidity. But in the same time, you cannot deny patients who appear clinically fit and healthy, though old, from getting a transplant. In fact, in all guidelines, transplanting elderly patient is not a contraindication. However, you have to screen those patients for cardiovascular disease, and you have to screen them for any hidden malignancy. Okay, what about patients who are at high risk of cardiovascular disease? Cardiovascular evaluation is very important in each transplant center. There is no definite guidelines in any transplant center regarding what exactly to do or what exactly to follow Each center has its own steps in evaluation and assessment of cardiovascular risk in a transplant candidate. But would you screen each transplant candidate who are going for a transplant surgery? This is a controversial and is controversial among the transplant centers. Definitely, there are some patients who has low risk, and there are some patients who have high risk disease. There are traditional risk factors which might present in patients with end-stage renal disease like any other. There are some traditional, you can hear me? There are some traditional risk factors which might present in patients with end-stage renal disease like any other patient in general population, like presence of diabetes mellitus, dyslipidemia, family history of coronary artery disease, particularly in the first degree relative, obese patient, and patient who are heavy smoker. However, dialysis patient, they have an additional risk factor in addition to those, like, for example, if the patient is male, if the age is above 50 years old, if they are having prolonged duration on dialysis, more than 2 years, if there is history of peripheral vascular disease or there is a history of ischemic cerebrovascular disease, if the patient has deceased donor, we found this group of patients, they have more additional risk to have cardiovascular events. All these can aggravate risk of cardiovascular disease. There are different scoring systems present in each transplant center, which is different in each transplant. Some of them, they depend on blood pressure. Some of them, they depend on hyperlipidemia, smoking. So indeed, the international guidelines, like European guidelines, American guidelines, and other guidelines, they like to stratify the risk for patients who are going for cardiovascular disease, who are going for renal transplant surgery, and accordingly to go. These are following screening measures. I'm not talking here about patients who are well known to have ischemic heart disease. I'm talking about the screening assessment for transplant candidate who doesn't have or not known to have an ischemic heart disease. The initial step, of course, you start with a 12-lead ECG, then you can do a stress echo, or you can do the stress scintigraphy. Just of note that exercise ECG in dialysis patient is very poor predictive value as a prognostic fact, as prognosis for patient with ischemic heart disease. So it is better to go for stress echo or stress scintigraphy. And accordingly, once it is positive, then probably you can post the patient for coronary angiography. This is a simple schematic diagram. As I said, that each transplant center has their own assessment for a transplant candidate. This is just a simple diagram that if patient is having low risk for a transplant, for cardiovascular events, then probably you can list them for transplant. If the patient are at a medium risk or high risk, if they are at the medium risk, like for example, this patient is diabetic, they have a longer duration on dialysis, more than 2 years, they are heavy smoker, they have other risk factor, then you do stress test or stress echo, and accordingly you decide. If it is negative, then you list the patient for a transplant, and you have to review their risk for cardiovascular disease on annual basis. While if the test is positive, then you schedule the patient for coronary angiography, and then accordingly, if it is abnormal, then probably you have to have the appropriate management. If it is normal, then he will get a transplant. If the patient is at a high risk of cardiovascular disease, or the patient is well known to have ischemic heart disease or severe decompensated heart failure, then probably you can defer those patients from having a transplant. To be done with the cardiologist to have a major surgery. Okay. What about heavy smoker? But might Can you hear me? Okay.
Yes, we hear you now.
Okay, sure.
Can you reshare again?
Are we
your screen?
justified to?
No, you share your screen again
Yes.
because it's color. I think you have.
Okay, sure. So are we
Yes,
justified, for example, thank you. Are we justified to avoid heavy smoker from getting renal transplant? What is the disadvantage of heavy smoker if they got a transplant? Cigarette smoking, as everyone knows, can adversely influence the kidney transplant. It can lead to increase in the cardiovascular disease. It can increase the risk of malignancy. But in addition to that, heavy smoker patient, they found to have an impairment in allograft function. And there are some small published studies that there are reduction in the cigarette smoking and patient anti-graft survival. Here, for example, in this published literature in 2000, the author had concluded that a heavy smoker, for those who smoke more than 25 cigarette packet per year, they have reduction in the graft survival compared to those who smoke less than 25 cigarette packet per year, and to those who never smoke. So it definitely, it is significantly reduced the graft survival. Similarly, it has also reduced the patient survival. Patients who are smoking less than 25 packets per year, they have a better survival than those who smoke more than 25 packets per year. So smoking, so the quantity of cigarette smoking is a poor prognostic factor. It can determine those patients who might lose their graft early. It is nearly they can lose 30%. 30% of patients of heavy smoker can lose their allograft earlier than others. In this diagram, which is published in 2017, smoking can have a harmful effect in both donor and recipient. We'll concentrate mainly about recipient. Recipient, as we mentioned, they have a high risk of cardiovascular disease, and they have reduced graft and patient survival. However, there is no correlation at all between the acute rejection episode and cigarette smoking. The correlation is like any other transplant patient, but they found that smoker, they have more chance to have bacterial and viral infections and even tuberculosis, and they have invasive cancer if they develop cancer. So smoking, whether tobacco and cigarette smoking, can reduce renal plasma flow. It can enhance the platelet aggregation. It can reduce the vasodilator endothelial nitric oxide, and it can increase the synthesis of endothelin-1, and it can increase the free radical production. And by all this, it can accelerate the atherosclerosis, and by time, it can lead to chronic allograft nephropathy. But as I mentioned, it has nothing to do with increased acute rejection episode. So with all these, increased hypertension, increased vasoconstriction, which can be permanently in the smoker, and other factor, this can increase intraglomerular hypertension. It can lead to vascular damage. And it can increase extracellular matrix deposition and fibrosis, which all might lead to glomerulosclerosis by time, tubular dysfunction, and patient can progress gradually to CKD. Other thing that cigarette smoking can increase proteinuria, and it can lead to vasoconstriction, which can be permanent in a smoker. In one of the analyses of allograft biopsies, the author found there are permanent histological changes in the allograft of heavy smoker patient. They found there is increase in the fibrous intimal thickening, which might lead to chronic allograft nephropathy in the future. Despite all this, as I mentioned, that there is no correlation between acute rejection episode. So you have to advise patients to stop smoking. If they stop smoking 5 years or even 2 years before the transplantation, the risk of getting a graft loss will reduce by 34% almost. You can advise patient you can encourage patient to have smoking cessation programs, which is offered almost in most primary center. You can advise them to have a healthy lifestyle, but definitely heavy smoker is not contraindication in any transplant guidelines from having a transplantation. And even if the smoker had stopped smoking before transplantation, there is a tendency to have a relapse after transplantation. Okay, what about pulmonary disease? What about patients who have a severe restrictive or obstructive pulmonary disease? Are we denying them from having transplant? In fact, when I was preparing this lecture, there is very limited data on a pre-transplant evaluation of patients with pulmonary disease. And any recommendation I found, it is exactly similar, like recommendation of general population who are going, like those patients who have a pulmonary disease and they are going for major surgery, not necessarily a transplant surgery. Definitely those patients who's having those who's having pulmonary disease, they are more prone to have pulmonary complications, and these can prolong their hospital stay, and this can influence morbidity and mortality. So those patients who are suspected to have pulmonary disease, for example, heavy smoker patient or any patient who have in the past pulmonary disease or still having like severe obstructive or restrictive pulmonary disease, the first evaluation you start by physical examination, taking detailed history, chest radiograph, and accordingly you can do CT scan or MRA as needed. What KDIGO clinical practice guidelines evaluation for those patients, similarly that you have to determine suitability of those patients. You have to have, as I mentioned, that you have to advise patients to stop smoking. They have to have chest radiography, and accordingly they have to have pulmonary function test. And accordingly, you decide with the pulmonologist about the suitability of those patients, if they can go for major surgery and they can have a transplant and they can bear all the complications of transplant and the immune suppressant later on. This is need a multidisciplinary team approach. There are some patients who have poor prognosis, and thereby you don't advise them to have a transplant, and in fact these are contraindication from having the transplant. These patients are like those who's having severe lung disease and they are requiring home oxygen therapy, those who's having uncontrolled asthma, those who's having severe core pulmonal, and they are having irreversible moderate to severe pulmonary hypertension, and those who's having severe chronic obstructive pulmonary disease like pulmonary fibrosis or restrictive disease. These patients, you advise them against having a transplant because already they have poor prognosis and their life expectancy are limited because of their original disease. Patients who have bronchiectasis with are mild to moderate, and those patients who had previous pulmonary tuberculosis, they have they should have detailed pulmonary assessment. Regarding their suitability for renal transplant, you have to determine this with the help of pulmonologist. So those patients whom tend to have a pulmonary disease, or you are probably worried that they might have pulmonary complications like smoker. If there is no risk, then they can proceed for transplant. If they have a risk, then probably you have to advise them. If there is some avoidable risk factor like smoking, if patient is obese, you can probably advise them to reduce their weight before going to transplantation. Otherwise, if the patient has severe lung disease, then you advise them against having transplantation. What about obesity? I hope I am in time. What about obese patient? Weight gain in dialysis patient is a marker of good nutritional status, opposite to poor weight gain in the dialysis patient. However, if the patient is having a body mass index above 35, this can limit their access to transplantation. It is well known that morbidly obese patients, they have an increased risk of delayed graft function, they have a prolonged hospitalization, they have more wound complication, and they have more episodes of acute rejection and decreased overall graft survival compared to other patients. In one of the analysis of US registry data, they found that obese patients, they have U-shaped association between the body mass index and death means. If the patient has very high body mass index or very low body mass index, this have been associated with high mortality rate. Similarly, there are G-shaped association between body mass index and allograft survival, means very high and very low body mass index is also associated with lower graft survival. In an old study between 1986 and 1988, they found that people with very high body mass index and very low compared to other people, they had longer operative time, they have prolonged hospitalization, they have higher rate of reintubation, and they have more frequent intensive care unit admission, and they have a greater incidence of wound complication. Similarly, in a recent data of 767 patients, they found the length of hospital stay are more in obese patients compared to other patients. This study were published recently in 2020 in a journal of transplantation. They found in 747 patients morbidly obese, BMI is greater than 30. They observed a higher mortality rate, a higher risk of bacterial infection, and the higher cardiac complication, and there is a higher death-censored graft survival on those patients, though there is no significant increased risk of early surgical complications among those patients. So if obese patients are listed for a transplant, you have to encourage them to lose weight through a healthy lifestyle, exercise and diet. And if the patient is above 40, you have to defer them till they lose weight, while if they have their BMI 30 to 40, then probably you have to study case by case. For example, if the patient has a live donor and they have poor vascular access and all this, probably you can encourage them to have a transplantation, while if the patient has no donor, maybe you should encourage them to lose weight. Those patients who are unable to reach target weight, you have a target weight through diet and through exercise, probably, and they have other comorbidity like diabetes, hypertension, sleep apnea. Probably you have to advise them to have bariatric surgery before going to transplant. Definitely, bariatric surgery is not without cost, without complication. But if you consider bariatric surgery compared to patient being on dialysis, definitely it is a good option rather than being a patient waiting for a long time. And definitely you have to screen obese patient for any underlying cardiovascular disease. And the other thing that you have to be careful for those obese patients after transplantation, because they tend to have rapid weight gain post-transplantation. So you have to encourage them to have a healthy lifestyle post-transplantation. What about history of claudication? Patient who has severe peripheral vascular disease, this might limit access to get a transplant. Everyone knows that a patient has a severe peripheral vascular disease. This can aggravate distal leg ischemia and can lead to vascular steer syndrome. Furthermore, it can be surgically technically difficult to have a transplant surgery. So how to assess those patients who's having a history of claudication? You have to assess peripheral pulses very well. You have to refer those patients to a vascular surgeon, and accordingly, if they have weak pulsation, then they should have CT scan, angiography, or MRA, and they might have angioplasty before getting any transplant. However, though peripheral vascular disease is accompanied with allograft ischemia, you have to treat this before getting a transplant. But even though it is not an absolute contraindication to the transplant. What about patients who are at increased risk of disease recurrence? Dr. Abdurrahman will speak in detail about recurrent glomerulonephritis after transplantation, but I just like to highlight a few things here. Recurrent disease is not only a renal transplantation, recurrent GN. Recurrent disease can be a primary GN, it can be a secondary GN like SLE, HUS, and other disease. It can be a recurrent metabolic disease like diabetic nephropathy, amyloidosis, and other. So if patient has a recurrent disease in the first allograft, then they will have a much higher recurrence rate in the second allograft. And indeed, some international guidelines, they discourage patients who had a failure of first kidney transplant from having second transplant. However, you have to counsel the patient very well, okay, regarding having a second transplant. The patient and his recipient as well. And if they are still insisting to have a transplant, then probably you should investigate him thoroughly in the second transplant for any recurrence. I don't know, is the time, I am in time, Dr. Amna, or we are running short of time?
Time out, Dr. Fakhriya, unfortunately.
Okay. What about patients who are having thromboembolic disease and they are on lifelong anticoagulation? Are they fit to have a renal transplantation? Patients who have a thromboembolic disease, they can have a hereditary or acquired hypercoagulable status, which can limit their graft survival after transplantation, and they can be at risk of higher morbidity and mortality post-transplantation. There are a number of thromboembolic disease which are genetically in those patients, like protein C deficiency, patient with lupus, patient with antiphospholipid, and other disease who require long-term anticoagulation, lifelong anticoagulation, and they are on your dialysis list. In the other hand, there are some patients who are dialysis, but they don't have a hereditary factor, but still they are at higher risk of having thromboembolic disease. For example, if patient has earlier history of thrombosis previously, they are at higher risk of thrombosis post-transplantation, as well as diabetic patient with polycystic kidney disease, patient who are in peritoneal dialysis, patient who, if the donor or recipient are at very young, below 6 or below 5, or elderly population, they found those population are associated with higher risk of thrombosis post-transplantation. Similarly, if the donor is deceased donor, if there are perioperative or post-operative hemodynamic variability, if the ischemia time is prolonged, if there are any technical surgical problem, and they found that female donor, they have duplicate risk of thrombosis. As I mentioned, all these are just association with more thrombosis rate post-transplantation. Female donor were found in Australia, New Zealand registry to have a higher risk of thrombosis. They attributed that probably because female donor have a small vessel diameter, but in other publication they did not found any correlation between the female donor and the risk of thrombosis. So all these just an association. So definitely those patients who have tendency of thrombosis, whether it is a genetic or acquired, they have a higher tendency of having graft thrombosis, arterial thrombosis, or venous thrombosis. And arterial thrombosis, venous thrombosis, it is different in different literature. It is between 0.2 to 8% in different literature. Not only graft thrombosis, but they are prone to have VTE in the form of pulmonary embolism, deep venous thrombosis, and other site thrombosis. And definitely this can influence the post-operative morbidity and mortality in those patients. So you have to screen those patients very well. In one of the studies, the author had concluded that transplant patient, they have 7-fold higher risk of VTE if you compare them to the general population. And he found as well that who had a thrombosis post-transplantation, the mortality rate is much higher than those transplant patients who did not have a thrombosis. Like the mortality rate were 28.5% in those who get VTE compared to 11.2 in the transplant recipient who did not have any thrombosis. Similarly, the death censored graft loss was more in those patients. And also they have more frequency of acute rejection episode. So if the patient is not well known to have thrombosis, but for example, they have a familiar tendency or familiar disease, you have to screen them for a coagulation defect. I don't mean to screen all patients, but definitely those who are more prone to thrombosis. If the patient is well known to have thrombosis and they are well known to have hereditary deficiency or lupus patient or patient with antiphospholipid or any kind of hematological coagulation deficiency, definitely those patients are on high risk, and they are already on the long-term coagulation therapy even prior to the transplant surgery. But you have to screen other patients whom the detailed history, for example, they have familial history or they are prone to thrombosis, as I mentioned. So how to prepare surgery for those patients? The preparation of surgery is like any other patient who are on long-term anticoagulation, who are on long-term warfarin therapy, for example, and you are preparing them for a major surgery, regardless if it is a transplant surgery or any other surgery. You have to stop the warfarin a few days before the planned surgery. You have to have your desirable INR below 1.4. And you have to do bridging with heparin. And of course, you have to stop the heparin, whether unfractionated heparin or low-molecular heparin. If it is unfractionated heparin, you have to stop the heparin 4 to 5 hours before surgery, or maybe a few hours if it is subcutaneous injections. And probably you can resume the warfarin after 24 hours if the patient has no surgical complication or bleeding tendency. And you have to watch the INR very carefully. So just a few highlights regarding the warfarin therapy for those patients. Everyone knows that warfarin therapy, it has a high drug-to-drug interactions. Medication which known to reduce the liver enzyme cytochrome B450 can lead to inhibitory effect on the warfarin. It can reduce the level of warfarin, so you might require a higher warfarin therapy. You might need to increase the warfarin dose in those patients. These medication like cyclosporin, tacrolimus, sirolimus, azathioprine. With this medication, you require a careful INR monitoring. The vice versa is true. Also, patient in warfarin, you have to monitor the cyclosporin level, tacrolimus level very carefully to avoid overdose or underdosage on those patients. Okay, what about direct oral anticoagulant therapy, which is some patient newly, not newly, during this era, they are most of them on direct oral anticoagulation therapy. Frankly saying, sorry, seems I'm running short of time. I'll just finish this talk. Regarding direct oral anticoagulation therapy, there are limited data on kidney transplantation patients. And whatever publication I found, there are very limited number in those publications. Most of them are 50 to 60 or 65 kidney transplant patients who are in those medications. One of the publications, which is newly published in 2020, in 52 renal transplant patients, they use apixaban, and the reason for apixaban use was atrial fibrillation in those patients. So they found there is no change in the kidney function, there is no change in the rejection rate, and in that study there was no drop in hemoglobin and there was no bleeding tendency. Similarly, there was a poster in one of the American Transplant Congress. Also in 62 patients, they found there is more bleeding tendency on those patients, and they have to stop. They have to stop the therapy in 7 patients out of 62. So definitely there is a drug-to-drug interaction clinical trial, but it is not yet defined. And they thought that this drug-to-drug interaction is limited. There are some medication like cyclosporin, tacrolimus, and cyclosporin and tacrolimus. It might have a drug-to-drug interaction, but it is like category B for apixaban and rivaroxaban, which is commonly used among those medications. It is category B. There is no much well-known effect, but they found in those studies that the interaction with the drug, like for example, the level of the drug is minimum. There is no change in allograft function, but still you have to have pay attention to the bleeding tendency on those patients, as some medication might prolong the effect, might prolong the drug, the anticoagulation therapy in those patients. And also you have to pay attention to the medicine itself, to the cyclosporine tacrolimus medication. So the effect is still unpredictable. You have to pay attention for any bleeding tendency, as well as you have to pay attention for cyclosporine tacrolimus level in those patients. I will stop at this level because I think I'm running short of time. Thank you a lot.
Thank you, Dr. Fakhriya, for your excellent overview. We are running short of time, so we'll go for the next speaker, Dr. Abdulrahman Diaby. He's an adult transplant nephrologist in Riyadh in Saudi, and he's going to brief us about recurrent glomerulonephritis post-kidney transplantation. So I would like to welcome Dr. Abdulrahman, and we apologize for the delay in the program.
Okay. Assalamu alaikum, everyone. It's my pleasure to be with you all. Today, I'll talk about recurrent of glomerular disease post-kidney transplant. It's a very big topic, but I have only 30 minutes, so I will try to go to the main important part of it just to be on the time. It's not moving, so I'll talk about, or my objective is to talk about the risk of recurrence, clinical presentation and diagnosis, impact of the disease recurrence, and management of disease recurrence. As you know, that primary glomerulonephritis is continued to be one of the leading cause of end-stage renal disease. According to several data, the prevalence is ranging from around 10 to 17% based on the big registry data international. In our region, this is a study from Saudi Arabia was showing primary glomerular disease is around 30% of the kidney disease diagnosis in this local data. But we can see there hypertensive nephropathy is 36% and etiology of unknown or unknown etiology is 10%. I'm sure that there would be like good percentage of this is due to undiagnosed glomerulonephritis. So it is well known that glomerulonephritis may reoccur after kidney transplant, but the classification for recurrence could be recurrence due to primary glomerular disease, a systemic disease that involves the kidney, and metabolic disease, in addition to de novo disease, which is developed after kidney transplantation. Because of the time, I will try to stick to the primary glomerular disease with some of systemic disease. So the prevalence of recurrent glomerulonephritis based on a large registry, like Australian, New Zealand registry, Mayo Clinic and Toronto registry for glomerulonephritis, and British Columbia was showing various number of prevalence. It's ranging from 10% to 40% of recurrence of glomerular disease. And if we look for each disease in particular, we'll find primary oxalosis and complement-mediated disease is coming in the highest prevalence, which around more than 80%. Fsgs, for example, the risk of recurrence is around 30 to 50%. Why this disparity in the percentage of recurrence? Maybe because of variable follow-up time, absence of clear native diagnosis to start with before kidney transplantation, incomplete biopsy data, different diagnostic criteria, and different population characteristics, in addition to variable threshold for transplantation and inconsistent reporting, which making this big variable difference. So recurrence of the kidney disease is associated with high probability of death sensory graft loss and high overall graft loss as compared to non-recurrence of disease as shown in this figure. And recurrent of glomerulonephritis come as a third most common cause of allograft loss after chronic rejection and death with functioning allograft. So it's important factors in assessing the patient before transplant, educating him about the risk, and something to monitor post-kidney transplantation. I will start my talk with FSGS. FSGS, it's not the commonest recurring glomerulonephritis, but because of the higher disease prevalence, you may see it more and more. FSGS can be recurrence of primary disease and can be de novo. Recurrence usually occur early. It's maybe related to circulatory factors, while de novo usually late. Risk of recurrence is 30 to 50% in the fifth kidney transplant and reaching up to 100% in second kidney transplant. And if untreated, it is associated with high risk for graft failure, which reach more than 90%. Risk factor for recurrence, including early age at diagnosis with FSGS, rapid progression toward renal failure, biopsy of native kidneys showing mesangial proliferation, living donor in some data, and previous recurrence, of course, and non-African American race. So what's the pathophysiology of recurrence? As you know that the podocytes are the site of damage in FSGS. Podocyte is highly differentiated epithelial cell of renal glomeruli, consistent of cell body and photoprocess, which make the glomerular basement membrane. The actin-based cytoskeleton of the photoprocess is critically in maintaining the effectiveness of the glomerular filtration barrier. So the disruption of this podocyte cytoskeleton will lead to the attachment of that podocyte and effacement of the podocyte process, leading to proteinuria and, of course, the focal segmental glomerulosclerosis. Experimental and clinical data study have suggested circulating permeability factors play a major role in the podocyte injury and development of FSGS. What are the circulatory permeability factors, or what's the evidence that suggesting that circulatory factors? So there are many clinical evidence that was proposing this to start with. One is recurrence can occur within an hour of transplantation, indicating that there are somebody in the recipient serum that is attacking the kidney or precipitating in the kidney. Remission can be induced by plasmapheresis after removing these factors from the plasma. Newborn child from a mother with FSGS can have transient proteinuria. And in experimental study, a serum taken from a patient with FSGS given to rat can lead to albumin, can lead to proteinuria, as published in this paper. Also, in a case was published from University of Chicago when a lady donated to her brother, and the brother had recurrence of proteinuria more than 35 grams immediately post-transplantation, not improving with plasmapheresis. They are concerning of losing the kidney, and biopsy done at that time was showing only photoprocess effacement in electron microscopy. So they suggest, or they propose, to donate the kidney. Nephrectomy done, it's transplanted in another patient, proteinuria resolved in a few weeks, and repeated biopsy later on was showing resolving the pathological finding. So one of the most common circulating factors where the researcher invests their time to look for is SOPAR, which is soluble urokinase. It is circulating permeability factors found to increase in the plasma of people with FSGS. It's produced by neutrophils, monocyte, and perhaps by other cells, which we don't know, such as T cells. SOPAR enter the kidney glomerulus and bind to beta-3 integrin. Activation of that beta-3 integrin will lead to podocyte dysfunction, effacement, and end up with proteinuria and FSGS. Several study was showing that SOPAR is higher with FSGS patient as compared to other glomerular disease. It is higher in the patient with recurrent the patient with risk of recurrence as compared to non-recurrence. That's why they link the SUPAR to the to risk of recurrence and to the response to the therapy. Despite years of research, this is still putative circulatory factors and remain elusive because subsequent study was showing no difference in the level in different glomerular disease, and increased level of SUPAR also seen in some patient who has non-nephrotic disease. There was also inverse correlation between SUPAR level and the eGFR. For example, in this study on Japanese population with glomerular disease, showed that the SUPAR level was inversely correlated with the eGFR and did not appear to be a biomarker for Fsgs. Another study was suggesting that measuring SUPAR in individual patient is not clinically useful, and probably it is not a single, probably is like it's not working alone. There are multiple factors that contribute to the food process effacement and proteinuria. Another studies has been done for different factors, especially the cardiotropin-like cytokines factors, CT4, Txs, apolipoprotein 1p. So how the patient with recurrent FSGS will present? They usually present with early onset massive proteinuria, hypertension sometime, graft dysfunction also, usually within hours, 2 days of post-transplantation, but it can happen at any time within the first years. Kidney biopsy, especially if done early, may show nothing or minimal changes. Sorry for the voice. Minimal change in light microscopy, while electron microscopy may show food process effacement. So the presentation is different from de novo FSGS, which present later, mild proteinuria, and de novo sometimes also can be secondary, for example, to infection, collapsing due to parvo-P19 or HIV. How to manage recurrent FSGS? Of course, RAS blockade. There is a few studies in the past about high-dose IV acyclovir and the use of IV cyclosporine, and the use of IV cyclosporine was not due to their immunosuppressive effect. It's mainly due to antiproteinic effect because cyclosporine have stabilized the cytoskeleton of the podocyte and lead to reduction of proteinuria. Plasmapheresis, Retoximab, and P7-1 blockade. So plasmapheresis, it is the most commonly used treatment for recurrent FSGS. There are like different regimen was used, but most common is daily for 3 consecutive days, followed by every other day with like 9 to 10 sessions. Then after that, gradual reduction based on the patient response. 1.5 volume each time replaced with 5% albumin. It is associated with better outcome when it is started early and lead to partial and complete remission in 60 to 70% of the cases. As I said, there are different protocols. One of these are the intense and prolonged treatment. So in this study, intense and prolonged plasmapheresis has been evaluated in 10 adults with kidney transplant had recurrent FSGS. In addition, they give them high-dose steroid initially and IV cyclosporine for 2 weeks, then oral cyclosporine. So in this 10 patient, complete remission was obtained in 9 out of 10, which is 90%, which is compared to the previous study is 27%. At 3 months and 12 months, proteinuria was very low. It was 0.16 gram per day and 0.19 gram per day, respectively. Only one patient who remained in partial remission. And plasma plasmapheresis was stopped at 9 months on all this patient, except one patient who remained requiring the plasmapheresis for longer time. Usually it's difficult to estimate how long the patient will require and how often do you need the session. I remember I have a patient who was requiring the plasmapheresis every 2 weeks for a year. If we postponed it for 3 weeks, she will have a proteinuria or relapse again. There is no exact reason, but after a year, she become in partial remission and she's off plasmapheresis. So in a systematic review, looking for 77 case report and case series, and I just wanted to highlight it's all case series and case report. There is no good study. The result was 71% of the patient achieve full or partial remission of proteinuria after treatment. Responder found to be the one who started early the therapy, the patient who have lower level of proteinuria, and the one who have shorter time for Fsgs recurrence. Other option is Retoximab, which is a well-known anti-CD20 monoclonal antibody. It's given in the 2 doses, either 1 gram over 2 weeks apart, or 370 milligram per meter square weekly for 4 to 5 weeks. In most of the published case series, it was used along with plasmapheresis. And for example, in this study of 6 patients where they used Retoximab, there was 3 patients has complete remission, 2 has partial remission, and 1 patient was not responding and progressed quickly toward kidney failure. Abatacept, it is one of the medication that has been proposed and studied in recurrent Fsgs. It is a co-stimulatory inhibitor that targeting the P7 or CD80. It may stabilize the P1 integrin activation in the podocyte, especially for patients who stain P7 in their glomeruli. Although an initial report suggests benefit among patients with recurrent idiopathic Fsgs, other studies have not demonstrated any benefit. So we mentioned that one of the risks of recurrence is a living donor, but if we look to the evidence, this data from recurrent allograft disease registry found that there was similar rate of recurrence among adult recipient of living or disease donor, and another analysis from a United States organ sharing network with good number of patients showing also there is no difference between living donor and diseased donor. What about recurrence? First transplant and preparing patients for second transplant. So the risk is very high, it's more than 80%. Usually considered to delay retransplantation for at least 1 or 2 years. There is only case report or small case series suggesting that preemptive plasmapheresis may lower the risk of recurrent Fsgs among patients at higher risk. And there is also some small case series about using Retoximab to prevent Fsgs, which may just showing small promise, but need more and more study about these 2 factors. Next, I'll talk about membranous nephropathy. So the risk of recurrence of membranous nephropathy is 10 to 40%. Risk of recurrence, high level of proteinuria before transplantation are considered as risky. Is risky, and patient with high titer of anti-PILA2R antibody. Usually patients with present proteinuria and their kidney function mainly are reserved initially. Graft loss at 10 years is around 10 to 15%. De novo membranous nephropathy can be seen also with prevalence of 2 to 9%, but it's more indolent course than recurrent disease. It's present later for recurrence, usually in the first 2 to 3 years, while de novo more than 3 years later. Maybe non-nephrotic, and the effect on graft survival is unclear because there is only very little publication about it. And even the de novo usually related to chronic rejection or acute rejection. So DSA or C4D can be found in the pathology. Pathogenesis, about 70% of idiopathic membranous nephropathy is triggered by autoantibody against the podocyte. There are 2 major targets has been identified. One is M-type antiphospholipase A2 receptor, and the second one is thrombospondin type 1 domain containing 7A. In addition to circulatory factors, which is circulating anti-PILA2R antibody, which found to be correlated with the disease activity. In this study, for example, when they look for the anti-PILA2R in 26 patients, it was positive in 12 patients and negative in another 12 patients. The risk of recurrence in the positive group was 83%, and it was also positive recurrence in 58% of patients with the negative group, which giving the positive predicted value for the antibody for the disease recurrence is around 83%. Also, positive PILA2R staining is important. It has sensitivity of 83% and specificity of 92% based on several studies. So why anti-PILA2R antibody inconsistent with recurrence? Sometimes we'll have patients with positive antibody, but no recurrence, sometimes negative antibody, and recurrence can happen. Maybe because induction therapy and immunosuppressive medication are enough to induce remission. Maybe because the epitopes of PILA2R in the transplanted kidney differ from that of native kidney, and the existing antibody does not recognize it. Subclinical recurrence may be masked by ACE inhibitor or CNI, and when detected in the protocol biopsy, there may be only low level of antibody that is below the threshold. So how to manage? It's depend on the presentation and severity of disease. Mild disease is just ACE or ARB. Severe disease or moderate disease, which has hyperproteinuria and progression of renal impairment, the option is Retoximab has come as first, but cyclophosphamide, cyclosporine, tacrolimus has been just mentioned in a few case reports with no clear benefit. Retoximab, it's usually, there are as usual different doses can be used. It's more effective when used early. It can produce or can cause remission, complete or partial, in 80%. For example, in this case, series of 8 patients with recurrence of membranous nephropathy received Retoximab. By 12 months, 6 out of 8 patients have either complete or partial remission. And post-transplant biopsy was also showing at least partial resolution of histological changing after Retoximab. IgA nephropathy is my next topic, which is has the risk of recurrence of 20 to 40% in clinical presentation and 60% in histological. And usually we have really to differentiate between immunoglobulin A deposition and IgA nephropathy, because some patients you will just find the deposit without the clinical or pathological evidence of a disease. Presentation is as native kidney can be very heterogeneous, sometimes microscopic hematuria, proteinuria, increasing creatinine, or maybe all these factors. Usually present within between 2 to 3 years post-kidney transplantation and can lead to graft loss of 10% at 10 years, which is really seems not different from non-IgA recurrence. Possible risk factors, and it's possible because there is really no good evidence about it. It's including young patient at diagnosis, rapid progression toward renal failure, left-ingrated donor, good matching with the donor, and previous recurrence, in addition to high serum IgA level, steroid withdrawal, and some uncertain type of HLA allele in recipient. So historically, it was thought that recurrent IgA does not affect graft survival. However, in this study, for example, in this retrospective study of 190 patients of IgA compared to more than 300 patients of non-diabetic control, at 15 years, there was no difference in patient survival between the two groups. While death sensor graft survival was less, it was 62 as compared to 72 for the control. So IgA found to be associated with higher incidence of graft failure as compared to the control group. So IgA, based on this study, is emerging as independent predictor of worse graft outcome, especially if followed for longer duration, more than 10 years. Treatment is, again, ARB, immunosuppressive medication, although the optimal immunosuppressive therapy for recurrent IgA is not known. Of course, medication, the same one, the one used for native or recurrence in the native kidney, depend on the aggressiveness of the disease. Prednisolone, 1 milligram per kg, cyclophosphamide IV, although there is no study in recurrent, good study, and rituximab, which is also, there is no data about it. MBGN, so MBGN, usually, as you know, there are two types of MBGN, which is immune-mediated MBGN and C3 glomerulopathy. Immune-mediated MBGN characterized by both immunoglobulin and complement protein deposition, where the C3 glomerulopathy characterized by predominant or exclusive C3 deposition. C3 glomerulopathy, including two types based on the electron microscope, which is dense deposit disease and C3 glomerulonephritis. So patients with C3 glomerulopathy typically present with 1 to 2 years following transplantation, and the risk factors is including low complement level, high level of circulating autoantibody like C3 nephrotic factor, and factor H autoantibody, in addition to the other factors like living donor and rapidly progression toward kidney failure. It is a recurrence of MBGNs means bad outcomes. The 5-year allograft survival post-transplant is only 30%, and of course, MBGN can occur as de novo post-kidney transplant. But if we occur late, or you think about de novo, you need to work up for the secondary causes all the time, like infection, hepatitis B, C, HIV, bacterial or parasitic infection, in addition to autoimmune disease and malignancy. Treatment for the immune-mediated MBGN is look for the underlying cause and treat if possible. For otherwise, depend on the severity. For mild disease, ACE or ARB. For moderate disease, prednisolone, high dose. And for severe disease, there is option for plasmapheresis and IV cyclophosphamide. For recurrent C3 glomerulopathy, it's the same for mild disease. And for moderate to severe disease, then the option can be escalated to prednisolone, plasmapheresis daily or every other day, and in patient with serum factor deficiency, periodic FFP infusion can be chosen. Eculizumab, especially for autoantibody, and patient with complement gene variant is one of the option. And usually eculizumab given is the same dose that we use in the typical HUS, 900 milligram IV per week for 4 weeks, and after that 1200 every 2 weeks. The question, for how long? It is difficult to know. Lupus nephritis, just a few slides about it, or one slide about it. The risk of recurrence is female, young, African American. There is few data about living donor. Clinical presentation is proteinuria, hematuria. Usually the graft function is not affected. Mean time for recurrence is 3 years post-kidney transplantation. And just to remember, ANA and complement is not good marker to predict recurrence. The effect on the graft loss is only 2 to 7% higher with more aggressive lesion. So unlikely to affect the graft in general. ANCA vasculitis, the risk of relapse is also small, it's 9%, and most of the time, recurrent of ANCA vasculitis is extrarenal. It does not affect the graft unless very rare cases. Time for transplant is important. So usually we have to wait until the patient is in complete clinical remission for at least 6 months before transplantation. ANCA titer does not predict the recurrence. And graft loss is also 8% at 10 years. Treatment, almost the same of pre-transplantation. The option is the same, steroid, cyclophosphamide, rituximab. Anti-GPM, there is the risk of recurrence 50% if the antibody is detectable, and less than 5% if the transplant differs 6 months or more until the anti-GPM disappear. That's why it's very important, or the timing for transplantation is important on those cases. Treatment, there is no high quality study to guide the optimal therapy. And plasmapheresis remain one of the options for anti-GBM, in addition to cyclophosphamide and steroid in some cases. Usually anti-GBM will reoccur, the outcome is bad. Take-home message is recurrent glomerulonephritis is the third cause of graft loss. Do your best to identify the primary cause of the kidney failure before transplantation, because that will help you in educating the patient, predicting the risk, and sometimes taking measures to prevent it, and also for monitoring. Understanding the pathogenesis of recurrent glomerular disease is critical for its prevention and treatment. Glomerulonephritis should not be considered as a contraindication for a successful kidney transplantation. Thank you. That's all my presentation.
Thank you, Dr. Abdulrahman. Thank you for sticking with the time, and thanks for an excellent overview. I would like to invite our next speaker, Dr. Hassan Al-Eid, and Dr. Hassan Al-Eid, he is going to speak about acute and chronic rejection. He's a consultant transplant nephrologist, and he's a director of the fellowship. And he's going to speak about rejection. Thank you. Dr. Hassan.
Thank you very much, Dr. Amna. Assalamu alaikum and good morning. It's a great pleasure for me to be with you today. You know, what I will try to cover today is basically rejection and its impact on kidney transplant, the type of rejection, therapy for rejection, how can we prevent, and then provide you with a brief summary at the end. But before we start, you know, if we look at kidney disease and kidney transplant, this is patient with transplant, this is patient with dialysis. You can see by 5-10 years, we can prevent 75% of mortality of patient on dialysis by transplantation. And this is our own local data from King Faisal Specialist Hospital, and similar, plenty of similar data are available, you know, from international literature. So what is rejection? You know, rejection is acute deterioration in allograft function, which is associated with specific pathological changes in the graft, more of immunological changes. And classically, we divide them into 3 types: T-cell dominant rejection, or antibody-mediated dominant rejection, or a mixed rejection between T and B cell. So, you know, when we put the kidney in, you know, kidney does not stay silent. It say, you know, hello, I'm there, and that lead, you know, these tissue of the transplant with the donor antigen presenting cell, they go to the recipient T cell and lead to activation of the T cell. That's called direct recognition. Alternatively, you know, the recipient antigen presenting cell detect of some of the injured, you know, tissue of the kidney, presented to T cell, and that lead to T cell activation. T cell activation, we know it activates inflammatory situation. It also activates B cell, and B cell, naive B cell will, you know, proliferate and will lead to several, you know, things. It will lead to formation of a plasma cell, which is short-lived, or a memory and long-lived plasma cell that would form antibody. And unfortunately, these two, you know, whether the antibody here will come and attack our kidney, or the T cell will come and attack the kidney. And as we said, if it is T cell dominant, we call it T cell. If it's antibody dominant, we call it antibody. Most of the time, there is a mixed element, because we know that there is a crosstalk between T and B cell. So what is the incidence of rejection over time? We have seen significant drop of rejection. You can see over the last 40 years, in 1980, almost 55% of graft will reject. On current rejection rate is around 6%. This is our local data, and similarly, the SRTS data showed 6%. However, we have seen with the drop in rejection, not a similar magnitude or parallel magnitude of improvement in graft loss. So there is still a slight improvement, but not as good as the drop in rejection. So, you know, as a transplanter and a physician, what are our goals? Our goal is to improve patient survival. We want to improve the graft survival. We want to put the kidney that live as long as the patient is surviving, and at the same time, we want to prevent rejection. So how can we achieve that? How can we maximize the accommodation and minimize rejection of the graft? We have seen and heard this morning elegant talk. So we want to minimize the HLA mismatch, and that's particularly for class 2, DR and DQ. We want to prevent sensitization by avoiding unnecessary like blood transfusion. We want to avoid crossing donor-specific antibody. Any donor-specific antibody would have its impact on the kidney. Want to provide adequate immunosuppression, whether induction or maintenance, because we know over the last 20, 40 years, we have seen that a triple immunosuppressive with FK, mycophenolate, and prednisone provided the best immunosuppression. And all minimization approach, unfortunately, ended in increasing rejection, particularly antibody, and led to more graft loss. Want to improve adherence of our patient to the treatment, and we want to have good monitoring of our kidney function. This is just to illustrate that, as you can see here in the Kaplan-Meier survival, if you have in this red line, adherent patient with good DR and DQ match, you have excellent survival. If you have in this orange line, a non-adherent, and at the same time, mismatch in DQ or in DR, they have a clearly lower survival by almost 30%. So what is the current standard, of care? Current standard is we do HLA matching, mismatching assessment, PRA, DSA. We give induction for almost now 90% of patients. Triple immunosuppression, I think, is the standard. The current rejection rate is less than 10%, and graft survival first year is more than 96%. We do monitor the graft by creatinine and GFR, and any increase in creatinine, it have to have a clear reason. Otherwise, we need to go and biopsy the kidney. Similarly, any change in proteinuria, either because of rejection or GN recurrence, as heard early, will trigger biopsy. Similarly, we need to look for the donor-specific antibody, whether it is de novo or pre-existing, because of its impact. However, there are also new novel ways of monitoring the kidney, and these are very good data on donor-derived cell-free DNA and the gene transcript of mRNA. So if any of these show, a clear indication to biopsy, we go for biopsy. We know that biopsy is the gold standard. It does provide you with, diagnosis versus other diagnoses like BK virus or CMV. It also helps in prognosis because you see the degree of fibrosis in the kidney. And, it does also help you when there's no good response to treatment. However, it's invasive. There is risk of a bleeding. So when we classify or stratify our patient, I think we, stratify them into low risk and high risk. People with low risk who have no donor-specific antibody, and people with donor-specific antibody, especially if they have positive cross-match, they are very high risk of rejection. We can further, stratify that as this probability of rejection goes with the risk. So if you have no DSA, the risk is very low, is like less than 5%. If you have positive DSA but negative cross-match, the risk is higher. If you have weakly positive flow cytometry, it goes even higher. Highly positive flow cytometry higher. And if you have CDC, the risk is very high. It can go up to 30% risk of rejection. And this is what we have actually observed in our patient. The highly sensitized with DSA and positive cross-match, the risk of rejection is around 15 to 33%. ABO incompatible around 27%. Intermediate risk is 12%, and the low non-sensitized risk is less than 5%. So, we divide patient into low risk, high risk. If we have a low risk patient, any increase in creatinine by more than 20%, or if we stabilize at a high baseline, so we did the transplant and creatinine like reach 150 and did not drop further, or if you develop a new albuminuria, I think that all warrant biopsy. If we deal with a high risk, even a lower increase in creatinine, around like 10% to 15%, I would do biopsy. Similarly, high baseline, albuminuria, or rising DSA or donor-derived cell-free DNA, I think that should lead to biopsy. And biopsy can clarify if there's no rejection, we're happy. If there is a rejection, then we classify it and treat accordingly. If we look at the impact of rejection, we can see here, rejection clearly dropped the survival of the kidney transplant. And particularly for the antibody-mediated rejection, as you can see here in the red line and here in the blue line. And T-cell also have an impact, but is slightly lower than the antibody-mediated rejection. In form of impact of rejection with time, if you have no rejection, graft survival is good. If you have rejection, whether early or late, it is bad, but late rejection, is worse than early rejection. Early on time of a transplant, within, the first like 3-6 months, you would have borderline and T-cell rejection, but subsequently, after the first year, the predominant form of rejection is antibody-mediated rejection. So how can we classify rejection and get into a standardized rejection form? So we met and nephrologist, pathologist met in Banff, and they developed Banff classification. And you see this is small boat. This is probably our chairperson, Dr. Amna, or other chair people sitting there enjoying their time, and develop the Banff classification for rejection. And with that, we divide it as a T-cell rejection, and it's basically lymphocyte infiltration of tubules, interstitium, and arterial wall. We can grade it based on the severity and site of infiltrate. So if we have low degree of infiltration, less than 4 cells per tubule, it's called borderline. If that is 4 to 10, we call it Banff 1A. If it is more than 10, we call it Banff 1B rejection. If it crosses the tubules and goes to the arterial system, arteriole, if it is mild, we call it Banff 2. And if it is crossing the whole wall of the arteriole, we call it a transmural, and it's Banff 3. We can show that in the illustration here. So, this is the tubule of the kidney for the, those who are not familiar with the kidney pathology. This is the glomerulus, and this is the interstitial space. And here, this is a small peritubular capillary between the tubule. We call it peritubular capillaries. We can see here in this tubules that was, here clean, there is no lymphocyte. And this tubule, you can see clearly here, this lymphocyte surrounded by a hollow. That's a lymphocyte infiltrating the tubule. Here, there was 1, 2, 3, 4, and probably 5. So we call this Banff 1A cellular rejection. The way we should treat it, I think, is pulse-steroid, methylprednisolone. In addition to augmentation of immunosuppression, response rate is more than 90%. Here you can see that the degree of infiltrate is higher. So there is more than 10 lymphocytes. You can see these dark blue with a halo around it. These are lymphocytes, and this would be BAMF1B. And I would give methyl prednisolone pulse, augment immunosuppression, and if there is no response, because response rate is probably here around 70 to 80%, I would go further to ATG. So the arteriolar, you can see here, this is small artery, and you can see here this dark blue is the lymphocyte, and affecting less than 25% of the arteriolar wall, and this is BAMF2A. You can see this side here, it's causing these lymphocytes more than 25% of the endothelium, and this is BAMF2B. Treatment for BAMF2 is you give pulse steroid, and directly you go also to thymoglobulin. In addition, you augment immunosuppression. If that inflammation crosses the whole wall of the artery and there's no blood flow, we call it transmural, and this is BAMF3, and it have to be treated with pulse steroid, thymoglobulin, and augmentation of immunosuppression. Unfortunately, response rate here is lower. So this is just to summarize what I have said. First, if we biopsy, we detected T-cell mediated rejection, we need to rule out mixed rejection. If it's a pure T-cell, we classify it into lower grade BAMF1 and BAMF2, treat with methylbred. BAMF2 and 3, we have to start thymo directly. And after treatment, we need to assess that creatinine is responding or getting back to baseline within 10% of baseline. If that is achieved, yay, we're successful. If not, we failed the therapy, and we need to look for other reason. Is this non-responding? We need a higher therapy, or the kidney is fibrosed, or there may be something else like viral infection, etc. Impact on survival, and not all cellular rejection affect graft survival, but severity of rejection moving from BAMF1A to B, 2, and 3. Severity of rejection worsen graft survival. Late onset rejection also worsen graft survival. Plasma-rich infiltrate, or those who do not recover within 10% from baseline, they affect the graft survival. We can go to antibody-mediated rejection. We need to have criteria for antibody-mediated rejection. And first, the criteria, obviously, you need to have antibody there, which is donor-specific. This could be either pre-existing antibody or developing new development after transplant. We call it de novo. And we look for that with single antigen testing. In addition, we need to prove that that antibody is coming and interacting with the vascular endothelium. And we have several ways of detecting that, either by staining for complement 4D fragment, which is basically a footprint of antibody coming and interacting with the endothelium. In addition, now there are more gene transcript that also show the same finding, either in that transcript or NK cell transcript that is very well associated with antibody. Third criteria is histological evidence of tissue injury. And if that is acute, like ATN or TMA changes or inflammation of peritubular capillaritis, we call it active or acute antibody-mediated rejection. If it is a chronic, it's multiple damage from before, leading to condition called transplant glomerulopathy, or a multi-layering of peritubular capillary. We call it a chronic. Chronic active antibody-mediated rejection, and I'll show you a picture of each one of these. So this is the peritubular capillary. You can see this is a capillary, this is capillary, this is this is tubule, and this is tubule, and this is peritubular capillary. You can see it dilated and inflammatory cell there. this is peritubular capillaritis. Here you can see the same here, peritubular capillary with inflammatory cell in between. And here also in the glomerulus, you can see the capillary loop is filled with inflammatory cell. We call it glomerulitis or peritubular capillaritis. Important finding, vascular or, endotheliitis, as we said in BAMF2 and 3, cellular, could be also a feature of antibody-mediated rejection. This is the transplant glomerulopathy, and if you look at the glomerular capillary loop, you see it here thickened, and it is formed of 2 layers. We call it a tram track or double contour, and that happened in transplant glomerulopathy and in membranoproliferative glomerulonephritis. This is C4D deposition, and it's done by different staining. This is immunohistochemistry, the brown segment, attaching into the peritubular capillary, and this is by immunofluorescence, which is more sensitive than immunohistochemistry. If this is electron microscopy, and if you look at the capillary wall here, you can see it multiple layers. So this is 1, 2, 3, 4, 5. We call this multi-layering of peritubular capillary basement membrane. So if we see that a criteria and then look into a graft survival, as we can see here clearly, antibody-mediated rejection has very bad impact on a graft survival, and they should be prevented, from happening. How do we treat it? If it is, active, acute within first year, we give pulse steroid, we do plasma exchange, IVIG, we use Retoximab, some other don't use it, and we augment immunosuppression. We then need to see a decrease in creatinine to within 20 to 30% from baseline within 7 days. If it is beyond 1 year, this is chronic, unfortunately active, the response rate is lower. We do pulse steroid, IVIG, Retoximab, augmentation of immunosuppression. There are no data for plasma exchange in comparison to early ABMR. Retoximab, there's one underpowered study that showed Retoximab is not effective, but I think most of the transplant centers still give Retoximab because of its potential effect on beta cell. Ultimately, if we succeed, we say yes, we succeeded. If not, then we rebiopsy and look whether this is, a potential salvageable kidney or no. If it is salvageable, we can use second-line agent like Ocrelizumab or Tocilizumab. If not, we just stop there and do not, increase the potential risk. So rejection could be subclinical, meaning that it's not affecting the creatinine and kidney function, or clinical, could be antibody or cellular. If it is subclinical rejection, then you can treat. Antibody, as we said, plasmapheresis, IVIG, Retoximab, plus minus Ocrelizumab. Cellular, we treat with pulse steroid and thymoglobulin. If you word on novel monitoring and transplantation of sensitized patient and pair kidney donation program. So, kidney solid organ, rejection assay or K-sort is basically a microarray that can predict rejection. It is a PCR that quantify mRNA, and now I think most of us, know the mRNA with the COVID vaccinating and etc. So it's a PCR that measure mRNA of 17 gene, and that was, associated clearly with rejection and leukocyte trafficking, or leukocyte coming to the kidney and transplant. It's been studied in several studies, but the largest is the ART study, included around 400 patients, and it showed clearly that the K-sort, or this gene transcript, has a sensitivity of 92% and specificity of 93%. This is like better than most of our tests. If we look at creatinine, for example, sensitivity and specificity to rejection is less than 40% of both of them. It can also predict rejection, not at the time of rejection, but before it happened by around the 3 months in more than 60% of patients, and give you chance to augment immunosuppression and prevent rejection development. You can see here in the red versus green column, rejector versus no rejection, big separation in the K-sort, and the area under the curve is around 94%, which is an excellent. This is the rejection time here at, and even before rejection happening by 3 months, you can see that the K-sort transcript is going up. If you treat rejection, it goes down. So it correlates very well, like timing before and after rejection. So exactly similar to K-sort, T-Rex assay, which is again another gene transcript of mRNA, and it's been clearly shown now that it correlates with rejection, whether subclinical or clinical. It has a very good, positive and negative predictive value, and more important, it does correlate with graft loss, not only with rejection, but also with graft loss. Donor-derived cell-free DNA, we know that when the cell die or get injured, it releases its DNA content. And during rejection or graft injury, large amount of donor-derived DNA is released. We can measure that by PCR, and that was a study and is associated with antibody-mediated rejection and cellular rejection. You can see here if the donor-derived DNA is more than 1%, it correlates with antibody-mediated rejection and T-cell rejection, and not with condition like ATN or delayed graft function. See the correlation with donor-derived rejection, donor-derived DNA. So this is high, and it's high in rejection. It's low in non-rejector, and that was much better than the performance of creatinine. You can see it here with antibody-mediated rejection high, cellular rejection is lower, and no rejection at all is even lower. I can skip that and for interest of time. Last word on transplantation of sensitized patient. Our aim is not only to prevent rejection. Our aim is to provide the patient with best survival. And even if there is a high risk of rejection that would lead to better survival of a patient, we should do. This is clear data showing that transplanting patient who are sensitized with desensitization does provide patient with better survival compared to remaining on dialysis. So even if the risk of rejection is there, we better transplant them with desensitization. But better than this, we, instead of just desensitization, now we can enroll them in pair exchange. So if we have incompatible live donor, if there is other donor, we get them and proceed with transplant. If there is no other donor, they are easy to exchange, we proceed with pair exchange. If they are easy to desensitize, we proceed with desensitized. If they are not easy to desensitize and not easy to exchange, what we do, we get them into integrated program of desensitization and pair kidney exchange. And this is just a picture of illustrating the exchange. This is one of the exchange we did in our hospital. So ladies and gentlemen, thank you very much for, pairing with me and attending this talk. Rejection is a leading cause of graft failure, particularly antibody-mediated rejection. Overall incidence is around 8%, but vary based on patient risk, whether low or high risk. Current monitoring depend on creatinine, proteinuria, DSA, and biopsy. Unfortunately, all of them have their own shortcoming. Timely diagnosis of treatment of rejection is vital, particularly antibody-mediated rejection. Several innovative methods are, there, and particularly the donor-derived cell-free DNA, and the mRNA quantitative method like K-sort or T-Rex. With that, I want to thank you all, and we can listen to a question at a later time. Thank you.
Thank you, Dr. Hassan, for an excellent overview. As you mentioned, we are running short of time, so we'll just go for the next speaker. And please, attendee, write your questions in the question box so we can read them later and answer them along with the speakers. So our next speaker is Dr. Andrea Rizzaliti. He's our transplant surgeon, and he's the professor of surgery in Italy. Please, Dr. Andrea, you can start your presentation.
Thank you so much. Do you see my slides?
Yes, we do.
Okay, thank you so much. So, good morning, everybody. And first of all, I would like to thank the president of this very interesting meeting, Dr. Amna, who invited myself to talk about the bad things in surgery after kidney transplantation. You know how much surgeons are reluctant in talking about mistakes or failures, but in this case, I will try to turn, these bad things into teachings, just to help, in reducing the adverse event, if possible. So generally talking, excuse me. Does it go back? Generally talking, in the background, we could say that the kidney transplantation are more frequent if an expanded criteria pool donor is accepted in your program, and from the recipient side, as you can see in this paper that has been published by our group, the impact of surgical complication increase with the age of the patient, and in this other publication we can say that the comorbidities correlate clearly with the high incidence of surgical complication after kidney transplant. Kidney complication, from my side, can be divided in two main groups: the vascular complication, urologic complication, and extraintestinal complication. Vascular complication are the main cause of graft loss during the early post-op period in kidney transplantation, and the incidence varies from 1 to 23% with significant, with a big delta. That means that the various transplantation centers doesn't have the same experience. Okay, vascular complication can be grossly distinguished in bleeding, fungal arteritis, artery thrombosis, vein thrombosis, artery stenosis, pseudoaneurysm, and rupture, early rupture of the kidney. I will just say that about the early rupture, few words now. Early rupture is usually secondary to vein thrombosis, or after transplanting a young kidney, a teenager kidney, into an adult recipient. And this is related to the different blood pressure regimen. Okay, going to the vascular complication. Without any doubt, they are more frequent if there are vascular normality in the graft, as you see in this picture with multiple arteries. Or if we are going to transplant an ectopic kidney like this one, where this anatomy that we have studied is totally different. Or even from the venous point of view, if the venous renal vein is too long, maybe it could twist that cause a early thrombosis. Or if the renal vein is too short, like in this case, and a graft is required to make it longer, especially if we have planned to do transplantation in the left iliac fossa, this is a major point for vein thrombosis. Or talking about liver-related kidney transplantation, where we have to deal with very short vessel anyway, a particular skill and experience is without any doubt required from the surgical point, point of view. So I mean, let's go for the first one, bleeding. The source of bleeding could be the graft, retroperitoneal fat, the major vessels, and the hematoma that will develop can compress the graft, like you see in this picture, causing graft dysfunction, vascular thrombosis, and obviously hemodynamic instability if the bleeding is massive. A particular case of bleeding that represent a real dramatic complication is represented by the fungal arteritis, which usually present themselves as a hypovolemic shock due to artery rupture or an anastomotic leak. As in our experience that we have published in this paper on transplantation, you know that the main problem that we found is not to ask why it happened, and after that, just teaching the perforation without or the anastomotic side. We know that after that, the bleeding will recur dramatically because new rupture will come. So I mean, unfortunately, the first thing to do in this case, as a first instance, is to do transplantectomy, arterial iliac axis removal, and femoral crossover immediately. Okay, now. Okay, artery thrombosis is the second chapter in vascular complication, and it represents, as I said at the beginning, the most common cause of graft loss during the early postoperative period, 30% in the first month, up to 47% after 3 months. The artery thrombosis is mainly due to a technical error or transplanting an advanced donor age graft. And as a clinical point of view, we can see that urine output will stop immediately after vein thrombosis. How to confirm the diagnosis? The diagnosis can be easily confirmed by Doppler ultrasound, and after that by angiography, as you see. The treatment is quite difficult because revascularization at times should be tried just if the ischemia time is not longer than 5 hours, so that transplant nephrectomy is the consequent surgical procedure, is the more frequent surgical procedure. Renal vein thrombosis occurs with an incidence of 0.1, 8.2, 8.2%, and usually, local pain in the iliac fossa, hematuria, oliguria are the common findings. Same thing that we observed in artery thrombosis. Technical error or anatomical or a difficult anatomy of the graft are the main causes after renal vein thrombosis developing. So I mean, the causes could be also the compression, as in bleeding, compressing the graft, or a big lymphocyl, or a progression of deep venous thrombosis. Diagnosis, as we saw in the artery chapter, diagnosis can be done by US very easily, and then angiography, but treatment is very hard. Unfortunately, revascularization attempt doesn't help too much, and the transplant nephrectomy often will follow. Pseudoaneurysm, if the pseudoaneurysm are intrarenal secondary to a kidney biopsy, they must likely spontaneous repair without any other therapeutical attempt. But much different is the case if the pseudoaneurysm is extrarenal, usually anastomotic, secondary to technical surgical error or to fungal infection, and unfortunately, also if the stenting procedure with by PTA could be done. Unfortunately, transplant nephrectomy is mostly observed in these cases. Then with the renal artery stenosis, we pass into the late vascular complication, and is most common seen if the graft comes from an expanded criteria donor pool, and intimal hyperplasia is commonly encountered in this lesion. Which is the treatment of the artery stenosis? Okay, we know very well that angiography and PTA are the gold standard techniques in this case, but nevertheless, Doppler ultrasound has a well-defined role, especially in the screening phase. As reported in this paper by our group, we say that angiography and even CT scan tridimensional reconstruction were not able to diagnose this stenosis, but that lesion was visible by means of contrast and acid Doppler ultrasound. I'll tell you the truth, this was a very tough case because before transplantation, this patient was operated on by a bypass, iliac bypass, for a very important process of atherosclerosis. Then, as I told, the gold standard is represented by PTA, transcutaneous PTA, with stenting of the stenosis, like you see in this angiography here. This is the stenosis, and then is the palmate in situ here, and or ballooning and then stenting for multiple arteries, stenosis, excuse me, like in this case. And then we pass very quickly to the vessel, lymphatic vessel problem. So I mean the lymphocyte. The lymphocyte is a lymphatic collection that requires at least 50 ml per day, flux a day. And we recommend a very accurate skeletonization of the, graft, preparing the graft, the hilum of the graft and the vessel of the recipients, in order to avoid the lymphatic spilling. Also here you can see the prevalence is the delta of the prevalence is very wide, from 0.6 to 51%, and the peak incidence is mostly observed after the first week after transplantation. Here we have a venogram, a venography showing how can be the compression of the lymphocyte on the venous, on the renal venous, on the renal vein, and how can be measured by measuring the different pressure up and down. So, which is the treatment according to the Heidelberg guidelines for a symptomatic lymphocyte? The first line therapy is represented by external drainage, the second line therapy by sclerotherapy, and the third line therapy by fenestration, open or better by laparoscopy. But please do not forget that even sclerotherapy could cause dangerous complications, as reported in this paper from our group too, graft loss due to percutaneous sclerotherapy of a lymphocyte using acetic acid after renal transplantation. So be aware, be careful in doing this procedure. So this is why since the early 2000s, we have treated the lymphocyte by laparoscopic, meaning doing an endoscopic fenestration of the lymphocyte, as we reported in surgical endoscopy in this paper. Let me spend just a couple of minutes to show you how the procedures can be done. It's very short video clip. This is a laparoscopic view, liver, and then you'll see the mass. Here is the mass where the graft has been implanted and the lymphocyte. So we have to be sure what is the exact place to be fenestrated, not to injure the vessels of the graft. So an endoscopic ultrasound should be done to localize the vessels and the adequate place where to open the lymphocyte. You see in this moment, you see, the endoscopic intra-op, the endoscopy. Okay, after that, I'll try to make it quicker. Okay, we start to opening, we opening the lymphocyte. That is the fluid inside, the lymphatic fluid inside the lymphocyte. Suction is done. Okay, this is the suction. And then the probe is introduced inside the lymphocyte, just to visualize, to be sure that there are no other cavities inside. This is the remnant fluid, the remnant lymphatic fluid. No septum at all inside the lymphocyte. So this is the end of the procedure. Okay. So we pass rapidly to the urological complication. The first one that has to be mentioned is the urine leakage, as you see here in this case. Urine leakage due mainly to the ischemia of the ureter, a small ischemia, or technical errors is in performing the ureteral bladder anastomosis. Okay, the first therapeutical attempt that we have to do is the further management is the maximal decompression of the kidney. So Foley catheter, percutaneous nephrostomy, ureteral stent in situ, and drainage of the urinoma. In the 80% of the cases, this should be enough for, to recover the patient. But in the 50% of the cases, we have to go to surgery and trying to fix it. Ureteral obstruction, two types of ureteral obstruction, the early one and the late after 3 months. The early ureteral obstruction is due to narrow anastomosis, edema of the anastomosis, kinking, and maybe compression by lymphocyl or hematoma, as I told you before. The late ureteral obstruction is due to ischemia of the ureter, or anastomotic or ureteral scar as a consequence of a leak, or BK virus infection. This is another case of a corkscrew ureter, a too long ureter that is twisted many times on its axis. And here, a middle ureteral stenosis that has been treated by transcutaneous ballooning and stenting. Transcutaneous pialostomy approach is also used for distal stenosis to a ureter on the anastomosis with the bladder. And this is a urological, algorithm. This is very easy, algological algorithm. Talking about ureteral stricture, after ballooning, if failures occur, or the open repair is required. Urine leak, massive urine leak, open repair immediately. If the urine leak is small, you can try the decompression, the maximal decompression of the kidney. If failures occur, open repair required. But when fantasy is needed to face difficult situation, as in this case that we have published on urology, the appendicular replacement of the ureter has been used to repair an extended post-necrotic lesion of the ureter. So the surgeon has to be prompt to adopt many techniques during after kidney transplantation, and his skills has to cover a wide variety of possible postoperative events. With that, we have to pass to extra-renal complication. Extra-renal is the most important and dramatic one is represented by acute necrosizing pancreatitis that has a mortality up to 100%, is a fatal complication. And as you see in this paper published on the American Journal of Gastroenterology by me, by our group, the cause are represented by hypercalcemia. So hypercalcemia should be treated before transplantation with hyperparathyroidectomy, and or other causes can be represented by immunosuppressive agent that can do pancreatitis, biliary stones or biliary sludge that has to be fixed before transplantation. Also, cytomegalovirus infection is implicated in acute pancreatitis. As you see in this case, the rupture of the main pancreatic duct has been demonstrated by ERCP, and the pancreatic duct was stented, but then the patient died. So this is, I would like to underline the acute pancreatitis is a fatal. In this case, we see another case of pancreatitis with extra pancreatic collection here that has been successfully drained percutaneously. And the last one, and with that I finish. I think I've saved time. The last complication is represented by intestinal perforation. Intestinal perforation is not so common, but is another fatal complication with 66% of mortality, and can be done by cytomegalovirus infection on the small intestine or MMF drug. MMF, therapy is often, associated with the small perforation of the small bowel, and non-occlusive arterial ischemic disease is often seen in the pathology report. So, be aware that, a abdomen that doesn't look well could be secondary to a local or four-quadrant peritonitis that in this patient cannot be misjudged, because intervention, the surgical procedure has to be done immediately without waiting and wasting time. So, with that, I'm finished. Thank you for your attention. I'm here for eventual questions.
Thank you, Professor. Thank you, Professor Andrea. We'll keep the questions for later, and we will start now with our last speaker for this session. And we are going to have a break, or prayer and lunch break, from 12 to 1 o'clock. And we are going to start at 1, little early, with the next speaker. So our last speaker for this session is Professor Abdelbasit Al-Isawi. He's a professor of medicine and nephrology at Al-Azhar University in Egypt. And he's an associate dean at Ras Al Khaimah University and Faqih University Hospital in UAE, and visiting professor in medicine in Harvard. Please start, Dr. Abdelbasit. You can share your slides.
Can you see me?
Yes, but not your slides.
I'm trying to share the screen. Can you see it now?
Yes.
Yes.
Okay. Thank you, Dr. Amna Al-Hadari and Dr. Fakhri Al-Alawi, for inviting me for this important update. And actually, my task is non-infectious complication of renal transplant, which follow the surgical complication mentioned just before me. And actually, this task it needs like more than an hour in order to elaborate on it. However, I was given 25 minutes. And this is why I highlighted the most important topic I can speak about, if the time even allow me. This is a whole thing about the post-transplant non-infectious complication. And this group I will try to highlight because we cannot elaborate much on it. So I will start by the epidemiological data, because this is the basis on which we will look for the non-infectious complication. And you can see clearly from this slide, overall, the transplant outcome have improved over time, over the last decade, in all age category, either above 50 or between 18 and 49. And this go back to better screening before transplant preparation and better management post-transplant with the most recent technique and the medications. To go over all about this important study over extrapolated from around 60,000 transplant patients in the United States about the cause of death and transplant in general, and you can find in your right hand, cardiovascular disease is the most important cause of death, post-transplant as well as pre-transplant for end-stage renal disease. and pre-transplant is around 50%. So I hope I will have time at the end to elaborate more about the cardiovascular relationship and treatment of post-transplant metabolic syndrome as a non-infectious complication. And this is followed by infection and malignancy. So as I just mentioned before, the overall graft outcome has been improved over the last 2 decades due to better preparation, better screening, better medication, and better follow-up. You can see out from this nice study, which is quite recent, like a decade ago, which is to tell you that the cardiovascular outcome, this due to cardiovascular cause, has been decreased substantially between the SEER era of transplant in 1980 to 1990. After that, it has been decreased. Cardiovascular deaths and post-transplant have been decreased in all age group smoothly in the last decade compared to the previous one. And this, as I explained before, better medication, better management, better screening, and everything. So the cardiovascular death, who is still #1 as a cardiovascular cause of mortality or post-transplant, is still #1 despite the substantial decrease in the last 2 decades in the incidence of cardiovascular death. If we correlate the cardiovascular death to serum creatinine, this is inverted curve, which tells you cardiovascular death-free survival. The cardiovascular death-free survival is better when the kidney function is better. So the worse the kidney function, the worse, the higher the prevalence, the higher the incidence of cardiovascular death, and the lower the cardiovascular death-free survival. So doubling of the serum creatinine simply can double the cardiovascular death in post-transplant. So we'll go to the next slide. This is a very important topic. I think it is the most important topic nowadays in post-transplant follow-up, which is subclinical immunological activation. Again, I was lucky that Dr. Hassan Al-Eid, the previous speaker, have highlighted a little bit more in this immunological, subclinical immunological activation in post-transplant, which will help me a little bit to get faster on this. So how do we monitor the kidney after transplant? We usually look for creatinine, and all of us know the creatinine is not a good marker for transplant. Serum creatinine started to increase when there is a loss of more than 50% of kidney function. The best example of this, when you receive a recipient with 1,000 creatinine and a donor with 100 or 90 creatinine, both of them after a week go out to home with a 90 serum creatinine with 1 kidney. It tells you that the body can lose 50% of function without rising serum creatinine. So we really need a more sensitive marker for monitoring post-transplant. The second thing is proteinuria, and there are several ways to measure it. And then to monitor the function, the biopsy, and this is have a special indication. And we come to the immunological assay, which was highlighted and elaborated better by Dr. Hassan Al-Eid in the previous speaker. I tell you about the immunological status. We have a status. We have to check HLA and non-HLA antibodies and development or worsening of donor-specific antibodies. So assay for identification of anti-HLA antibody, one of the most important advances in the past decade. And luckily we have this day Luminex. So it is, if it is specific for donor HLA, we call it donor-specific antibodies. So donor-specific antibody can exist pre-transplant or develop de novo, as it was highlighted by the previous speaker. And this cartoon shows you very beautifully the course of development of donor-specific antibody. So this donor-specific antibody, de novo, if it starts post-transplant, it has one of 2 possibilities: either rapid rising, high titer, and the risk factor has explained by Dr. Hassan. And this can cause acute clinical antibody-mediated rejection. And it is usually associated with endothelial injury, pre-tuberous capillaritis, and glomerulitis. And it also is associated with C4D staining, and also endothelial associated transcript, RNA transcript. So if it is rapid rising, you will have acute rejection. and you antibody-mediated rejection, and you will have a staining of C4D. And if you do gene chip array, you will feel endothelial transcript rising. And if the rising of the donor-specific antibody is low titer, is not enough to cause acute antibody-mediated rejection, then we will jump to the next step, which is chronic antibody-mediated rejection, tubular atrophy and interstitial fibrosis, graft arteriosclerosis, and transplant glomerulonephritis. And eventually, this could happen as a residual of acute rising of donor-specific antibody. So the question will come, how often do the de novo DSA develop? This nice study, which it shows after exclusion of around 200 patients and 500 renal transplant patients with very low HLA risk mismatch before transplant, it's because they are low risk and they are well matched. We have 9% also who received thymo, 23% also only received Basiliximab, and they were in triple immunosuppressor, and they were low risk. And this is, you can see over 10 years, the percentage of developing of de novo donor-specific antibody, 27%, even if they are low risk with good triple immunosuppression. So who gets de novo donor-specific and when? You know, also it was elaborated before, the most common cause of appearance of de novo donor-specific antibody is non-adherence. The patient who skip medication 1 day or 2 in the week, or take one and skip 2, or the other will skip the whole thing. This is the non-adherence is the most common cause of donor-specific antibody. And when our graft survivor have been correlated to the de novo appearance of donor-specific antibody, there is a substantial effect on graft survival. As we can hear, those who have a de novo donor-specific antibody have a significant, around 10% graft survival over 5 years. So lesson learned from immunological monitoring. This is something we note actually to make it routine. We need to have a sensitive test rather than the messenger RNA gene chip array for research purposes, or rather the donor derived cell DNA. This all little bit so far is still sophisticated. We need a sensitive way, and we need to put it as a protocol for DSA. Even before branch, we need to detect, we need to have a post-transplant surveillance with a way to detect the DSA even before graft injury. So we need something different from creatinine and the proteinuria. As the chronic antibody-mediated injury in patients with new onset late graft dysfunction often leads to graft failure. And this is a more argument to find a way to routinize some sort of routine testing of DSA in certain group of patients. And nowadays we have the Limonex. It's still a little bit expensive, but it is available and easy. So this finding bring up a provocative management question. How can we minimize late post-transplant donor-specific antibody? When and how frequent should we monitor post-transplant donor-specific antibody? Should a biopsy be done when de novo donor-specific antibody are found? When there is a late chronic antibody-mediated rejection, how do we treat? So this 4 questions is still very good question for multi-center study and novelty in transplant to better improve the late graft outcome. So proteinuria, this is another important issue in transplant as well as non-transplant. Is it a risk factor or is it a marker? So it is found it predicts graft loss. It is associated with higher cardiovascular disease and mortality. KDOQI guideline recommend monitoring urine protein at least once in the first month, every 3 months, every 3 months in the first year, and annually afterward. And allograft biopsy is recommended when you see a new onset proteinuria or unexplained nephrotic range proteinuria to determine if a potentially treatable cause of graft dysfunction is present. So when you have a nephrotic range proteinuria unexplained, for example, you can shift patient to mTOR and he will develop the proteinuria, then we know what it is. Or a new onset proteinuria, then graft biopsy most probably is indicated to find out if there is a treatable cause inside the graft. And here is a very nice, it's kind of always very nice correlation. If the proteinuria less than half gram or more than gram, and it is related to graft survival, you can eventually see poor graft survival with proteinuria. Not only graft, but also patient. The more the proteinuria, the poor the graft and the patient survive. The less the proteinuria, the better the graft and the patient survive. And here is again when they correlated the proteinuria to systolic blood pressure. If a patient have a systolic blood pressure more than 40 and the proteinuria, the chances that he live with a functioning graft is much less compared to a patient who have no proteinuria and systolic blood pressure less than 40, and between them the alternation. So for those who have a living or who have a living kidney transplant, or those who have a native kidney and they got transplanted, especially those who got preemptive transplant before dialysis, there is a chance that this proteinuria post-transplant coming from the native kidney. A small study suggests that live donor recipient with residual native function, they have a native proteinuria, usually decline and may disappear after the first month. And after it disappears, subsequent increase in proteinuria should be related to the transplanted kidney and dealt with as I explained before. So proteinuria and sirolimus, I will not go through the STN study, spare transplant kidney. This study have shown that once you switch the patient to sirolimus, you might have threefold increase in proteinuria at 12 months compared to non-sirolimus group. So we can bear in mind when we use sirolimus or everolimus mTOR that this might be associated with increase in proteinuria, and usually we have to do a quantitative proteinuria before adding mTOR to the patient. And to have to know that a good group of those, when we switch it back to CNI, the proteinuria disappeared, which prove that it is related to mTOR. So we do not start mTOR therapy in a patient who have a proteinuria 1 gram per day. And the question is, does ACE inhibitor prevent proteinuria for up to 2 years conversion from CNI? Well, some data, this is a question, is still to be answered. And there is initial small data, but it's not enough. When you choose your patient to mTOR, are you going to add ACE inhibitor or not? Then the answer on this question will come in the next video. We'll study multi-center study which compared the use of ACE inhibitor, ARBs, versus placebo and treating proteinuria more than 0.2 gram in those who have a GFR more than 20 for almost 8 years. So they started after 2 weeks, 2 weeks they give the patient, they see if all the patients are tolerating the medication, yes or no. Once they prove they are tolerating and there is no intolerance, so they randomize the group ramipril versus placebo. They followed them for 4 years, and then they made another extension for 4 years, for another 4 years. And by the end of the study, which have almost 200 patients in each arm, ACE inhibitor, it does not show improvement on post-transplant proteinuria after 8 years follow-up. One of the most important post-transplant non-infectious complication is anemia. I will highlight it. There is a lot of study coming in, but I will go rapidly. The etiology is biliotropic. Infection, malignancy, some medication, chronic blood loss, iron deficiency. But we have to bear in mind that based on the United States registry data, 50% of the transplant cohort have creatinine more than 1.5 milligram per deciliter. and this puts them in the category of stage 3 CKD. So it's transplant CKD or transplant glomerulopathy, and stage 3 is the stage where the secretion of erythropoietin from the kidney started to decrease. So you have half the transplant cohort already are in CKD stage 3 stage with a decreased secretion of erythropoietin, and you have the other factors. And again, I chose only one study, but there are like several of them. But this is well done study like a decade ago, and tried to see if treating post-transplant anemia similar to treating anemia in patients with CKD and end-stage renal disease. If you increase more than 11.5, it will be associated with mortality. And in this study, they clearly showed if you increase the hemoglobin to above 12.5 using erythropoietin, it is associated with decreased survival and increased cardiovascular mortality. So as the group non-treated have a better survival, the group treated up to 12.5 have a cardiovascular mortality is like an untrue. However, there are several studies afterward, they are contradicting this data. So malignancy, it's very important. I highlighted it. So post-transplant malignancy, it have to be discussed with patient before transplant. And we have to emphasize our skin cancer and lymphoma as the most common. And the most data come from registries. And the incidence of cancer, non-skin cancer in transplant recipient is 3.5 times more when compared to general population. Excuse me. So the non-skin cancer in transplant patient is more than 3 times higher when it compared to a general population. So the importance of malignancy after transplant, as I showed early in the epidemiology data, this is why I bought it, because increasing life survival due to improved medication and technique and increase the life expectancy of transplant patient, as in general population, the older they get, the higher incidence of malignancy. So this is what is going on. And the rate of trunk cancer, another point to consider, the rate of cancer among the transplant patients. Imagine a patient of 30 years old transplant. He has the same rate of cancer like 60 years old of general population. So to correlate, transplanting a graft with immunosuppression increase, put the patient in the category of general population like 20, 30 years older in terms of incidence of malignancy. And the liver and kidney transplant recipient, malignancy is the second and third most common cause of death at 5 years post-transplant. And this is a very nice graph. It shows you in your left hand, there is a increase in 5-year incidence of cancer in the last decade because increase of the life expectancy of the transplant patient. If you look to the right-hand curve, it actually explains the left one, because in the last decade, lastly, the death, the graft failure, and the retransplantation have been decreased substantially. So the life of the patient has been increased, and due to decrease graft failure, decreased death, and increasing life and increasing life of the patient and life expectancy lead to increased incidence of cancer. It's not due to increase the cancer itself, because it's increased the age of the transplant patient. And this is a collective slides. I tell you, after 3 years, the incidence of skin cancer in transplant patient is equal to the incidence of all non-skin cancer. And this highlights the importance of a skin cancer and the skin care post-transplant. So all the non-skin cancer equal to the skin cancer. And this you have the whole data. I can share this presentation with you after the meeting. So that to bear in mind, the skin cancer equal to all non-skin cancer, and this gives a special care to skin post-transplant patient. And again, this is the last slide in malignancy. You can see here cancer in transplant patient versus general population. 2-fold increase, this is colon, lung, extra. 5-fold increase, melanoma, extra. 15-fold increase, kidney. 20-fold increase in skin, and lymphoma. And then we come to the etiology. And the importance of etiology, I just highlighted to stress on the pre-transplant workup. Most of the etiology are viral related. And this is a stress, as this is a virus, we have to screen, and everyone doing a transplant workup have to screen for this virus to treat, and also to put in mind that these people need a special surveillance for post-transplant cancer. And of course, in addition to the immunosuppression. So screening of virus, pre-transplant highlight for us the etiology and how to follow up these people who have positivity, and they needed to be treated first and needed to special follow-up. And of course, the role of immunosuppression in malignancy is known everywhere in transplant and non-transplant. So metabolic disorder, it is very important because we have seen that the cardiovascular death represents 30% of cause of mortality of post-transplant patients. So this is the definition of metabolic syndrome. If we have fellow, and so it is either 3 or 5 of this element: abdominal obesity, high triglyceride, low HDL, hypertension, elevated fasting blood glucose. Any 3 of those together, it is a metabolic syndrome. And it is usually associated with increased cardiovascular disease. And we know it is the highest #1 cause of death in transplantation. And this is a nice study which elaborates when you transplant obese patient with BMI more than 30. This study shows the pre-transplant metabolic syndrome. So if you have transplant patient with more than BMI within 30, you have higher incidence or high prevalence of hypertension, you have higher prevalence of triglyceride, you have high prevalence of fasting blood glucose, you have higher incidence of central obesity. And this is very important because you have to watch out what kind of immunosuppression you want to give in this patient post-transplant. And if you have a protocol, steroid avoidance or short course steroid, and you stop it after withdrawal, this will be the optimal management for this patient, for this group, to avoid post-transplant metabolic syndrome. And again, and I stratify them. Corticosteroid is associated with gain, hypertension, enhanced atherosclerotic liver profile, and also glucose metabolism disturbed. Cyclosporin more than TAC in weight gain, hypertension, and enhanced atherogenic lipid profile. However, TAC is more than cyclosporin, and regarding the new, and more than mTOR regarding new onset of post-transplant diabetes mellitus. And I will give a hint about this at the end of my talk. I still have like 2 or 3 minutes. And hyperlipidemia, mTOR is more cyclosporin and TAC. I remember I was a part of the clinical trial of using RAD. It is the first one made by Sandoz at that time, which will become later or a Novartis company. And it was mTOR developed by them. And I was working in France. We have 6 patients. And I do remember very well when I used to take a blood sample and I do centrifuge, the supernatant was become white due to hyperlipidemia. The supernatant completely white. No clear supernatant. And all 6 patients I was following developed the interstitial pneumonitis. So mTOR is associated with hyperlipidemia. And again, as 50% I mentioned before, as 50% of patients with a transplant have serum creatinine more than 1.5 milligram in the transplant registry in the United States, this puts them in a stage 3 CKD. And I already wrote a review in Current Opinion in Nephrology and Hypertension, and I brought this figure from it. And it tells you CKD stage 3 pre-transplant or graft dysfunction to the level of a stage 3 GFR less than 60. This is the mechanism by which you can have insulin resistance and diabetes in post-transplant, as well as in pre-transplant. So this is what happened in a CKD stage 3 or a graft nephropathy stage 3. So again, for about post-transplant diabetes, the old consensus was very high rate because there is no consensus about definition. When they got the consensus about definition, the rate decreased by 50%. And post-transplant diabetes as impaired as well as impaired glucose tolerance can adversely affect graft function and survival and promote cardiovascular morbidity and mortality. So identifying this group of patients pre-transplant and tailoring the immune suppression, obesity, whatever the type, decrease steroids or avoid tacrolimus will be the best. And this is show you the subject free of cardiac event when they are not diabetic, compared to new onset diabetes, compared to diabetes before transplant. So these are, so diabetes post-transplant is very highly associated with cardiovascular disease, like as a general population. And cumulative mortality also, it is increased here in post-transplant diabetes compared to normal glucose tolerance. So cumulative mortality here in post-transplant diabetes compared to normal glucose, significant difference in patient survival. So I wanted to elaborate. I will not go through all this screen, but I wanted to tell you the target protein of tacrolimus FK506 binding protein is also expressed at high level on pancreatic beta cell. So when you give tacrolimus to these people, it binds to protein and inhibits the secretion of insulin, and also it decreases the transcription of insulin promoter, okay, and as well induce beta cell damage and apoptosis. So tacrolimus is expressed on beta cell, sorry, FK506 is expressed on the beta cell. So giving tacrolimus will impact the beta cell function, will inhibit the insulin promoter, and will cause beta cell apoptosis. This is why I explain the very high incidence of diabetes with the tacrolimus. So this has to be considered when you have a patient with high risk of diabetes when you transplant patient. The most important point, once you stop TAC, the diabetogenic effect is reversed as early as 4 days after end of tacrolimus. And the strategy to treat post-transplant diabetes, I elaborated in my review on current opinion in nephrology and hypertension, edited by Professor Prenner, beta cell rest and reduction of body weight and the blood pressure, A1 reduction, and combination therapy. And the new agent like empagliflozin, GLP-1, and metformin, the old one. So the metformin, in addition to new agent, it works completely away from beta cells. So this is it works by decreasing A1C, body weight, and the blood pressure. This SGLT2 inhibitor and GLP-1 agonist in addition to metformin. This is, I think, is the best combination to treat post-transplant diabetes. In addition, the EMBA, SGLT2 inhibitor, and GLP-1 have proved in a small study to reduce the fatty liver. And all of us know 50% of diabetic patients, whatever general population or post-transplant, have a fatty liver, and it has an impact. If you know, it is one of the second common cause listing on liver transplant, NASH, non-alcoholic hepatic steatosis, which is caused by obesity and diabetes and metabolic disorder. And we found these two new medication decrease the fatty liver, so it gives them one more prevalent. And again, when they did, they bring the empagliflozin in culture, and I mixed it. They put it with beta cells. So they bring tacrolimus, beta cells in culture, and they put it with tacrolimus. It causes apoptosis of beta cells and the decreased secretion of insulin. And when they added to it empagliflozin, it blocked the effect of tacrolimus on beta cells. To summarize this long embedded discussion, so when they take in vitro beta cells, tacrolimus, it inhibits the secretion of insulin and causes apoptosis. When you add empagliflozin, it blocks the effect of tacrolimus on beta cells. To conclude this part, we have to screen well for post-transplant diabetes, either before or after, and we have to tailor our immunosuppressive medication. Also, we have to look to correct vitamin D and magnesium. The data is not conclusive, and there is no trials, but it's very important to correct them. Last point, hypertension or dyslipidemia. I would take 2 minutes if Madam Chairman allow me. Hypertension, there is no guideline for hypertension post-transplant. We have to bear in mind that certain type of calcium channel blocker, non-dihydropyridine, have drug-drug interaction with cyclosporine. ACE inhibitor or ERBs can cause rising of serum creatinine and the drop of hemoglobin. We have to consider it. Hyperlipidemia, a statin can interact with CNI. Ezetimibe is effective, but it doesn't work alone. Fibrate can rise serum creatinine. BCKC9 trial proved effective in CKD, but not in kidney transplant. This is before the last slide. So this is a statin in transplant improve outcome. And this is the last one using BCSK9 post-transplant, bearing in mind effect only one study. This one study in heart transplant, 16 patients, proved effective, but it's a very expensive drug. Again, there is a new review coming, only highlight to this 16 patient, and that's it. And dyslipidemia is very important now as a major cardiovascular risk factor, extreme risk. CKD stage 3 and 4, which is graft dysfunction, very extreme risk, very high risk. So CKD stage 3 or 4, which represent 50% of the transplant cohort in the United States, CKD stage 3, we have to give very important care about treatment of dyslipidemia. Thank you very much.
Thank you, Dr. Abdul Basit, for an excellent overview and clinically related overview about non-infectious complication post-transplant. But because we are running short of time, I'll just go through the questions. I would like to invite all the speakers to be online with us, please, so they can answer the questions. I'll start with you, Dr. Abdul Basit. The first question is, do you do some kind of malignancy might relate to to a certain type of immunosuppression?
Well, the study showed that the other way around, actually, that using mTOR would decrease, as an antiproliferative, would decrease the incidence of malignancy, especially skin cancer, and there are several data about this. And when you have a patient with malignancy, especially skin cancer or lymphoma, the first thing to do to decrease immunosuppression, and if you can add mTOR, these are small studies showing it can improve skin cancer and it can improve lymphoma. So it is the other way around, because the TAC and CNI is associated with increased malignancy as an immunosuppression, but mTOR is associated with antiproliferative effect. So mTOR have an anti-malignancy effect so far, as we know, whilst tacrolimus and CNI, in addition to MF, it is related to enhanced non-specific immunosuppression rather than a specific cause of this CNI or the other CNI, because tacrolimus, they have the same mechanism of action. So enhanced immunosuppression in general predisposed to malignancy. However, we have mTOR have anti-proliferative, anti-malignancy effect for skin and lymphoma.
The second question is to Dr. Abdulrahman. What was the outcome of your patient? I'll start with the initial part of the question. Did you have an experience with cases who had C3 glomerulonephritis post-kidney transplant, Dr. Abdulrahman?
No. No. But I think that the question also asking about the Eculizumab, right?
Exactly. How long would you treat such patients? I mean, so, it is debatable, but what do you suggest?
So the thing which mentioned or published in the literature is just only few case report or case series. They are showing a response, but exactly for how long, really nobody knows. Some cases they follow for a year, some 2 years, and nobody can answer this question so far.
The second question for you is, do you monitor CD20 levels post-given Retoximab?
No, although it has been suggested in some article that they follow the CD19 actually for the response for Retoximab, but we never use it. Just use the standard dose of Retoximab 1 gram, 2 weeks apart, and that's it.
Right. Yeah. Dr. Abdul Basit, is post-transplant erythrocytosis still a problem?
Well, it is not yet a problem. I tell you why, because now we use a new immunosuppressions which suppress the hematopoietic development of RBCs, like MMF. So this was before a problem in the era when we were using steroids and azathioprine to the limit. We used to do venesection for patient every week. And then after this, we come to the era of ACE inhibitor. ACE inhibitor is known to inhibit erythropoiesis in people who have some kidney impairment because angiotensin converting enzyme inhibitor, it doesn't inhibit only angiotensin converting enzyme, but inhibit also another enzyme called SKDP. This enzyme is responsible for conversion of erythrocyte progenitor to erythrocyte. So it blocks the erythrocyte in its progenitor stage, so it decreases the erythropoiesis. So excessive use of MMF and ACE inhibitor post-transplant makes the post-transplant erythrocytosis now is very minimal compared. In the old day, we used even to use before the era using the ACE inhibitor, we used to use cyphylline to inhibit erythrocytosis, and it caused gastritis. It was a hassle. Now we don't see it very rarely. And I use 2.5 milligram ACE inhibitor even in non-hypertensive patient. It helped prevention of proteinuria theoretically, and it helped also prevent improvement. I have a patient who was recently, I was following him in UAE. He was doing like once venous section per month. Sorry? Once venous section per month. And I give him 2.5 milligram ACE inhibitor. He stopped to do it. His name is Mohammed Saidi.
Okay, thank you. Dr. Abdurrahman, another question for you. Why high dose intravenous cyclosporine is better than oral in focal segmental post-transplant in the study which you have shared?
Okay, so no, they don't mention it's better. This is the protocol they designed for the study. They start with the IV cyclosporine for 2 weeks, and then they shift to oral. There are some studies which is also, again, just case series, they use oral cyclosporine and they targeted high dose and high trough level. As I said, it's for mainly antiproteinic effect to maintain beta-1 integrity and cytoskeleton. Is there any study comparing IV cyclosporine and oral? No, that's only the design of the study.
Yes. Dr. Andrea, are you there?
Yeah.
Okay.
Yes.
The next question is for you. When is the right time to do the kidney transplantation if the patient was affected with COVID?
That's a good question. That's a really good question. Well, I'll tell you something. I'm not able to tell you the answer right now. I mean, because I mean the COVID-19 is just, I mean, is just a new thing. But I can tell you something that infection contracted by kidney patient that has been transplanted, the risk started after 3 months after transplantation. After 3 months after transplantation, you're gonna see the first sign of the COVID-19 infection, like lung symptoms, like findings. And unfortunately, from the experience that I have been in contact with my center, this thing could be lethal in a small rate of the small number of the cases, but it could be lethal too. So I mean, if the candidate is affected by, well, I think we're gonna wait. I mean, the usual 15 days to be so that the patient will be negative, and then we should be. This is my feeling. We should be wait for the vaccination of the recipient, and if the living donor, recipient, and donor, and postpone transplantation after a couple of months, after 2 or 3 months.
Yes. Okay, thank you very much. Again, the next question for you, being chairperson of transplant committee in Dubai Hospital. Did you activate disease kidney transplant in Dubai Hospital?
You can answer.
No.
Dr. Amna, you can answer.
Okay. The next question
This is for you. This is for you.
Okay, and what is the approach that implemented, I guess he means, to increase donation to ensure success transplantation? In fact, we were in a process to start the disease donation, collaborating with our ICUs and in Abu Dhabi as well with Dr. Ali, but the COVID infection a bit was challenging and stopped us there, but hopefully very soon we are going to start again. Okay, kidney purification, Dr. Andrea. Kidney purification machine is used for transfer diseased kidney. How much that's adding value to enhance survival after transplant and reduce rejection?
Well, again, I will answer you that I'm not able to answer. That I mean, our experience with the mechanical perfusion, continuous mechanical perfusion of the kidney is just related to improve the storage. I mean, say to reduce the resistance of small intraparenchymal arteries in the graft. So I don't know if there are any data concerning that those kind of machine can reduce the viral load in a, affected donor.
Right. Dr. Fakhriya, the next question is for you. Can a patient with amputation go for the kidney transplant?
Amputation is not a contraindication for renal transplant. Amputation can occur because of severe vascular peripheral disease, or it can be caused by other causes like thrombosis or others. In general, it is not a contraindication for renal transplant, but of course we have to assess the vasculature very well. And if the patient has stenosis or anything which can be cured, yeah, we can go ahead and interfere, and then can patient have a transplant. But in general, it is not a contraindication amputation.
Right. The next question to Dr. Hassan. Should we reduce immunosuppressive medication, tacrolimus and cyclosporine and mycophenolate when treating, sorry, I guess it's for Dr. Abdurrahman. Should we reduce immunosuppressive medication, tacrolimus and mycophenolate when treating GN with cyclophosphamide and rituximab?
So for cyclophosphamide, yeah, we have to stop anti-metabolite if IV at least for 2 weeks from the dose. For rituximab, there is no recommendation about holding or minimizing the immunosuppressive regimen during after the rituximab dose. So it will be just based on your general assessment for your risk and benefit for your patient, risk of infection. But generally, no for rituximab.
Okay, great. The last question is Dr. Hatem.
Assalamu alaikum.
So the question is how the immunologist can suspect if there are autoantibodies.
Okay.
In addition of DTT, or you have
yes,
any?
actually, it starts when the clinician requests. The clinician, we are always asking the clinician to send us the provisional diagnosis. It will lead us how to do our work. Then after we're getting the antibody screening by CDC or one of these tests, if we suspected the autoantibodies, the modification which we did, adding with DDT or heating the serum, this is it will eliminate the autoantibodies. So when we suspect it, we are doing treatment for the serum, and of course the result will be changed after getting this treatment. And with communication with the physician, we figure out is an autoimmune antibodies or something else affecting our result. It's a matter of communication, and that's why we are asking always the physician to write for us the case of the patient, the pregnancy, autoimmune, what treatments they are taking, what anti-immunosuppressive they taking, if it's post-transplant investigation.
Yes, thank you, Dr. Hatem. With this, I would like to end our first session, and because of the prayers and for small lunch, and then we will join again at 1 o'clock, please. Thank you very much. See you in 1 hour.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much. Hello, everyone. We are back. we are back to the sessions, and our first speaker will be Professor John Cunningham. He's a professor of nephrology and at University College London Medical School, the Royal Free Hospital, and an honorary fellow of Trinity Hall, University of Cambridge. And he's going to give us an overview of early intervention. He's going to give us an overview of oral and IV calcimimetics in the renal transplant patients. I would like to welcome Professor John Cunningham. Please share your slides.
I hope you can see my screen now. Good morning, everybody. Greetings to you from the UK, where it is nice and sunny, but very cold. I hope you're having an enjoyable meeting in the UAE, and I rather wish that I was with you there rather than here. But those circumstances may change, of course, in the coming year with any luck. The talk I've been asked to give is going to straddle the pre-transplant and post-transplant era. Let me see if I can make these slides move, which at the moment they don't want to for some reason. That's very strange. So why are my slides not advancing? Let me just slightly odd. Bear with me a moment. Oh, that's very strange. My whole computer seems to have just stopped for some reason. I'm assuming you can all hear me and see this screen, but the screen won't move. So the whole thing is frozen, so I'm going to have to probably come out of this, I regret to say. And
Stop share and reshare again.
Hello. There's number 2. There we are. So let's see if we can go back now. Okay, so that's slightly better now. So here we are then. Here, this is the title. And the other way of looking at this, because we're going to be talking about the scenario both before and after kidney transplantation, I sometimes think of this as trying to make the body fit for the kidney, getting the dialysis patient ready to receive a kidney. And there are many components to that, of course, a number of which have been dwelt on during the course of the meeting already, I'm sure. But we're going to think more about the bonuses. There's a disclaimer from Amgen relating to the use of the drugs we may be talking about during this talk, and those are my disclosures. And I'd like to start off with this diagrammatic representation of the evolving changes that we see in calcium phosphate and the regulating hormones during the progression of CKD. And if we track this from left to right, we have here patients with good kidney function, GFR better than 90, progressive deterioration as we go from left to right. And what do we see? We see a series of adaptive changes developing as we go along. Now, these ones are as follows. Here's serum phosphate. Now, serum phosphate, you note, remains normal until the GFR is really quite low, 25, something like that, sometimes even lower. We see patients with normal serum phosphate, even with a low GFR. Yet we know that those patients have an impaired ability to excrete phosphate because the GFR is low. So you ask the question, how do they keep their serum phosphate normal? And the answer is they do it by developing secondary hyperparathyroidism and by developing progressive elevation of FGF23, 2 phosphaturic hormones. And without those changes, the serum phosphate will rise much sooner. And we know from experimental studies that in the absence of FGF23 and the absence of PTH, CKD is more destructive in terms of phosphate metabolism than it is in patients who have these responses intact. So these are adaptive responses in the early stages, and they're probably on balance a good thing. Later on, they may become so severe, these changes, that in some cases they probably become maladaptive, driven by the possibility that very high levels of FGF23 and very high levels of PTH may be bad for you in various ways, bad for the skeleton, bad for the vasculature, for example. This line here tracks the progressive failure of vitamin D activation. This is calcitriol here, and you can see that starts going down very early on indeed, when the GFR is still above 60. Then we come along with a kidney transplant, and some wonderful things happen. There's the patient on dialysis. We put in a transplant, and all of a sudden we have a scenario with the kidney that will excrete phosphate properly, and PTH comes down, and FGF23 comes down. And these two dramatically abnormal hormones move back towards normal very dramatically indeed, and quite swiftly, such that in the majority of patients, but not all, these hormones are either normal or near normal 12 months after transplantation. Serum phosphate, high on dialysis, typically drops down to subnormal levels very frequently in the post-transplant phase. We know that, and then tends to rise again back, sitting within the normal range, albeit the normal range, the lower part of that normal range in the majority of patients following transplantation. So the kidney transplant does a lot of good things. Now, one of the things we're going to be talking about today will be the impact of calcimimetic drugs on these processes. Now, these drugs interact with the calcium sensing receptor. Now, this figure may look a bit daunting, but you don't have to go through it all. I just want to draw your attention to the fact we have a parathyroid cell up here, we have a renal tubular cell there, and we have a bone cell here. And all these cell types express the calcium sensing receptor. Thereby, they all have the potential, when exposed to a calcimimetic drug, to alter their responses. So when you treat someone who's got hyperparathyroidism with a calcimimetic drug, bear in mind you're not just treating the parathyroid disease, but you're also going to have an effect on renal tubular handling and functions of various kinds, and on bone cells. So you're treating several organ systems when you give a calcimimetic drug. Worth bearing that in mind. That'll come up again later. Now, there's a big body of experience from the use of cinacalcet in the CKD and particularly the dialysis population. And I'm going to summarize the bulk of that information on a single slide here. So what have we learned from cinacalcet? And we're talking here almost exclusively dialysis patients. The main focus has been over the years the effects on surrogates. That's where we have the most data. What we really want, of course, is effects on outcomes. That's what matters to the patients. And this is a much smaller body of data, unfortunately, than this one. Now, we know that cinacalcet has generally a very beneficial effect on calcium, phosphate, PTH, and FGF23. Lots of studies demonstrate that. Cinacalcet greatly improves our ability to achieve biochemical targets, be they KDIGO, national guidelines, or whatever. So that drug, the arrival of cinacalcet, had a big impact on our ability to get the biochemistry good. It's very likely from studies, including the advanced study, that cinacalcet attenuates vascular calcification in the dialysis population. That's pretty certain in my view. Bone and parathyroid glands, cinacalcet definitely lowers abnormally high bone turnover, increases bone density, and reduces parathyroid gland size. So those are all potentially good things, but they're all surrogates. If we come over to the patient level outcomes here, there's no doubt that cinacalcet reduces parathyroidectomy requirements. So that's a patient level outcome worth having. Cinacalcet probably reduces fracture rate. That's from the EVOLVE and other studies. And it probably reduces cardiovascular mortality and cardiovascular events. That's EVOLVE and other studies. Now, the EVOLVE study was strictly negative, as you know, in terms of the primary endpoint, but there are various reasons for that. And I personally think, and a lot of my colleagues think, that ultimately there are probably positive signals coming from that study. So I'm going to say that this probably reduces mortality based on EVOLVE, but that it doesn't quite definitely do so. So these are the patient level outcomes from cinacalcet. Here's the receptor we're talking about here. This is the calcium sensing receptor, which, as you know, is a transmembrane receptor with an extracellular domain. It's expressed in many tissues. So here's the extracellular zone, intracellular zone. And we can interfere with this receptor with calcimimetic drugs. And here's cinacalcet, which binds to the transmembrane domain of the receptor, and by so doing makes the extracellular domain more sensitive to calcium. So the receptor becomes more responsive to calcium when there is a cinacalcet molecule sitting here. Don't worry about evacalcet, that's another calcimimetic that is used in Japan only. Then we have etylcalcetide, which is a much newer intravenous calcimimetic, acting predominantly on the extracellular domain, a bit on the transmembrane domain as well, probably, but it also increases the sensitivity of the extracellular domain to calcium. So we have these two different calcimimetics, etylcalcetide and cinacalcet, acting in somewhat different fashions on the receptor. And don't forget that they will be acting not just on these receptors in parathyroid tissue, but also in renal and other tissues. To summarize what etylcalcetide is all about, it's a synthetic peptide. It's not a very big one. It's resistant to proteolysis. So unlike most small peptides, it circulates in plasma and is very stable indeed. It's eliminated mainly by renal function, by GFR. And therefore, if the GFR is low, etylcalcetide remains in the circulation for long periods of time. It's dialysable, but in end-stage renal disease, the half-life is very long, 3 to 5 days. Now that means that if you give a single intravenous injection, potentially it's going to hang around until the next dialysis in a dialysis patient, which is quite useful. It doesn't cross the blood-brain barrier either. Look at the pharmacokinetics of this agent, tell quite an interesting story. We're looking at hemodialysis patients here, given a single intravenous injection of etylcalcetide, 5 milligrams up to 60 milligrams. You see an abrupt rise of the serum etylcalcetide concentration, and then a brisk fall here as it redistributes, and then from about 12 to 16 hours until the next dialysis, the levels remain almost flat. This reflects this extraordinary stability of etylcalcetide and resistance to proteolysis. And then at the next dialysis, the levels come down further as it's dialyzed away. And this applies across the dose range. If you look at effects on PTH on the right-hand side here, again, dose response study, and you can see that at all doses, even the small 5 milligram dose, there is a massive reduction of PTH, 60% or more, with a recovery, which is the rate of which is determined by the size of the dose given. So this stuff is very, very potent indeed. These doses are much higher than clinically used doses now, but nevertheless, across the clinical dose range, we see very profound reductions of PTH. So etylcalcetide is extremely potent as a calcimimetic. So let's look at a placebo-controlled study. This was the first big definitive placebo-controlled study that a group of us did a number of years ago, randomized 1-to-1, 500 or so in each group, and followed up for a period, treated for about 26 weeks, for 6 months, and then followed up for 30 days. And you can see quite profound effects on PTH here, placebo group and the treatment group, big reductions of PTH of at least 50% seen in the treatment group. And effects on calcium and phosphate, somewhat predictable. Here's serum calcium falling significantly in the treatment group, and serum phosphate also falling significantly in the treatment group. This has been seen with cinacalcet studies as well earlier. So quite a similar pattern to that seen with cinacalcet. These are very profound reductions though. So it is, as I said, very potent, this agent. That's exactly what you'd expect. If you look at the effect in relation to the severity of the underlying parathyroid disease, Here we've analyzed the data looking at 3 strata of parathyroid disease severity, A being the most severe, A being the least severe, C being the most severe. And in terms of percentage reduction of PTH, you can see it's pretty constant. Here's the etolcalcetide with about 70 to 75% achieving at least a 30% reduction of PTH. Doesn't matter how severe the disease is. If you look at absolute reduction of PTH, slightly different story. And the more severe the disease, the less likely you are to get full reduction of PTH to below 300 picograms per liter. But that's not surprising. You've got to push this drug harder as the disease is more severe. Dosing, not surprisingly, the most severe group, those with PTH greater than 1,000 to start with, ended up on a substantially higher dose than those with the more minor disease. So this again, no surprises here. The more severe the disease, the bigger the dose you end up giving. Our key question, of course, is does this new agent, etolcalcetide, work any better than cinacalcet? So we did a head-to-head study comparing cinacalcet with etolcalcetide. PTH, first of all, on the left-hand side, and you can see that here's cinacalcet and etolcalcetide. The main message here, both of these reduce PTH dramatically. They're both extremely effective at lowering PTH. Etolcalcetide probably a little more effective, possibly a dose effect, but nevertheless, these both do a very good job in lowering PTH. It doesn't matter whether you talk about the absolute levels or percentage reductions, the effects are quite dramatic and exactly what we would expect to see. In terms of serum phosphate, again, similar effects, both etolcalcetide and cinacalcet lowering serum phosphate to a modest degree. This is almost certainly reflecting a reduction of phosphate efflux from bone. Is the likely explanation for that. And serum calcium coming down as well, a little bit more with etolcalcetide than with cinacalcet. So again, these drugs are doing what it says on the tin. This is what we would expect a calcimimetic agent to do in hemodialysis patients. What about side effects? Well, one of the hopes in relation to etolcalcetide was that because it's intravenously administered, it would bypass the intestine and therefore would not trigger any of the GI disturbances that have been somewhat problematic with cinacalcet. So it was a source of surprise and disappointment to find that this was perhaps not the case. So we look at nausea and vomiting, and we see with etolcalcetide and cinacalcet really quite similar frequencies of these problems. So etolcalcetide, based on this study, seems to be no better than cinacalcet as far as upper GI symptoms are concerned. Now that's a surprise. It begs the question, why might that be? And I think the answer has to be that the effect of the calcimimetic on the GI tract is probably mediated via the calcium-sensitive receptor in the upper GI tract, and it's probably mediated via systemic delivery of drug, not by delivery specifically to the mucosal surface for an oral drug. That's somewhat speculative, but I think there's its most plausible explanation. Effects on FGF23. We know cinacalcet lowers FGF23 in dialysis patients, and we know etolcalcetide does as well. Dramatic reduction of FGF23, over 50% reduction. So that's quite a lot here. It's not as much as you get after doing a transplant, but it's still quite a lot, and none with placebo. If we compare etolcalcetide with cinacalcet, we see that etolcalcetide lowers the FGF23 quite a bit more than cinacalcet does. They both lower it, but etolcalcetide more. Now, does this matter? Well, we know that FGF23 is a very powerful predictor of bad cardiovascular outcomes in dialysis patients. So it is to be hoped that this would translate to a reduction in cardiovascular morbidity and mortality. There is no evidence to confirm that that is indeed the case at the moment. But with profound reductions like this, there's a significant possibility the studies are needed. So we keep our fingers crossed there. Etolcalcetide dosing. Many of you will have used etolcalcetide already. And in the various studies, typically, as I said, The more severe the disease, the more ethylcalcitonide you need, 20 to 20 milligrams or thereabouts weekly dosing in the placebo-controlled studies and other studies done by other groups showing similar sort of range of dose. Now, transplantation. Now, as far as the skeleton is concerned, that's what we're hoping we can do with these agents in transplant patients. This just summarizes the scenario historically that's been documented repeatedly in transplant patients. We have a loss of bone mineral density early on, high fracture rates, higher even than on dialysis. We have a very variable skeletal substrate at the time of transplantation. It can be anything from adynamic bone disease to hyperparathyroid bone disease. We then put the skeleton into a pretty toxic environment following transplantation with CNIs, very likely ongoing CKD if the kidney is not a particularly good one. And we used to expose the skeleton to a lot of steroid as well, progressively less and less, and these days in most centers very little and frequently virtually none at all. High prevalence of vitamin D deficiency and of hyperparathyroidism, which is what we're going to talk about today. There's no doubt that the skeletal outcomes are much, much better now that we are using steroid-sparing regimes for immune suppression. This has been a real game changer as far as the skeleton is concerned. Transplantation, as you would expect, does a very good job on hyperparathyroidism. This study was done way back in the 1960s. So in fact, before you could even measure PTH. So before it was possible to measure PTH, looking at a substantial, the quality of the images is not very good. Over a 10-month period, there's been a substantial lessening of subperiosteal bone resorption over a 10-month period, just radiographically. So this was the radiographic surrogate for measuring PTH, which couldn't be measured at that time. But it's been a problem that was on the radar for a long time. Also from an earlier study, 1998, it's been known for many years that the PTH that evolves post-transplantation is predicted by the pre-transplant PTH. Now, not entirely surprising, but this may have a bearing on how we use drugs like cinacalcet and etoposide pre-transplant in terms of trying to keep PTH down. So if we look at pre-transplant PTH rising progressively from left to right here, you can see that that's quite a good predictor of the PTH that is going to settle post-transplant. It's not a perfect correlation, of course, but there is a definite relationship there. So the bottom line there is that if hyperparathyroidism is severe at the time of transplantation, it's quite likely to persist following transplantation. It is a predictor. Now let's have a word about hypercalcemia post-transplantation. This is pretty common. It's almost always PTH dependent, not quite. So you need to be aware, of course, of other causes of hypercalcemia, all of which can exist post-transplant, but which are relatively infrequent in relation to PTH. So the PTH-dependent ones resolve spontaneously in most cases, and therefore the phenomenon is seen frequently early following transplantation and less frequently as you move away from the time of transplant. Persisting hypercalcemia is normally associated with big parathyroid glands and nodular hyperplasia, reflecting severe hyperparathyroidism before transplantation. So again, the more severe the disease before the transplant, the more likely you are to have trouble downstream following the transplant itself. And an example of this comes again from a nice study that was done again many years ago by Moulin and colleagues, who took a group of transplant patients who had outstandingly good graft function, so creatinine clearance 92 ml per min. And they matched them with a control group who had identical creatinine clearance, also 92. So we have this. So this group represents the very best, as it were, of the transplant outcomes in terms of GFR. And here are normal controls, untransplanted. And if we look down the list here of the various parameters we're looking at, one thing we notice is that PTH in the transplant patients is 5.2. Now that's at the upper end of the normal range, but note that it's almost double the PTH in the control group. So this is mid-normal range, this is upper normal range. Now these are not big, this is not a dramatic level of hyperparathyroidism, but I show it to make the point that even in the very best transplants, mild hyperparathyroidism is very frequent indeed, reflecting what has happened before the transplant was done when the patient was on dialysis. These patients have a high calcitriol level. That may surprise you. And the reason they have a high calcitriol level is because the PTH is driving the bioactivation of vitamin D. Serum calcium is normal, these two groups, no difference at all. And the renal handling of phosphate indicates a mild degree of phosphaturia, as you would expect from the slight elevation of PTH. So these patients have persisting, very mild hyperparathyroidism, even though calcium is normal, and even though the GFR is really very good indeed. They have thus a phenotype that is really very similar to mild primary hyperparathyroidism. And this indeed reflects almost certainly the underlying parathyroid pathology that exists in these patients. So what are we going to do about these patients with persisting hyperparathyroidism? Well, we want to attack the parathyroids in one way or another. We can chop them out. We can inject them with ethanol or calcitriol. These are treatments done very widely in Japan, but not much in other countries, but very successfully in Japan by and large. We can use vitamin D compounds, depending on the serum calcium level, and we can use calcimimetic agents. So what have we got? Cinacalcet to treat hypercalcemia. Now, there's a relative lack of what I would call good quality control studies here. There are plenty of retrospective studies of various designs, multi-centers, etc., but not many good control studies. This is one of them from Peter Evenepoel, done a few years ago. And this is looking at 114 patients randomized to cinacalcet or placebo. Okay, so reasonable numbers, and this is what happened. So we're looking first of all here at serum calcium concentration. Here's the placebo group, no change, mild hypercalcemia, no change as you'd expect. Cinacalcet group, very effective reduction of serum calcium of about 1.5 milligram per deciliter, something like that. Useful impact of cinacalcet, and after a year's treatment, cinacalcet withdrawn, and indicating that this treatment is not curative, it is suppressive. And the serum calcium bounces back to the baseline level almost immediately. So no surprises there, but it does work well in that situation. If we look at PTH, we see a similar story. PTH comes down very nicely in these patients who had parathyroid-dependent hypercalcemia, and at the end of the 1 year treatment period, bounces back to the more or less to the pre-treatment level. So again, it's a good suppressive treatment, but does not cure. And if we look at serum phosphate, this is interesting and quite important. Serum phosphate fairly steady in the control group, as we'd expect, and rises significantly in the cinacalcet group. This is the effect of reducing PTH, of course, and the reduction of PTH-induced phosphaturia. Now, in transplant patients, this rise doesn't usually matter because most of them are starting quite low, so they've got plenty of headroom. And in particular, the transplant patients who've got hyperparathyroidism, almost all have a low serum phosphate. So we don't mind a rise of serum phosphate, and indeed it's probably a good thing as far as skeletal metabolism is concerned as well. And again, phosphate comes back when the treatment is stopped. So again, these patients all have this phenotype, very like primary hyperparathyroidism, and are showing similar responses. Now, what about comparisons between surgery and cinacalcet in patients of this type? So these, again, parathyroid-dependent hypercalcemia. There's no doubt that parathyroidectomy is a very, very effective treatment for this condition. Now this study shows dramatic falls of PTH. Looking at this is using the technique of intraoperative PTH monitoring, which you are probably aware of, where a very rapid PTH assay is deployed in or close to the operating theatre to enable the surgeon to remove some of the parathyroid tissue and then do a PTH assay and see whether or not he or she has removed enough parathyroid tissue. And if the PTH hasn't gone down enough, come back and remove a bit more. It's a very, very good and useful adjunct to parathyroid surgery. So you can see dramatic reductions very quickly, which reflects a good biochemical outcome. But from that study, if we compare the effects on calcium, phosphate, and PTH, and we're going to compare the cinecalcet group with that parathyroidectomy group I just showed you. So let's look first of all at the PTH concentrations. That's in the middle here. And here's the baseline. And we see that in red, the parathyroidectomy, and the levels come down quite dramatically, and they come down rather more than in the cinecalcet group. Quite a significant increase following of the impact of parathyroidectomy versus cinecalcet there. If we look at serum calcium, there's relatively little difference. It's either not significant or barely so. Both treatments lower serum calcium to a modest degree. And serum phosphate, there's a rise of serum phosphate, as we would expect here, from levels of just under 1 millimole per liter. And again, the parathyroidectomy group has a slightly bigger rise of serum phosphate. Not surprising in that that group has the bigger fall of PTH. So the impact of parathyroidectomy is somewhat greater than that of cinecalcet. Now you may say, well, this is telling us that cinecalcet is not as good as parathyroidectomy. Well, superficially, looking at these data, you might say that's the case. But if we look at the doses that of cinecalcet were used, I would put it to you that the protocol didn't push the cinecalcet hard enough here. So the starting dose was 30 milligrams a day. At month 3, we have a third of the patients on 60 milligrams a day and 2/3 of the patients still on 30 milligrams a day. And at month 12, we have a third of the patients on 60 milligrams a day and still 2/3 on 30 milligrams a day. So the doses being given were, for most patients, only 30 milligrams a day. For about a third of the patients, 60 milligrams a day. This is not pushing cinecalcet very hard. And in my view, the cinecalcet was probably not escalated enough according to this protocol. So I think that's one of the reasons we're seeing these discrepancies here. My take is both these treatments work very well indeed. So the question then is, which of these are we going to choose? Well, they're both very effective for calcium and PTH, although probably the parathyroidectomy option is slightly better for lowering PTH. Not much difference on calcium. I haven't spoken in detail about the effect on bone density and bone markers, largely because they're very inconsistent from the various studies that have looked at those, and the study quality looking at those has not been particularly good. Neither of these approaches, parathyroidectomy or cinecalcet, has a demonstrable effect on fracture in good quality studies following transplantation. So the question then is, which is one of these one is going to go for? And I think the decisions are going to rest on various more practical considerations. Does the patient want an operation, or does the patient want to take tablets? Being one. Another one will be local expertise in the center. Some centers are more focused on the surgical approach here, reflecting either an interest or a particular level of expertise. And if expertise is high, surgery is certainly an attractive option here, because parathyroid surgery can be done very safely in good centers. But that's not always the case. And there was a worrying study published from the US about 3 years ago, retrospective study looking at post-operative complications of parathyroidectomy in renal patients, showing a really quite worryingly high readmission rate for local complications of surgery. Now, many of us in Europe, and I think probably you as well, would have looked at that study and said, well, they're having a much more, many more complications than we are. We've had very, very few significant complications over many years at my center. And I think we're fairly typical. I don't think we're necessarily much better than anywhere else, but we're quite good. And complication rates are very low indeed. So the are the guidelines that we work to that have been developed based on this. Admittedly comes from about 2017. So these are guidelines developed jointly by the British Transplant Society and the Renal Association, which is our UK-based kidney organization. So for so-called tertiary hyperparathyroidism, which is this autonomous hyperparathyroidism following transplantation, we would all agree that it is better to have the patient approaching transplantation well prepared and severe hyperparathyroidism treated, either with a vitamin D compound or calcimimetic or surgery, whichever. Cinacalcet can certainly be used following kidney transplantation, and that treatment, if the GFR is low, should essentially be the same as for other patients with CKD, pre-dialysis CKD. Now, I think that the calcimimetics have really produced a very useful option here in the post-transplant setting. As I said, established benefit in the endocrine scenario of primary hyperparathyroidism, and it's not surprising to me, therefore, that in the transplant scenario, which is very, very similar, we also see generally very good results. Thank you very much indeed, ladies and gentlemen.
Yes, Prof. Cunningham, thank you very much for a very interesting, informative lecture. I would like to introduce our next speaker, Professor Austin Stark. Professor Austin Stark, he's a professor and foundation chair. He's a professor and foundation chair of medicine of School of Medicine, University of Limerick, and consultant nephrologist of University Hospital Limerick in Ireland. He's going to talk about hyperkalemia and chronic kidney failure and heart failure. Welcome, Professor Austin Stark.
Good afternoon, everyone, and I hope you're all hearing me loud and clear from Limerick in Ireland. It's a great privilege to join you today for your transplant symposium. Austin Stack is my name. I'm a nephrologist at the University Hospital Limerick and the University of Limerick in Ireland. And what I'd like to do this afternoon is to share with you my insights in terms of the challenges of managing hyperkalemia in patients with chronic kidney disease and heart failure, and also to try and enlighten us all on how we should best manage patients to protect their kidney function and their heart function in the long term. So as an outline, we'll talk about why potassium control is important for patients with chronic kidney disease and heart failure. I will allude to the benefits of optimization of inhibitors of the renin-angiotensin system in both heart failure and chronic kidney disease. I will share with you recent data on the consequences of underdosing these patients or undertreating these patients. And we'll also look at the barriers to prescribing RASi inhibitors in patients with CKD. And finally, we'll bring you right up to 2021 with regard to novel treatments for managing potassium in the clinical setting. And I suppose before I proceed, I think we're all aware of patients with chronic kidney disease and heart failure. And over the past 20 years, what we've learned is that it is crucial to try and prevent or block the renin-angiotensin system. And we know we've got effective therapies to do that. ACE inhibitors, angiotensin receptor blockers, mineraloreceptor antagonists, and more recently, the ARNIs. But unfortunately, one of the challenges in optimizing the dose of these therapies is hyperkalemia, and that's what we will talk about today. So as kidney function declines, what we do know is the proportion of individuals in a population with hyperkalemia will increase. And in this nice population-based data from Kovetsky, we can see that as your GFR declines, the propensity of hyperkalemia increase with a greater number of individuals developing or having hyperkalemia. And if we take, for example, a threshold potassium of 5.5, we can see there's almost a linear relationship between the probability of having a moderate to severe hyperkalemia and a reduction in GFR. So, for example, individuals with a GFR of 15 mils a minute have about 16-fold higher likelihood of having hyperkalemia versus somebody with a GFR of about 80 mils per minute. And if we look at the health system to try and quantify the burden of hyperkalemia, we can see again there's this, gradient or almost linear effect. So as one's GFR declines from stage 1 to stage 5 CKD, the probability of hyperkalemia increases substantially. And this is just data from the Irish healthcare system, where we found that individuals with CKD stage 3, their probability of having hyperkalemia was 3%, rises to about 10% with stage 4, and about 35% with stage 5. And these patients were not on dialysis, so these are non-dialysis CKD patients, and we can see that the probability or the prevalence of hyperkalemia increases with advancing stage of chronic kidney disease. And then, of course, if we look at patients who are being managed by ourselves, nephrologists, I think we get a unique perspective of where we are in terms of potassium and its management. It's a very nice study from our Italian colleagues, a cohort study where they analyzed the quality of metabolic complication management in over 2,500 individuals attending Italian clinics. And what they found is that at visit 1, as you can imagine, that as kidney function with advancing or worsening stage of CKD, that the burden of hyperkalemia increased. And again, it was certainly high for those with mild to moderate, but still in all, it was, I believe, substantial and important for those with severe hyperkalemia. So at visit 1, this is what they found. But interestingly, after about a year, when they looked at the same patients at the clinic, the burden of hyperkalemia, mild, moderate to severe, was no different, indicating that it's prevalent and it is persistent even among patients who are directly under the care of nephrologists. And what we've learned, again, in recent times is that there's a very strong relationship between serum potassium and death, both in the general population and also in patients with CKD. And in this very nice study from Lou and colleagues in the US, they show the relationship. It's not linear, it's actually a U-shaped correlation or a U-shaped association. In other words, there's a higher risk of death for patients at the extremes of potassium. And it begins typically above potassium values of 5.5 and below potassiums of 3.5, with substantial elevation in mortality risk. In other words, the optimal range for patients is quite narrow, typically between about 4 and 4.9 millimoles per liter. And interestingly, that relationship, that U-shaped correlation, also extends across each individual stage of chronic kidney disease. And this data from a fairly large Japanese observational study analyzed the association between serum potassium and mortality by stage of CKD in those with the more advanced stages from stage 3 to stage 5. And as you can see in the left part of this slide here, that there's a gradient of risk from normal kalemia in the very light blue to severe hyperkalemia greater than 6 in the dark blue, and that is seen across each stage. But interestingly and importantly, that the impact of hyperkalemia differs across these stages. In other words, the impact is far greater in patients with mild CKD versus those with severe CKD. And as you can see here, in patients with severe CKD, the difference in risk is about 3-fold higher. In those with stage 3A, the difference is 15-fold higher. In other words, a high potassium in somebody with a GFR of about 45 mils a minute has a more detrimental impact in terms of mortality than an individual with stage 5 CKD. And we have looked at this recently in a systematic review and meta-analysis of a large cohorts presented at a recent European meeting. And again, we show the U-shaped association between serum potassium and mortality. But again, if you look at the difference between CKD patients who are not on dialysis and those on dialysis, you're seeing a differential risks. So for example, a CKD patient who is not on dialysis in the pink with a potassium of 6.5 has almost a 2-fold higher risk of death due to potassium versus a similar patient on dialysis. And similarly, and we shouldn't forget, hypokalemia also carries an increased risk of death. And we found that there was almost a 4-fold difference in mortality risk for a potassium of 2.5 for a CKD patient not on dialysis versus somebody who was dialysis dependent. In other words, the impact of serum potassium on mortality differs by level of or stage of CKD. What we teach our medical students and what we've learned over the past 20 to 30 years is that inhibitors or blockers of the renin-angiotensin-aldosterone system are beneficial and lead to significant improvement in patient outcomes, whether it be ACE inhibitors, angiotensin receptor blockers, or the mineralocorticoid antagonists. In addition to blood pressure reduction, these are cardioprotective, they are vasculoprotective, and they protect your kidneys. So when I prescribe an ACE or ARB, I usually tell my patients, you know what, there's 3 benefits, in one pill. They'll protect your heart, they'll protect your blood vessels, and they will help protect your kidneys in the long term. And that's the mantra I typically use to try and, I suppose, encourage compliance and make sure that we can optimize the use of these medications. And landmark studies, again, over the past 20 years, have demonstrated the efficacy and the safety of these agents, both in patients with heart failure and also in patients with chronic kidney disease, both diabetic and non-diabetic. And following these studies, the international guideline associations and professional societies have endorsed the use of these agents to protect kidney function and to protect heart function for these patients at risk. So we know that they slow the progression of kidney disease. We know in heart failure they reduce hospitalization and improve patient survival. And the recommendation from these guideline groups is that we should be using the highest tolerated targeted dose to get the best outcome, because that's what has been shown or demonstrated in clinical trials. However, if we look at our own practice in nephrology, we do recognize that there's variation in the use of these medications across countries and by stage of kidney disease. This is nice data from the CKD DOPS, which shows, quite significant variation in the prevalence of RASI prescription across countries. And we've got 4 countries illustrated here: Brazil, France, Germany, and the United States, but also by CKD stage. And I just kind of highlight just the US, for example, that the prevalence of RASI inhibitor use decreases from 59% to 32% from stage 3 to stage 5. And that's not surprising because of perhaps hyperkalemia or decline in kidney function, and the consideration that these agents might accelerate initiation of dialysis in some subgroups. Typically what happens is that these medications are either not started in the later stage of CKD, or typically the dose is reduced or withdrawn. And the question that we have to ask ourselves is that desirable? Is that a good thing? Now, there are no randomized controlled clinical trials on this, but observational data recently suggests that this may not be a desirable clinical strategy. And this data from the Hopkins group analyzed the outcomes of patients from a large US healthcare system, where they compared patients who had their ACE or ARB stopped when their GFR fell below 30 mils a minute. And in this longitudinal cohort, they followed them for up to 5 years, and they looked at major outcomes: mortality, major adverse cardiovascular events, and end-stage kidney disease. And this is what they found when they analyzed the data. So when they looked at survival, they found that those patients who had their ACE inhibitor or angiotensin receptor blocker stopped, that their survival was worse. And no matter how you looked at the data in terms of adjustment or using propensity scored matching samples, the pattern was virtually identical. In other words, individuals who had their RAS inhibitor therapy stopped, they had a higher mortality by about 40% versus those who did not. Similarly, when they analyzed in detail the incidence of major adverse cardiovascular events, they found a similar pattern. In other words, those individuals who had their treatment stopped, their cardioprotective and renal protective treatment, that their risk of MACE was 37% higher compared to those who did not. So clearly that information would tell us, or would suggest, that stopping RAS inhibitors is not desirable in patients who have got progressive decline in kidney function. Similarly, when people have examined the outcomes of patients who either had their treatment stopped or reduced, another pattern, a similar pattern, is emerging. In other words, patients who have their RASI dose reduced or their treatment stopped, they experience a higher risk of death or a higher risk of adverse clinical outcomes versus those who don't. And this nice data from Epstein shows this quite clearly. And as you can see here in the dark blue, that individuals who stop their therapy, or in the red who've had a reduced dose, experience higher risk of death or a higher risk or a higher percentage of adverse clinical outcomes. And if you just look at mortality, as they have done in this particular analysis here, whether you look at patients with CKD, heart failure, diabetes, you're seeing a similar pattern emerge, that individuals who have their RASI therapy discontinued, those patients do not do well. They have a higher risk of death versus those who are on the maximum dose. They have a significantly and substantially low rate of mortality. So the question is, can we optimize RASI treatment and improve patient outcomes by improving potassium control? And yes, I think the answer is we can. And I believe we can use potassium binders as a therapeutic enabler to allow us, one, maximize or optimize the prescription and the continuation of RAS inhibitor therapy, and at the same time ensure effective potassium control to keep it within the desired normal range. So there's been a number of new drugs on the market that have come to fruition. And the first one that I would like to mention is patiromer. This is a high capacity polymer. It's a cation exchange polymer. It binds potassium in the colon and exchanges it for calcium. It's an oral solution. It is not absorbed. And it's effective at reducing serum potassium and at maintaining the serum potassium within the normal range. There are some side effects, which I've mentioned, and there are also, it's important to know, some drug-drug interactions. So it's important to take this medication 3 hours apart from other oral medication that the patient may be on. The clinical efficacy, the safety of this drug has been examined conclusively in at least 2 major clinical trials. The first is the OPAL-HK, which I'll just present quite briefly here. And again, these are patients with chronic kidney disease who are on a NACE inhibitor or an angiotensin receptor blocker. And in this randomized controlled trial, they stratified patients at baseline by the degree of hyperkalemia, mild versus moderate to severe. And it was a 2-phase study where they initially randomized them to placebo versus patiromer at different doses. And they followed them for 4 weeks and looked at the change in serum potassium. That was the first part, part A. And the second part of this clinical trial, it was the withdrawal phase. They focused on those who had moderate to severe hyperkalemia at baseline. And what they did with those patients, they randomized them to either stay on patiromer or remain on a placebo, for another 4 to 8 weeks, and then examined the serum potassium at the end of that treatment period. And this slide here illustrates what happened over the total duration of the study. So at the end of the first part of the clinical trial, at the end of 4 weeks, the overall reduction in serum potassium amongst patients who were randomized was approximately 1 millimole per liter. There was a greater effect for patients who had moderate to severe hyperkalemia versus those who had mild hyperkalemia. In the phase 2, or the withdrawal phase, what they found is that individuals who were randomized at that phase, those who remained on patiromer, their serum potassium remained within a normal range, but those who were randomized to placebo and continued the RAS therapy, their serum potassium started to creep up again. At the end of the study, the difference was 0.7 millimoles per liter. So this clinical trial demonstrated that patiromer was effective at both reducing serum potassium in patients with CKD on RAS therapy who had hyperkalemia, and number 2, maintaining that serum potassium within the normal range at extended follow-up. But the second, and I think equally important and compelling point, is that when they looked at the proportion of patients who could remain on a RAS inhibitor in the study, they found that 94% of patients in the patiromer group were able to stay on their RAS inhibitor therapy. 94% versus 44% in the placebo group. In other words, if you can control serum potassium, your patient more likely to stay on the RAS inhibitor therapy with very little change in the dose, or very little risk of down titration of the RAS inhibitor dose. The second study, which assessed the longer-term safety and efficacy of patiromer, was the Amethyst DN clinical trial. And the overall goal of this particular study was to determine the optimal starting dose of patiromer, and also to assess its effect in individuals who are not just on an ACE or ARB, but who also may be on a mineralocorticoid inhibitor, and the drug they used was spironolactone. So this was a phase 2 randomized controlled clinical trial. They included patients with stage 3 and stage 4. These were diabetic patients with albuminuria, and they were on a stable RAS inhibitor dose prior to randomization. It was a somewhat complex clinical trial, but ultimately it tested the efficacy of patiromer in 3 specific subgroups, following the screening period. So at the run-in period, they had one group of patients who were on RASI therapy and then were randomized according to their serum potassium. A second group of patients were those where they had stopped the RAS inhibitor, during the run-in, and started losartan, a very fixed dose of 100 milligrams daily, and then added spironolactone, if need be, for blood pressure control. And a third group of patients where they continued the RAS inhibitor therapy and then added spironolactone 25 milligrams in all of that cohort. So they followed them over time, and they analyzed change in serum potassium at the end of the 4-week follow-up. And this slide here illustrates the final results. And what we can see is that individuals who were on the higher dose of patiromer, typically the 25-gram dose, had a greater benefit in terms of potassium reduction than those on the more modest 8.4 grams. So it looked like there was a dose response, with the most efficacious dose plateauing at 25 grams. And secondly, they illustrate, as before, that there's a greater effect amongst patients who were classified as having moderate to severe hyperkalemia versus those who were mild. And they saw that both at the 4-week and at the 8-week analysis. The second compound or drug that has come to the market has a big long name. It's called SZC, sodium zirconium cyclosilicate. And unlike patiromer, this is a sodium-based potassium binder. It's again orally administered, it's not absorbed, and it binds potassium in exchange of sodium. But unlike patiromer, it works along both the small and the large intestine. So it's effective along really the entire GI tract. It is a more rapid onset of action. And again, it has similar side effect profiles to patiromer in terms of GI intolerance and hypokalemia. But importantly, it can also cause edema. And that could be an issue in patients who have are prone to volume overload, or patients with coexisting heart failure. And that's going to be important in the larger clinical trials, which will be evaluating harder clinical outcomes. And the harmonized clinical trial has examined the safety and the efficacy of SZC in patients with hyperkalemia. And this was a 2-phase study design. The initial was a 48-hour open phase study where they assessed the efficacy of SZC 10 grams 3 times a day to achieve normal kalemia. And amongst those who achieved normal kalemia, that's a potassium between 3.5 to 5, they then proceeded to the randomized phase where they compared 3 doses of SZC versus placebo, a 5 gram, a 10 gram, and a 15-gram dose. And again, similar to Pathogenesis, this drug is effective at normalizing and maintaining normal kalemia in patients with hyperkalemia. As you can see, there's a fairly clear dose response from the 5 up to the 15-gram dose. And again, this effect persisted throughout the duration of study compared to the placebo arm, whose patients remained hyperkalemic. In terms of side effect profile, I think the major ones are GI intolerance and hypokalemia, but also, as I mentioned, edema is one of the side effects of these, naturally attributed to its sodium base in the compound. From a clinical perspective, so what we want to do is we want to optimize the use of RAS inhibitor therapy, and at the same time ensure patients are safe by ensuring normal kalemia. And since they're a new drug on the market, it's important that we prescribe them carefully. And also, like any other new drugs to the market, there will be a learning experience in terms of getting familiar with the patient phenotype that we're using them for, and also how we monitor levels, monitor kidney function and potassium to ensure patients are safe and adequately monitored. So typically, we would initiate when the potassium is 5 or above and titrate the dose up until the potassium is within the normal range. With Pathogenesis, the normal starting dose is 8.4 grams a day, titrating up to a maximum of 25 grams a day. With SZC, the initial treatment is, we call it the correction phase, and it's prescribed as 10 grams 3 times a day until the patient is normal kalemic. And then we maintain them on either 5 to 10 grams of SZC daily to ensure that the serum potassium remains normal, during the optimization phase of the RAS inhibitor. I think it's important to note that we need to know when to stop these agents. And my view is that they should be stopped very similar to the rules for stopping ACE inhibitors and diuretics in patients who are sick or acutely well. We call them the sick day rules. And these drugs should be stopped until the patient is back to good health again. If you stop the RAS inhibitor, you also need to stop the potassium binder. You can't stop one without stopping the other. In other words, they come as a packet. It's a marriage. Because if you stop the RAS inhibitor and then you continue the patient on Pathogenesis, naturally they're prone to hyperkalemia, which can also have ill side effects. The kidney function needs to be monitored, as does the serum potassium. And in my rule of thumb, because we don't want to make things complicated, I think we need to monitor these patients as you would do any patient on an ACE inhibitor, an angiotensin receptor blocker, or a mineralocorticoid inhibitor. And I think we're pretty good at monitoring kidney function in patients with, moderate to advanced CKD. So what's next in terms of these agents? Well, I think we need to see how they work in the real world clinical settings. We've seen how they work in the clinical trials, and this is under close observation, but we really need to see how they function in terms of safety and efficacy in real world clinical populations. There are 2 large clinical trials that are currently underway to assess the efficacy of these drugs in terms of the harder clinical outcomes, in terms of cardiovascular events and death. The first is the DIAMOND trial, which will assess the efficacy of Pathogenesis in managing hyperkalemia in patients with heart failure. And the second is the PRIORITIZE HF, which again will test the efficacy of sodium zirconium cyclosilicate in patients with heart failure. Both of those clinical trials are underway, and I believe we'll have the results in 2022. But like everything else, the COVID pandemic has clearly affected timelines and schedules, so it might be a little later than expected. So patients who benefit most from RAS inhibitor therapy really are the patients at the greatest risk of hyperkalemia. So as clinicians, I know that you and I will face the same dilemmas. When we manage these patients, we see them in clinic and we see the potassium is 5.5. And the question is, do we prescribe a RAS inhibitor therapy, RAS inhibitor, and accept the presence of hyperkalemia? Or do we stop or reduce it and lose the benefits in terms of clinical outcomes? That has been the dilemma and the challenge. And that's what I think us as nephrologists and cardiologists have been faced with over the past number of years. And we really haven't had an effective, safe clinical strategy to do that. But I do think with these new agents, I think it will open new opportunities and allow us to maximize therapy for them. So to summarize, hyperkalemia is extremely common in patients with chronic kidney disease and heart failure. It is associated with substantial morbidity and mortality, one direct related to the hyperkalemia, but also due to the coexisting reduction or stopping of agents that block the renin-angiotensin system. Both patiromer and SHC are effective potassium-lowering agents. They offer better tolerability and safety over existing strategies. And I think it'd be really interesting, and I look forward to the clinical studies, the clinical trials that are ongoing to assess the impact on these major outcomes. So we look forward to what happens to the results of these in the next year or so. So with that, I thank you for listening to me, and I'm delighted to take any questions. So from myself here at the University of Limerick and my colleagues, I thank you for listening.
One question. Kriya Fernandez Budacheria. Hey, how are you now, Marujo?
Okay. Share video.
Achi.
Share video.
Thank you, Professor. Thanks for an excellent update. What about any data in kidney transplantation?
I thought you might ask that. I am not familiar. So I mean, clearly, I mean, the initial clinical trials have assessed it in the larger populations with CKD, the more generic that we see. I always think, transplant patients are like the end-stage kidney disease. They're always assessed at the very end when we know about the safety and efficacy in the other more stable populations. I don't have any data on that. I'm sure it's going to be tested, but I without a doubt, I would bet that they will be the next population to be studied in detail. One of the things that is going to be, I suppose, like everything else, a little challenge is that once you take these agents, there's a possibility it's going to interact with some of the transplant medication. And what we don't want to do is that it binds, mycophenolate or tacrolimus and alter immune suppression. So I think they're a population to be studied very closely. And I have no doubt that perhaps at the moment there are some studies ongoing, but I don't know myself who is leading those or what's the current stage.
Thanks for an excellent presentation, Professor. So we were decided to keep the questions at the end, but I couldn't wait asking this question.
Not a problem.
We'll go for the next speaker, Dr. Mohammed Riley. He's a consultant in Dubai Hospital. For the last 30 years, he's been serving Dubai Hospital. And he's one of the pioneers who established peritoneal dialysis at Dubai Hospital. And he's going to solve our dilemma today about BK nephropathy. Welcome, Dr. Riley. Please start.
Thank you.
Final, sir.
Huh?
Please run final.
નથી દેખાતું.
Final, sir.
ના દેખાતું નથી મને.
I just press on it.
Okay, fine.
Slide from the beginning. Slide show.
નથી દેખાતું છે મને.
Slide show. Slide show.
અહીંયા.
Slide show.
અહીંયા. આ મેં slide show કર્યું ને.
From beginning. Beginning. Unmute.
થઈ ગયું. Good afternoon, everybody. Can you hear me, please? કરી લીધું છે.
Yes, here.
We do, Dr. Riley, yes.
Yeah, I have been given a difficult task, that I have to solve this dilemma this afternoon after biryani. Okay, but I will start. Yeah. So the topic I was supposed to discuss is management of dilemma in BK virus nephropathy. Usually this nephropathy arises because of the consequence of more potent immunosuppressants which we use to reduce acute rejection and improving allograft revival. Now, to understand before we go further, I thought this is very important to understand the genome of this BK virus. It has got, the virus has got 3 regions of functioning. One is about the proteins, the T proteins, which are necessary for the replication and reconstitution, collecting all the things for it to multiply in our human body. The second protein, which comes later, is usually V1, V2, V3, which is virus protein. And then there is another region which is known as a non-coding region, which ultimately allows it to go out of the system. This is how it happens. And usually these are non-enveloped DNA virus. You must understand that any DNA virus to proliferate somewhere, it has to go into the nucleus of that cell. And in this, you can see the virus is coming inside the cells to multiply and form the inclusion bodies. And this is by help of this T antigen and the virus P1, P2, 3 antigen, which takes part in its proliferation, rebuilding, and ultimately the cell, there is a multiplication of the virus in this cell, and the cell gets swollen up, and then it gets burst, and eventually the virions are released into our system. Now, we all acquire this virus while we are small age, around during the childhood, mainly around between the age of 5 and 9. Nearly 80% of us has acquired this virus. Usually it is through the respiratory system, and then it goes and settles down in the tubular epithelium where it rests. And then any risky conditions comes, this virus are stimulated. Now, somebody, if he undergoes renal transplant and then he is immunosuppressant, there are certain risk factors which I have listed over here, which will stimulate, or it makes them more prone to develop this BK virus nephropathy. And these are, you can see over here, this is recipient related, older age, I mean age more than 60 years of age, if he has any steroid exposure because of any rejection beforehand. Donor related. Now, these genotypes, the BK virus has got 6 subtypes. And type 1 is the commonest one, which nearly 80% of us has. Now, 15% of us have genotype 4, which is second most commonest. So if a donor gives a kidney who has got a genotype 4 to genotype 1 person, this person doesn't have antibodies to genotype 4, and they tend to develop this BK virus nephropathy. What are the transplant related, as we said, high immunosuppressant is one. Use of tacrolimus has been noticed. if during the initiation or induction, thymoglobulin induction has been given, these are the people who are more prone to get this nephropathy. If ureteral stents is used, or if there is a mismatch of HLA. Now, you can see there are so many factors over here which are listed over here. The problem is these are from the various institutions, everybody, these are all small number of patients, and they've come to a conclusion from there. This is why all the list of these risk factors are over here. Now, the most important thing about BK virus is the initial screening of the patients. Now, what are the clinical features of BKV infection? Most of the time, there is, when we are checking the BK virus, it will be increasing, and that will alert you that there is a chance that this patient will develop nephropathy. But if you are late in doing this, then you tend to develop renal dysfunction. That is the first manifestation. So usually by that time, there is always a damage done inside the kidney. Occasionally, 3% people of they present as they have urinary obstruction. The obstruction is in the ureter area. This is around 3% of the patients, they tend to develop this obstruction. Usually this obstruction is within first 6 months, usually 3 to 6 months, this obstruction will manifest. So this is why it is recommended that you should start screening these patients as early as possible, probably every month for the first 9 months, if possible. Some of the centers, they start at 3, some of them, they start at 6. But it is, from this, you can realize that it is advisable to start screening these patients as early as possible. In patient who has bone marrow transplantation and they are harboring BK virus, the patients with bone marrow transplant, they have got a lot of immunosuppressant. And then these people, there is a flare of BK virus, and in them, usually it manifests as hematuria or hemorrhagic cystitis. The other presentation is there might be because of the viremia, and in somebody who has received a transplant from cadaveric, sometimes they tend to develop the systemic manifestation involving even the CNS system. This is why I mentioned it before, that prospectively we must do the screening as soon as possible. Usually the screening, what was recommended initially, we used to check the urine for the decoy cells, but the way to screen the patient is through the plasma PCR, because this correlates with what is happening inside the kidney. And the level which they recommend is 4 log by 10, which is approximately 10,000 copies in the blood. And if you notice this, then you should start reducing the amount of immunosuppression. You will be lucky this way to stay away from developing the kidney damage. Now, but this screening is hampered by universal standard, because the standard in each laboratory is different. The way they measure it is different. So it is advisable, if you are in one station, you stay and try to use the same laboratory. Otherwise, what will happen if you go to the different laboratories, their standards are different, and you will be unable to calculate these things from them, and you will end up having high levels without you having the knowledge. The other things, what they notice, that if you do the titers of neutralizing antibodies, this is BK virus neutralizing antibody, it gives quite a good idea. You can see here the survey which was done over here. The recipients who developed the delayed and weak this NAB response, they were very high, significantly risk at developing BK viremia and BK virus nephropathy. So it is nice to monitor this, and it will give you an idea whether this patient is going to develop this nephropathy or not. The other thing nowadays, what they are checking is they are using the innate immune system measurements. When I say innate immune system, there are two things which are important over there. One thing is they measure the HLA between the donor and the recipient. And there are some HLA which are low risk causing viremia. So these are the named, I gave you HLA-A2. These are some of the things. And some of them, they make you more prone to this nephropathy. So you will have an idea that whether your chances of developing nephropathy. So in order that you monitor the virus level very diligently. The second immune system which you should be checking is natural killer cell function. These are known to protect. If you have got enough titer inside your body, then it will prevent nephropathy. So it's nice to measure the level of the natural killer cells, and this you can do by measuring the CD3 positive, CD8 positive T cells and interferon gamma levels. If you check this, in those people who are prone to nephropathy, the levels will be lower in these people. So you can adjust accordingly. There are some methods where you can probably either reduce or you can add some things which will make these cells available for you. So this is another thing. The other thing nowadays also there, you can see from this genome, there is a microRNA in this. Now, whenever somebody has got a severe infection, right, of the virus inside the body, this microRNA levels also they increase. Now, if the microRNA level are to certain level, which they have measured, it is as good as knowing that there is, it's as good as doing a kidney biopsy in a person. And it will tell you a lot of things that there is a probably damage going inside that kidney. So it is worthwhile if you can manage or measure these microRNAs. More recently, what they found, sometimes, you know, there are centers where they don't have the facilities to measure the decoy cells, or they don't have that expertise in that center. So in them, if at all, if they have electron microscope, there might be, they will be able to find these three-dimensional aggregates of polyoma in the urine, which are known as HAWFED. And when you measure, if you quantitate these things, this is a very good indication of how much viruses are in the kidney or intrarenal area. And it has got a positive predictive value of 90% nearly. Now, when somebody's level is more than 10,000, usually the American Society of Transplantation is recommending that they should undergo kidney biopsy. But not all the centers all around the world or the nephrology section, they follow these guidelines. They said that if the level is high and if the creatinine is normal, they will just reduce the immunosuppressant and they will observe the patient. Now, if the creatinine rises, then they will probably do a kidney biopsy. Their motive being because they want to rule out acute rejection in this person. They want to know the drug level of the person. And they want to know whether the BK virus has damaged how much the kidney. Some of the centers, when they find increased indication of immunological risk, although the creatinine is normal, they tend to do the biopsy, which are these people who are highly sensitized with PRA, who has a presence of donor-specific antibodies. Their blood group, there is incompatibility, and because of that, probably they might have already developed rejection and they have already received the therapy, or people who have a retransplantation or history of acute rejection. These are the people, they tend to undergo kidney biopsy. Now, the false rate, negative biopsy rate, it ranges from 10 to 30. And why it happens? Because if you want to biopsy in somebody who has got BK virus and you suspect that he has developed nephropathy, you must take at least 2 courses of biopsy. And this should contain the medulla in this biopsy. They advise that normally sometimes we use 16 to 18 gauge needle. We should try to use 15 gauge needle, and it should go quite deep in order to get this specimen, right? Now, this was a survey, or these are the consecutive transplant biopsies which were done in 2,244 consecutive transplant patients. And you can see when the cortex was only taken, they could diagnose nephropathy in 2%, while those people who had taken a biopsy with medulla, in them, there was significant increase in the amount of number of patients who can who could be diagnosed with BK virus nephropathy. Now, you will ask me that why it's what is the importance of the biopsy? As I mentioned before, that you can rule out the other causes. Nowadays, you know, the BAMF have made a classification for these biopsies. There are 3 grades. So exactly you know how much damage is there and what is the outcome of that patients can be judged from this biopsy. The only problem with this biopsy is it's quite confusing. Sometimes there are features of acute rejection in this biopsy, and it is difficult to know whether these changes are because of the acute rejection or is it because of the BK virus. But if somebody has got a significant tubular atrophy and he has got interstitial fibrosis, and then there is a staining of SV40, it tilts more towards this BK virus nephropathy, right? So it gives a valuable prognostic insight. If you do the biopsy also serially, it adds some more information. Now, after knowing the biopsy, it's very difficult now. This is the question, what would you do now? You have already started reducing the immunosuppression. They say that before the creatinine is disturbed, and if you start decreasing the immunosuppression when the kidney function is baseline or normal, then in a prospective observational studies, they notice that 80% of the patient, they recover. I mean to say the viral load comes down. It is very optimistic. And if you already have a damage in the kidney, then probably you require more intervention steps. It will take longer time for you to recover. And probably you might face with permanent loss or renal allograft loss in these people. Now, the problem, the cases or the studies which have been done, there is no randomized trial. You can see from each center, there are few patients reported, and they have reported their experiences. This is why I could not put anything over here on a graph, but these were some of the recommendations. First of all, American Society of Transplantation has given. They say first 2 alternatives. Their alternatives, they say reduce. Now, previously we always used to think that mycophenolate is the only problem. But no, even the tacrolimus and cyclosporine also brings these problems with us. So there are 2 alternatives you can follow. You can reduce this tacrolimus or this cyclosporine 25 to 50% in 1 or 2 steps at a gap of 2 weeks duration. And at the same time, later on, you can reduce mycophenolate or anti-metabolite in these people. If the viremia still persists or it doesn't decrease, then you decrease the or you stop the anti-metabolite completely. I have met few other people from other centers. They stop their anti-metabolite initially. They sometimes replace it with something. Now, the second alternative they gave, you reduce the anti-metabolite mycophenolate by 50% followed by calcineurin inhibitor by 25 to 50%. If the viral load doesn't come down, then again you discontinue the antimetabolite. Now, while you are reducing, or how much you will reduce this immunosuppressant, you will keep tacrolimus level less than 6 in these people, or you will aim at that level, while the cyclosporine level will be between 50 to 75. Some people, what they do, they stop the metabolite over here. Now, I have given the alternatives what the other people they did. They switched the calcineurin inhibitor to sirolimus. They replaced it with sirolimus. Other people, they stopped mycophenolate. They gave low dose sirolimus. Other people, they took mycophenolate completely off, and they started leflunomide in these people. Now, they combined this, they changed this, and also they started reducing the calcineurin inhibitors. If the level doesn't go, then they try to take other type of drugs. Here you can see, this is one of the example, one of the centers. In that center, they used to reduce, they used to change tacrolimus to cyclosporine, because it is noted that the cyclosporine, it reduces the multiplication of this virus inside the tubular epithelium, while the tacrolimus, it stimulates it. So this is how they change tacrolimus to cyclosporine with maintaining the level of 50 to 75. And otherwise, as I mentioned, at the same level, they changed the mycophenolate to leflunomide, and they continued with this regime. Or sometimes they stop the tacrolimus and MPA, and they start mTOR like sirolimus or everolimus and low dose cyclosporine. They wait for 4 to 6 weeks. If there is no improvement in BK viremia, then in these people, they administer the intravenous immunoglobulin. They wait for 4 to 6 weeks, and if there is no improvement in viremia, sometimes they use Cidofovir fortnightly in these people. Now, I will go to these alternative drugs just briefly. Leflunomide has anti-inflammatory agent. Also, it has also unique antiviral properties. And usually, we replace mycophenolate by leflunomide, and quite a few centers, they reported success with this regime. What do? They regularly, you have to monitor the blood count in these people, because there are some significant side effects of this drug, like hemolysis, hepatitis, thrombotic microangiopathy. There is a bone marrow suppression because of leflunomide. So you have to be little vigilant about following the blood count, liver function in these people. And you have to maintain the therapeutic response at between 40 and this other level in order to achieve what the effect of this anti-inflammatory and antivirus. The second drug, which is like commonly used nowadays, it's the intravenous immunoglobulins. It is commercially available, and it contains antibodies that neutralizes all major subtypes of BK viruses. So this is why it is used. And we know also this drug we use in antibody mediated rejection. So if there is mild rejection going into that kidney, it will also benefit these people with these immunoglobulins. It rapidly improves clearance of BK viremia, decreasing the potential of formation. Now, what happens when the virus invades the kidney? It is protected. It has got its own antibody, which is putting the immunosuppression of the rejection down. When this virus affects this kidney, this protection goes, and that antibodies which are there, allo antibodies, there is a formation of antibodies now which starts rejecting the kidney tissue. And as I mentioned, that patients who have a high I had mentioned this before, that who have got a neutralizing antibodies. Now, they did a survey in some people that when intravenous immunoglobulin was given to these people, it increased this neutralizing antibodies in these people, and it helped in preventing the rejection and the involvement of the kidney because of the BK virus. The other drug which is used with cidofovir, it is reserved as a last resort for the refractory disease. And its mechanism is poorly understood. It is not used very commonly because it is nephrotoxic, and it has not proved to be very, very effective. So this drug is very sparingly used. I've seen quite a few centers, even here, they are using mTOR inhibitor because it is thought that it inhibits the 70S phosphorylation with reduction of virus, especially the T antigen expression, as I showed you in the diagram. So it inhibits this part, so it doesn't allow the virus to multiply in the tubular epithelium. And in various centers, when after 18 months of patients, they found out that there were undetectable plasma BK virus in these people with improvement in the function. There are some cell-based therapy also, where they give T cells. Now, you will ask me, once, suppose if he starts improving, when will you start resuming the immunosuppressant? It is very difficult to know how long do you wait till the viremia is absent to start this immunosuppression. But you have to be careful that, because if you delay this introduction of the drugs and you don't reach to the trough level, this patient is going to develop chronic allograft rejection then. So it is a very delicate question, and they found out that for those recipients who have got a low risk, who is age 65, first transplant, or unsensitized, they recommend only to continue with calcineurin and antimetabolite, not to start mycophenolate in these people. But those people who have got risk factors, like those who are sensitized, who are retransplanted, or they have got donor-specific antibodies, you should try to reintroduce antimetabolite in a smaller dose and consecutively measure the viral load. If it reappears, then you will have to stop the antimetabolite for the lifetime. If somebody loses the kidney completely, can he be retransplanted? Yes, he can be retransplanted. And in these patients, induction and maintenance immunosuppression will be the similar which were used before. And you have to be careful. Don't use the thymocyte globulin in this patient. Try to use almitazobue. Now, when they did this thing, even then, nearly 17% of the people, they required the treatment for the BK viremia. Suppose in some person, if you can't reduce the viremia, if even there is a reduction of 2 log, that means if it becomes nearly 50%, you can transplant these patients. There is no need of surgical removal of transplant in this patient, right? Now, as I mentioned, there are some unresolved issues. One is, when do you call somebody is in remission? Do you look the biopsy and see that you can't find the antigen over there? You will say that this patient is remission. Or would you look at the viral state in the blood, whether it has resolved or not? It's a very difficult question. The second thing, the other issue we should be aware, because of this reduction of the immunosuppression, because of this polyomavirus inside the kidney causing chronic inflammation, and these people will tend to develop donor-specific antibodies. So you have to be careful. You have to keep a watch on this, that they don't develop donor-specific, or if they develop, then appropriate steps should be taken. Now, we tend to forget that these viruses are multiplying inside the renal system, and they can cause malignancy. So you should be aware about this. In the future, when you see these patients, you should be aware about the things. Thank you very much for listening.
Thank you, Dr. Riley, for an excellent overview and update of BK virus treatment. We'll keep the question for later. We'll just continue with our speakers. Now, our next speaker will be Dr. Fernanda Bonilla. She is a consultant in infectious diseases, co-chair of the antimicrobial stewardship program, and she is a member of COVID-19 task force at Cleveland Clinic Abu Dhabi. She's going to talk today and update us about the immunosuppression adjustment in patients transplant patients infected with COVID-19. Please, Dr. Bonilla, you can start.
Yes, good afternoon. Can you hear me?
Yes, we do.
Yes, I'm having some technical problems and I cannot see my camera. I'm sorry. So I don't know if this is there, if you are seeing everything well, if you are seeing my presentation.
Yes, we do.
Okay, wonderful. Thank you very much for the invitation to talk at this conference about this topic of COVID-19 in kidney transplant. I'm going to start and let me know how this is looking there. Unfortunately, I'm not able to show you this slide very well. But I wanted to talk first about risk factors in kidney transplant. So when talking about COVID in organ transplant, we need to start by talking about what are the risk factors for infection and bad outcomes in COVID and transplant. Unfortunately, this topic is difficult to investigate in publications. But what you cannot see here is the graphic that I have done, which shows which are the main risk factors for exposure, when we can start with the risk of exposure and the factors around the person, which are social distancing, duration of exposure, use of PPE, and intensity of the virus circulating in the community. Those are all key. But another key factor for the transplant community is the infectious dose that may perhaps still lower in this immunosuppressed population, but this is really not clear. Anyway, the measures to reduce the risk of exposure are well known to our transplant population, and they are also well defined in this publication by the American Journal of Transplantation. Now, the population of kidney transplant recipients in general has higher risk rate of comorbidities, and that's associated with worse outcomes in COVID-19, such as hypertension, diabetes, chronic cardiovascular disease. The impact and the role of immunosuppression, unfortunately, does not remains unclear, and it seems to be a double-edged sword. So on one hand, we have a higher risk that is suspected due to impaired immunity with inadequate response to the virus. And on the other hand, we have the already established immunosuppression that actually could be an advantage, and we think it's an advantage to control, to tame the hyperinflammation response and cytokine storm that is present in later phases of COVID-19. So again, unfortunately, immunosuppression is rarely included in the risk scores, and the impact remains unclear, and this role is not well defined at this point. When talking about immunosuppression and severity of illness, to expand a little bit more about the impact, knowing that the pathogenesis of COVID-19 includes this first viral response phase and then a host inflammatory response phase, it is suspected that immunosuppression medications affect the severity of infection, as the data from other respiratory illnesses suggest. by causing lymphopenia or causing a decreased humoral response and production of antibodies, but the impact is unclear. This negative effect includes the possibility of rejection, of course, triggered by infection and drug-drug interactions and the complications from these, like lymphocytopenia. On the other hand, immunosuppression, as I told you before, may have a positive impact by controlling these later in orange that you see here, host inflammatory response that is present in the later phase, as it happens to being suggested by other infections such as Staphylococcus aureus septicemia, which is found to have an improved mortality in patients with immunosuppression in some publications. So this is suggesting that immunosuppression may have an survival advantage. Also, the other important advantage that may have is that they have a closer monitoring by the medical team with increased access to healthcare. In terms of immunosuppression and outcomes, some publications, as you see here, have a look at this, and patients have an increased severity of infection, requiring admission to the hospital in a higher percentage. As you can see here, 87% in the French cohort by Caillard and colleagues, and also a higher percentage of ICU admission, ranging between 30 to 39% in this publication in the New England Journal. So in general, the mortality is high and depends on the severity of infection. That's the 28% that you see also in the cohort by Alkaline and colleagues. But many of these, again, let's keep in mind that many of these have medical comorbidities, and the limited data that we have suggests that these comorbidities are the ones that are driven all the complications in COVID-19. In terms of risk for mortality, in this publication by Cates and colleagues from University of Washington, older age and these comorbidities that you see here, congestive heart failure, chronic lung disease, and obesity, as well as the presence of lung infiltrates and lymphocytopenia, were independently associated with mortality by 28 days. But surprisingly, the transplant-related measures as surrogates of immunosuppression intensity were not. So as you see here, years of transplant, maintenance of immunosuppression, number of immunosuppressants did not correlate with mortality and complications. So really the mortality was similar to that described in the general population with comorbidities, and it was largely driven by the underlying medical comorbidities and these certain clinical features at presentation, but not by the immunosuppression intensity. And this has been found in other studies of kidney transplant patients by matched by two controls. In terms of clinical manifestations, immunosuppressant, immunocompromised patients in general for other infections can have atypical presentations of viral diseases. So in this first publication that is at the bottom by Gillen, they found a more atypical presentation with gastrointestinal symptoms at the beginning and less fever. So it's important to keep in mind these to have a lower threshold to test these patients due to possible subtle presentations and rapid deterioration. But in a most recent cohort from Spain, patients with solid transplant and COVID-19 presented very similarly to the regular cohort with fever in more than half of them, cough, dyspnea, myalgias, so very similarly. So it's at this point not very clear if they really, apparently not the majority present with atypical presentation. In this other big cohort from the US, we can also see that the main symptoms at presentation were very similar to the ones for the regular non-transplantation. Again, fever, fatigue, myalgias. And really the most common symptom was fever in 70% of the patients. So let's talk a little bit about the pre-transplant screening and the recommendations that we have from different societies, such as the American Society of Transplantation and the Transplant Infectious Diseases Society. So this is, of course, a work in progress. It's not completely clear at this point, but in general, donors and recipients are decline or defer if there is suspicion for COVID and not negative PCR, if there has been an exposure with a patient with COVID-19 within the past 14 days, and if there has been history of infection less and not 14 to 21 days, depending on the societies, have passed, and there's no resolution of symptoms yet. For those patients that have had infection, we need 2 negative PCR more than 24 hours apart, and 1 to 2 negative PCR, depending on the place, 20 to 48 hours before surgery. For the sampling, the PCR of respiratory samples are, of course, the most the established diagnosis, and the upper and lower samples are require better to obtain from deceased donors. In terms of the management, the adjustment of immunosuppressant regimen should be individualized and having in mind the risk for acute rejection, of course. But what we know from different publications, such as the 4 that we have here, is that in general, the antimetabolite was held in all of them. And in some of them, also the mTOR inhibitor, with the calcineurin inhibitor reduced and actually with stopped in some of these patients. So let's look at this cohort from France. They look at 279 patients, 243 were admitted to the hospital, and 36 were managed at home. Their median age was 61 years of the ones that were hospitalized, and most of them had the comorbidities, as we know. Unfortunately, I cannot show it here. Well, you can see it on the right side. So as I was telling you, most of them had comorbidities, and 31% of those hospitalized require mechanical ventilation. 20% died by 28. So that was the mortality among this population of kidney, in general, solid organ transplant patients. The age and underlying comorbidities, as I told you before, rather than the immunosuppression, were major drivers of mortality. And the most commonly used intervention was immunosuppression modification in 70% of the patients. As you can see on the right side, 56% of them had the antimetabolite discontinued, 10% of them had the metabolite reduced, and less than 1% had all immunosuppression discontinued. Some of them were on Betalacept. I'm sorry. Let me go back to this one. Hold on 1 second. Are you able to see it here? Yeah. Okay, let me go back to this French cohort. And then actually antimetabolites were withdrawn in 70%. Calcineurin inhibitors in 28% only. mTOR, for those that were on it, was stopped in 13 patients. And belatacept administration was postponed in half of the participants that were on this medication. So in general, the antimetabolite was the first one that was withdrawn. Hold on 1 second. I'm not finding here my cohort from Okay. Let me talk about now the cohort from Cates and colleagues, which is the one from University of Washington. That is the one with 480 solid organ transplant recipients from more than 50 transplant centers in the US that were included, and of those, 66% with kidney or kidney pancreas patients. The median time post-transplant was 5 years, and 92% of those had more than one underlying comorbidity, as you can imagine. Among those hospitalized patients, 117, 31% of them require mechanical ventilation, and the mortality on this one was 20% at 28 days. And as you can see here, 56% of them had the antimetabolite held or reduced. There is not much information on the other in medications, and we know that less than 1% of them only had all immunosuppression discontinued. So going to talking about steroids, these cohorts unfortunately don't talk about their strategy with steroids specifically, but we now know that steroids are the actually one of the few measurements, and it's part of the standard of care on patients with COVID. This was based on this landmark study from the UK called Recovery, that was a multi-center study, randomized controlled trial, but open label, that showed clearly that the mortality was lower with dexamethasone. So the 28-day mortality, as you can see here, was 22% for the dexamethasone group versus 25% for the standard of care group. And the survival benefit was actually a little bit different for the different requirements for oxygen at the time of the use of steroids. So those patients on invasive mechanical ventilation had clearly an advantage with much reduced mortality, 29% versus 41% of the standard of care. And there was also a significant benefit on the ones on supplemental oxygen, 23% mortality versus 26% mortality for the standard of care. So because of this, and moving to management, the most used strategy at this point is to reduce or hold the antimetabolite. The rationale behind that is that we know how useful this intervention is in controlling other viral infections such as BK and cytomegalovirus. And also we know the association of low absolute lymphocyte count with adverse outcomes of COVID-19. And now there's some evidence, but it's in vitro evidence, that mycophenolate, mTOR, tacrolimus, cyclosporin inhibit replication of coronaviruses. But keep in mind that this is all in vitro, and it has been also shown by many other medications that but this in vitro activity has not translated into in vivo activity. However, However, although there is no consensus yet, it is widely agreed that maintaining some degree of immunosuppression may provide protection in anticipation of the progression to the inflammatory phase and respiratory failures. So here, many transplant centers continue the calcineurin inhibitors, although they may alter the target trough by reducing those. And because it's also known that calcineurin inhibitors may have a role in ameliorating the cytokine storm, because they inhibit T cell activation and suppress cytokines, tumor necrosis factor, interferon gamma, and others that mediate this second phase of cytokine storm. But this is at the expense of reducing this immunosuppression. You should maintain some or increase the prednisone. This practice, as I just mentioned, was supported by the Recovery trial. The approach for antivirals convalescent plasma and supportive care is very similar to the non-transplant population. In terms of management, it's also important to keep in mind that these patients may have some prolonged shedding and longer isolation may be needed, and they may also have high rates of superinfection. In terms of COVID vaccine and transplant patients, immunosuppressive population has not been included in the studies of the vaccine. The main message for these patients is that the effectiveness and safety profile is not currently known. Although we know that all of them are non-live virus vaccines, and in general, they should be all safe in this population. It's important for the patients also to know that the vaccine response is probably going to be decreased compared to the general population due to their underlying baseline immunosuppression. And caregivers and household contacts should be strongly encouraged to get vaccinated to protect the transplant patient. So in conclusion, retrospective studies in a pandemic are limited by detection bias. But as we have learned from these publications, the risk seems to be primarily related to exposure, and it seems to be similar to non-immunosuppression cohorts, mainly driven by the underlying comorbidities and not much by the immunosuppression. So immunosuppression does not seem to make things worse. The most common strategy is to hold antimetabolite or reducing it, plus using steroids at the expense of that reduction in the immunosuppression, and especially on the late phase of the hyperinflammation and cytokine storm of COVID-19. Okay, with this, I finished my presentation. I apologize for the technical issues, but I hope you were able to see everything.
Thank you very much, Dr. Fernando. We'll keep the question for the end. I appreciate if you stay with us, yeah? I'm going to introduce our next speaker, Dr. Hanan Al-Basata, and she is a transplant infectious diseases fellow in Toronto General Hospital, University of Toronto in Canada. And she's going to update us about treatment of hepatitis C post-transplantation. So I would like to welcome Dr. Hanan. Please share your slides.
Good morning, good afternoon, everyone. I would like to thank the committee for inviting me to this important virtual meeting in kidney transplant. So I'll be discussing mainly about hepatitis C and post-renal transplant. This is my outline. So as an introduction, we know that in July 27, the WHO estimated that globally an estimated 71 million of people had chronic hepatitis C. And looking to the antibody prevalence and the mean in the Gulf region, the incidence of hepatitis C were at 20.5%, while looking for the viremia in hepatitis C itself, it was in Gulf region, which is 65.9, and specifically in UAE, the prevalence of HCV among the national was 0.24%, while among the foreigners it was 1.64. And it was also seen that in the hepatitis C prevalence among the patients who inject drug in the MENA region were 49.3. So, and if we can see the prevalence, and we know that the prevalence of HCV is more higher in hemodialysis patients, and this is one of the reports that was in Saudi Arabia showed that the prevalence of patient being in hemodialysis was 1.8 among the 400,000 official reports. And in the last decades, between 2006 and 2016, the prevalence was 19%. While in UAE, we have only a report in 1995 which is 25%. Unfortunately, we don't have any kind of updated prevalence in the last decade. So looking at this chronic hepatitis C infection increase the risk of end-stage renal disease, and in kidney transplant patient, it's associated with higher graft loss and mortality rate. Treatment with interferon regimen has been limited because of increased risk of interferon-mediated graft rejection and relatively low efficacy, resulting in unacceptable risk-benefit ratio. With the introduction of the direct acting antiviral agent were developed that are having high effective against all HCV genotype and seems to be safe and effective in clinical trial, as well as studied an immunocompromised patient such as a liver transplant recipient with HCV. An interest in using DAAs to treat HCV infection in kidney transplant patient has increased. And the next few slides, I will be talking about specifically the safety and the efficacy of DAAs in treating patients with post-kidney transplant with infected recipient. So this is one of the studies that it was conducted in Europe between 4 countries and 5 cities. They were actually randomizing patients 1-to-1 whether to receive 1 or 12 weeks or 24 weeks in treatment with a fixed dose of Lidipasvir, Sofosbuvir. One of the advantages of using this medication or this combination, first of all, it has less drug-drug interaction with the immunosuppressant agent. Second of all, it has relatively absent of effect in hepatic function, and it has a good pharmacodynamic medication. So the genotype that I specifically choose in this studies, it's mainly our genotypes, which is 4-to-1, which is predominant in our region. And the patient actually were enrolled in this patient within 6 months of transplant, and they were monitoring their HCV RNA, and the primary efficacy endpoint is the percentage of patient with HCV less than the lower limit quantification, which is 15 international unit at 12 weeks after stopping the DAAs. So if you can see, this is their demographic, and usually they had like 114 patients, and it was between November 2014 to mid of June 2015, and their predominant genotype were type 1, which is represent 91%, and out of this there are subclasses of 1B, which is represent 75 genotype, and the most patient that in the treatment itself, they were naive and did not have a significant impact of cirrhosis. Even for the cirrhosis itself, they have like a specific criteria and eligibility to include the patient, the cirrhosis score of Metavir was 4, and the Ishak score greater than 5, and they were doing a fibroscan for such a patient, which it should be the fibroscan greater than 12.5, even the AST platelet ratio index greater than 2. And this is the FibroScan outcome, and the median of transplant was 10-12. And this is the median creatinine that by Graft, which was 50-60%. This is their way of putting the patients, whether in the immunosuppressant agent that they were using. So as you can see, for the efficacy of the medication, Lidipasvir, Sofosbuvir treatment result in a good and a rapid cvRNA suppressant by week 4 among 112 patients out of 114, which represent 89%. And even following them, and after 8 weeks, almost 100% of achieving of suppressed RNA. And even while following the patient at the end of the treatment, while stopping after 12 weeks itself, it showed a good virological efficacy, and there was no evidence of virological failure or relapse in this patient. So if we look to the safety and tolerability, most of the common adverse effects among these patients were headache, followed by aesthesia, and only like almost 13 serious events were reported, such as an increase of serum creatinine that contributed only to with a raise of the immunosuppressant agent, and syncope and pulmonary embolism that was considered to be treatment related. And other side effect that it was seen also, the hyperuricemia that occur in 10 patients, and 6 of them were considered to be treatment related, but they reported that there is no reported gout among this patient. So, and this is for the renal efficacy. As you can see, all the time the renal reading was estimated GFR was stable among this patient, which is a good thing, and remained stable during the study of even the post-treatment week. After 4 weeks, the estimated GFR was between 0.6 to 3 milliliter per deciliter. Even 21% of patients that require, as I said, their adjustment of their immunosuppressant agent. So for the time being, I'll skip this slides because it is almost have the same patterns of including the patient and the genotype that they were using. That the DAA's treatment was mainly based on the genotype that available, and it's almost have the same result as I mentioned earlier. Even this meta-analysis that was conducted between like 5 to 6 studies have concluded the same. I'll discuss this study specifically as it was done in Egypt. It is one of the high prevalence in the world for HCV disease. And the difference between this study and the previous studies that in Egypt, they were including the patient who have evidence of decompensated liver disease, while the other research, they were almost excluding the patient who have an evidence of cirrhosis. Even the previous study mostly were focusing on patient naive, while in this patient, research, they have included almost 12 patients who had received previously an alpha interferon treatment, and they also included a co-infection of hepatitis C. And one of the patients, actually, he was suffered from hepatocellular carcinoma, and he underwent a chemoembolization. And looking for the DAAs, it is known that usually we treat based on the genotypes that of the patient itself and the renal function. So 109 of patients, they were receiving sofosbuvir-based regimen, while the other were receiving partipravir. Partipravir, it is known protease inhibitor. It has a higher interaction medication with the ritonavir. So this is a demographic of these patients. As I mentioned earlier, 12 of them, they were receiving interferon gamma, and the transplanted, till they started the DAAs, it was prolonged compared to the other study. It's actually 4 years, like 14 plus minus 7.5 years. And they were having history, or they have documented biopsy of acute rejection in 60 of the patient, or chronic rejection in 38 patient. And this is their description of the fibroscans, which was almost similar to the previous studies, usually between 1 to 2. And so for the result of these patients, for the result and the efficacy of the medication itself, a rapid virological response also was achieved in all patients after 4 weeks, regardless if they were cirrhotic or regarding of their genotypes and immunosuppressant protocol, even or the duration of the transplant itself. A sustained virological response at 12 weeks and 24 weeks was achieved in almost 113 patients. Only one evidence of relapse, which was after 3 weeks, and it was in sofosbuvir and ribavirin, and they were contributing of not compliance. And even if you can see that liver function enzymes, AST, ALT, have a significantly improvement after the treatment, which is with a p-value of 0.001. The graft-related complication was found in creatinine were raised in 12 patients, and only 8 patients they required biopsy, and 4 of the patients were found to have acute cellular rejection, while other 2 showed to be having chronic transplant chronic. The biopsy revealed a chronic transplant glomerulopathy, and the other patients have chronic calcineurin inhibitor nephrotoxicity. They contributed. The reason of graft failure were concomitant with an raise in immunosuppressant medication like tacrolimus, that it has a toxic effect in 3 patients. So looking specifically to, as I mentioned, the 5 patients who have Partipravir, which is known to have a higher interaction, and most of the patients who develop a rejection in this category, this is their pre-transplant characteristic and demographic. One of the patients actually had increase in LFT after 3 weeks of starting the treatment. And he even after like 3rd week, baseline was almost 30%, and in 6 weeks later, at 26 weeks, sorry, he had like reaching to higher, which is a triple of the normal kidney function, normal liver disease, which is 288. They haven't stopped. They noted they haven't stopped the medication itself, and they continue. And after stopping completing of the medication by 16 weeks, the kidney function improved dramatically. And this is for a graph showing between the graft function and the fluctuation of the medication. So regarding the graft function, there was a raise in serum creatinine in 3 patients, 60%, as you can see in figure 2A. And as I mentioned earlier, it was concomitant with mainly with immunosuppressant trough level. The struggle that they found it mainly in tacrolimus patients, who the good thing that they achieved that trough level within 10 days after a single dose of 0.05, and 2 of the patients, they have like maintained of higher trough level later on up to 21 days. So the thing was they have done as they were not able to modify the doses. So one of the patients, they augmented the tacrolimus and they kept him on 2 doses, while other patients were switched to sofosbuvir regimen that it has less interaction, and the patients successfully have an SVR of 12. While for cyclosporin, there was no reported any complication from that arm, while for sirolimus, they said that they achieved the trough level within 72 hours, but unfortunately, the patient was, after 21 days, he has been immunosuppressed, and he ended up with sepsis. After recovery from the sepsis itself, patient was switched to other regimens, sofosbuvir regimen. So this study showed that the treatment of DAAs based on the genotypes and the renal function, it's having a good outcome. So in the short term, in the side effects and in the graft function. So where this puts us in concept of a long term. So this is a single center experience in China, they were evaluating the long-term outcome of DAA's therapy and the impact of plasma concentration of immunosuppressant in Chinese cohort. And it was a retrospective and reviewed all HCV patient kidney transplant recipient that they initiated interferon-free interferon DSA regimen and January 2015 to December 2017. And total of patients, they were divided in two groups, who have lost their graft, there were 11 and on dialysis, while other two patients who received the DAs before the kidney, and the patient who received the DAs after the kidney transplant. And most of the patients, they were not cirrhotic, and the treatment cycle was initiated within weeks, which is 12 weeks. For sure, the DAs was based on the genotype that they having it. And for the virological suppressed, again, it's showing that after following the patient up to 48 and 96 weeks, there is no evidence of relapse or evidence of chronic hepatitis C. And while for the side effect itself, it showed that 4 of the patients have in dialysis group, they have side effect, and one of the patients has raised bilirubin that they investigated and was contributed to the not to HCV itself, to the medication. And one of the patients, 4 of patients actually, another group, the patient who received the DAs after the transplant, that who has initially raised in their creatinine function from the baseline, they have more raised in their creatinine and reported of lower lymphedema. So there's challenges that we are facing in kidney transplant, which is the waiting list. And many patients, they may take up to 10 years till they get transplanted, like in US. And this lead has a high impact and with the high mortality and morbidity in end-stage renal disease. And in the past, the transmission of hepatitis C from donor to recipient was a serious concern. However, with the landscape of HCV changes in 2013, with the introduction of DAAs, showed to have SVR almost 100 in HCV patient and has a safe profile in chronic kidney disease. So the way to expand the pool of transplant and ongoing trial and studies of in the last few years, they have been growing an interest of HCV donor and transplant population. And to increase the pool, they were including the patient, the donor who's infected and recipient who are unaffected. And why not? Most of the HCV patient, they are, if we can say, have less or few medical comorbidities. And so this is a slide that it is present in the guidelines of AASLD and IDSA, that how to handle the patient with HCV viremic donor. For sure, we have to explain the risk and benefit for the recipient itself, and we have to assure that within 7 days of the transplantation, we should provide an RNA result, and to start immediately when the patient is stabilized with a pan-genotype treatment that it's well described in the guidelines. And this is the same thing that we have to monitor them even for a long term for any kind of evidence of relapse. And this is the treatment based on the genotype itself, whether they are decompensated or compensated, and what is the criteria looking to the the donor kidney, and to exclude any kind of effect of the HCV in the kidney itself, and providing the genotype resistant in certain scenarios. and the regimen that it should be used, which is usually standardized between 12 to, we can extend it to certain, we can individualize it based on the risk factor of the patients themselves. So this is an expander trial. It is known that they were looking to the to single center that it is non-label, open label, non-randomized, and in John Hopkins centers in US. And they have included patients who were HIV and hepatitis C negative, and they took a biopsy from the liver and from the biopsy from the kidney also, and they documented there is no evidence of chronic changes in the donor kidney. Even as I mentioned earlier, one of the protocol, they were doing a donor serum RNA quantification and genotype within, it should be available within 1 week of the transplant, and they initiated the treatment immediately within first few days of the transplant itself. And they were looking to the patient after 12 weeks, and they were looking what is the effect and the outcome of this patient. So this is the characteristic of demographic of the patients. So most of them, as I say, they are younger, they are 30 years old. And this is while the other side, if you can see the recipient, they are older and they have, this is their comorbidity that led to renal failure. And if you can see also the weeks and the months of the transplant, it was dramatically decreased, like it is within 4 months, which is a good thing for who's waiting for the transplant. And if you can see out of this population, 3 of them, they have initially raised an viremic level. Well, a good thing, after following the patient of stopping this medication by 12 weeks, showed to be negative. And this is as I mentioned earlier, there is no evidence of virological relapse or any kind of clinical hepatitis, of chronic hepatitis C. And even the median creatinine during the follow-up and during the treatment and the post follow-up of after 12 weeks is showed of median creatinine were 1.05 milligram per deciliter, and the estimated GFR at 63.5. So the last study that I'll be discussing, and this study, they have like a different approach that they said if we wait, because we know that sometimes acute hepatitis C can be cleared by itself after 12. So they wait for the patient to be cleared after 12 to 16 weeks. If they have any kind of persistent in their RNAs, viral load, they start the treatment also based on the genotype of their patient. And this is also the baseline characteristic of the patient, of the recipient one. And this is the donors and the cause of death and their different genotypes that available and the way of treating and then immunosuppressant agents. So this study also have the concerns with the same previous studies that virological suppressant was almost 100%, and even the LFT function was having not affected at all. Actually, it was a good, it was only increasing by upper to 3, the triple of the normal, upper normal. And the time between the initiation of DAs and the transplantation was 76 days. Sorry. And this is comparing the liver function enzymes with the RNA. It's showed not significant effect of the liver enzymes, and they reported only like 1 episode of combined antibody mediated rejection and acute cellular rejection, and 3 patients developed acute cellular rejection. It was explained with the concomitant of PK infection and CMV reactivation. The good thing that there was no graft loss. And this is the medium of their GFR. It was stabilized between 60. So to conclude, can we transplant patient who's infected with HCV as self? The most of the study that have been showing with a different genotype that has been using, it showed to be safe from the SVR after 12 weeks. It is effective, and even there is less side effect in the kidney in itself and the graft. And that's it. Thank you.
Thank you, Dr. Hanan. We'll move on to the next speaker, and we'll keep the question to the end. We have our last speaker, not least today, Dr. Hcl Expression. She is she's Director of Renal Pathology and Medical Director of Electron Microscopy of Cleveland Clinic at Ohio, USA. She's specializing in interpretation of renal biopsies from both transplant and native kidneys for the last 15 years. I would like to welcome Dr. Hcl. She's going to talk about histopathology case-based transplant cases.
Good morning, everybody. Hopefully you can see my slides. I'm just going to take you through a quick transplant pathology tour using a case-based approach. What I hope that we can do today is basically understand the Banff criteria that we use in the diagnosis of T-cell and antibody-mediated rejection, and then to emphasize the potential for overlapping morphology and tissue injury that's caused by the various problems that can happen in an allograft, including rejection, infection, drug toxicity, and recurrent native disease. And I'll show you along the way the available techniques that we have that help us to differentiate among these various etiologies of allograft injury. So let's dive right in with the first case. This was from a 43-year-old man who had ESRD from polycystic kidney disease. He received a renal transplant from his cousin, and 1 year after transplant, he presented with a rising serum creatinine. His baseline was 1.8, and his creatinine was now up to 2.2. He'd had a protocol biopsy at 6 months that showed no rejection, but 9 months post-transplant, he developed BK viremia, and so he had his mycophenolate decreased. 2 months later, his BK was undetectable, and at the time of biopsy, immunosuppression was FK506 and low-dose MMF. So the first biopsy core actually looked really good. Here are 4 representative panels. We can see here that the tubules are back-to-back. There's very minimal interstitial inflammation. The glomeruli look essentially normocellular, and really this core looks excellent. So in that first core, we really had no evidence of cellular rejection. C4D staining by immunofluorescence was negative. And I think what I'm trying to drive home with this case is, what is an adequate biopsy? Do we need a second core? So this first core contained 8 glomeruli and 1 artery, showed no evidence of acute cellular rejection. And often the question that I get from people who are doing biopsies is a second core really going to change my management? Is it going to change your diagnosis? So I think that this is an illustrative case, because let me show you what the second core in this biopsy showed. A very different looking biopsy. So here, instead of the tubules being back to back, you can see that they're spread apart. There is a lymphocytic infiltrate here that is very diffuse and very active appearing. To show you with the PAS stain, you can see these tubular basement membranes, and you can see that many of these lymphocytes have crossed from the interstitium into the tubular epithelia. This is what we call tubulitis, and here it's pretty severe. Here you can see a tubule that's been almost overrun, more than 10 lymphocytes in this tubular cross-section. Just to show you that I'm actually showing you the same case, this is a low power picture of the slide, that first core that I showed you that looked quite good, and then this second core that is diffusely inflamed. So ultimately, this case ended up being diagnosed as a grade 1B rejection. And I think I'd just sort of like to circle back to what is an adequate assessment. Currently, the Banff criteria say that you need at least 10 glomeruli and 2 arteries. They highly recommend, but do not require 2 separate cores. And really a minimal sample for reporting is considered to be 7 glomeruli and 1 artery. In terms of the sensitivity of a 1-core biopsy, this was looked at back when they initially formulated the CCTT classification, which preceded the Banff. And they looked at 2-core biopsies and the sensitivity of adding that 2nd core versus just a single core. And what they found was for the diagnosis of rejection overall, a single-core biopsy had a sensitivity of about 91%, but a 2-core biopsy had a sensitivity of 99%. But more to the point, a single core biopsy really only had an 82% sensitivity for detecting endovasculitis. We definitely sample fewer vessels in a single core biopsy, and endovasculitis can be a much more patchy finding. So ultimately, the conclusion of this study was that a single core biopsy can lead to the undertreatment of rejection in about 10% of cases. So we really do encourage 2 cores whenever possible, and discourage just relying on a single core for the diagnosis, especially if you have a high pre-probability of rejection. In terms of what we look at in the Banff scoring of acute cellular rejection, we really focus on 3 different types of lesions. We look at the interstitial inflammation. Here we're going to restrict our assessment to the unscarred cortex only because scarred cortex can be non-specifically inflamed, and we basically break it down by percentage, whether you have less than 10%, which is considered to be essentially normal, 10 to 25%, 26 to 50%, or greater than 50%. We also look at tubulitis. We exclude, again, very atrophic tubules. And we also try to break a tubule into a unit of about 10 cells. You don't want to look at one huge tubule that has 20 cells in it or something and assess tubulitis in that tubule alone. But we're basically looking to see if tubulitis is present at all, whether it's minimal being less than 5 cells, moderate being 5 to 10 cells, or severe being over 10 cells. And then we also look at the vessels, and these are predominantly small to medium caliber arteries, and we're looking for the presence of any endovasculitis at all. If that occludes less than 25% of the lumen, it's a V1 lesion. If it occludes more than 25%, it's a V2 lesion. And then if there's transmural arteritis or fibrinoid necrosis, that would be a V3 lesion. So just to show you these histologic lesions, the I-score is based on this interstitial infiltrate here, which is really probably best assessed at lower power. The tubulitis score, that T-score, is based on the number of lymphocytes that you can see inside a given tubule, and the lymphocytes have this sort of smaller, darker nuclei, often with a halo, and you can see here that this tubule has upwards of 10 lymphocytes in that tubular cross-section. This is an example of a V1 or a V2 lesion where you can see that the endothelium of this vessel has been lifted up and these lymphocytes are undermining it, occluding a portion of the capillary lumen. And then this would be a V3 lesion where you have fibrinoid necrosis in this vessel wall. So once you have assigned your IT and V scores, you can then decide what grade of cellular rejection it is. So ultimately, a grade 1 cellular rejection is going to have just tubulointerstitial inflammation. You need at least 25% interstitial inflammation and 5 to 10 cell tubulitis to get a 1A. If your interstitial inflammation is over 25%, then you have upwards of 10 cells, that would be a Banff grade 1B. Once you get arterial involvement, you're in the neighborhood of grade 2 and grade 3 cellular rejection. Grade 2 would be a 2A if it's a V1 lesion, which would have less than 25% occlusion of the artery by the inflammation. Grade 2B would be more than 25% of the luminal occlusion. And then grade 3, which we rarely see except in really non-compliant patients, would be a transmural arteritis or fibrinoid necrosis, and that would be that V3 lesion. I should also bring up borderline changes here because often we will fall short of meeting the criteria for this grade 1 rejection and throw things into this category of borderline. I think that this is an important category to sort of understand how your personal renal pathologist calls these, because technically the way the Banff criteria is written right now, really any degree of interstitial inflammation or tubulitis could be considered borderline. But where I practice at the Cleveland Clinic, they often treat borderline rejections, even if creatinine is fairly stable. So we use a threshold of I1T1, which is at least 10% interstitial inflammation and at least a little bit of tubulitis rather than the lower criteria set in the current BAMF classification. I think a lot of published studies now have gone back to using this I1T1 threshold as well. So that wraps it up for acute cellular rejection. Let's move on to case number 2. This came from a 50-year-old female with end-stage renal disease due to polycystic kidney disease. She got a living unrelated transplant from her husband. Initially, she was a positive cross-match and was treated with plasmapheresis and IVIG for 9 cycles and then had a negative final cross-match. Her immunosuppression was FK506, MMF, and corticosteroids, and after transplant, she received another 2 cycles of plasmapheresis and IVIG. 2 weeks after her transplant, her creatinine rose from 1.2 up to 1.9, and they did a biopsy. So in contrast to the previous biopsy where we saw a lot of tubulointerstitial inflammation, one of the most notable things about this biopsy is that a lot of the abnormality appeared to be in glomeruli. You can see that this glomerulus appears to be hypercellular. You can see marginating lymphocytes within these glomerular capillaries. This lesion is called glomerulitis. Now, instead of the interstitial inflammation and tubulitis that we saw in the last biopsy, here you can see that there are markedly dilated peritubular capillaries and lymphocytes marginating within these capillaries. And this is what we call peritubular capillaritis. Now, the interstitium itself doesn't have much in the way of interstitial inflammation, and the tubules do not show tubulitis. So this is different than what we were looking at before. And then also in contrast to the first case, C4D staining in this case, and here it's shown by immunofluorescence, was diffusely positive in peritubular capillaries. So here you can see a glomerulus, which shows positive staining. That is not a specific finding. In fact, we usually see glomerular positivity for C4D. But the C4D staining we're most interested in is this peritubular capillary staining out here. So you can see this linear staining along this arcade of capillaries out in the tubulointerstitium. So this is a positive C4D stain. So what we had here was a combination of microvascular inflammation, which is that glomerulitis, as well as the peritubular capillaritis. And then we have diffuse C4D positivity. And these are the histologic findings of acute antibody-mediated rejection. In terms of the BAMF scoring that we look at in acute antibody-mediated rejection, we're mostly interested in 3 scores. First score is the G score, or that glomerulitis score, and this is just the percentage of glomeruli with that glomerular capillary inflammation. We're also interested in the PTC score, which is the peritubular capillaritis. Again, we're interested in seeing at least 10% of peritubular capillaries display some degree of capillaritis, and then we base the PTC score on the most severely affected capillaries. And then we look at the C4D staining. Again, this is a percentage score, the percentage of peritubular capillaries that are showing positive staining. In order to diagnose antibody-mediated rejection, you need to see 3 things for definitive diagnosis. If you can fulfill 2 of these 3 categories, it's considered to be suspicious for acute antibody-mediated rejection. So the first is the presence of some form of tissue injury that is in the spectrum of antibody-mediated rejection. This could come in the form of microvascular inflammation, like we saw in this case with a positive G or a PTC score. Intimal arteritis or transmural arteritis, so those V lesions we talked about in the setting of acute cellular rejection, can also be seen in antibody-mediated rejection. And if you see these V lesions in the absence of interstitial inflammation and tubulitis, you should consider the possibility that they may actually be a manifestation of antibody-mediated rejection as opposed to cellular rejection. Now, acute tubular injury can also be seen in antibody-mediated rejection. Obviously, there are lots of other causes of ATN that can happen in the transplant setting. So I rarely use this criteria unless I see it in combination with diffuse C4D positivity, as well as a positive DSA. And then thrombotic microangiopathy can also be a tissue injury pattern that we see in antibody-mediated rejection. So really a pretty large array of potential lesions that can be in that spectrum of tissue injury. C4D staining is sort of the most common way that we demonstrate antibody interaction with endothelium. But we have recently sort of loosened the criteria for this criterion. And if you have at least moderate microvascular inflammation, so the G score plus the PTC score exceeding 2, you can use that instead of C4D staining, because we've now recognized that there are some C4D negative forms of antibody-mediated rejection. And then the third criteria is the clinical finding of a circulating donor-specific antibody. In terms of that histology, again, that C4D staining here, you can see this linear staining of peritubular capillaries. This is an example of a case that had ATN as its manifestation. Again, this doesn't look any different than ATN from, say, ischemia. So you do need to be careful to make sure that you don't overcall this and don't mistake an ATN from another cause for being an ATN due to antibody-mediated rejection. Here is an example of peritubular capillaritis, again, a dilated and inflamed peritubular capillary. This is an example of an antibody-mediated rejection that presented with thrombotic microangiopathy. Here you can see glomerular capillaries filled with fibrin. And then this was a patient who stopped taking their medications and had both a thrombotic microangiopathy as well as some transmural arteritis with fibrinoid necrosis of the vessel wall. This would be a V3 lesion consistent with antibody-mediated rejection. Just a brief mention about the C4D staining. What we use predominantly in our lab at the Cleveland Clinic is immunofluorescence staining. I prefer it because I think the signal to noise ratio is better. You can also do the staining by immunohistochemistry in labs that are not outfitted for immunofluorescence if need be. It's just a little bit harder to interpret. And then the threshold for interpretation is a little bit it's a little bit lab dependent, but basically any staining that we see on these immunohistochemical stains is potentially considered to be positive, whereas we'd need a more diffuse staining by the immunofluorescence. All right, so on to case number 3. This comes from a 62-year-old man with end-stage renal disease due to IgA nephropathy. He received a deceased donor kidney transplant 9 years previous. His medications on maintenance were FK506 and mycophenolate, and his baseline creatinine was 1.5, but he's had a recent rise to, or 1.7, but he's had a recent rise to 2.5. The prior year, his proteinuria was only trace on a dipstick, and now he's presenting for follow-up and is found to have 3+ proteinuria. His urinary sediment was bland. So this is a low power picture. This is an allograft that's been in for almost 10 years. So not unexpected that we would have some fibrosis and some glomerulosclerosis, but you can see even from low power that this glomerulus is hypercellular. Now, given that his cause of ESRD was IgA nephropathy, I would be potentially concerned about recurrent native disease. That's always something that we have to have in the back of our minds. And since his native disease was a proliferative GN, I would really want to make sure that I do the full immunofluorescence panel to exclude the possibility of recurrent native disease here. As we look a little bit more closely, you can see that there is endocapillary hypercellularity, which certainly we can see in the setting of a proliferative GN. But the other thing that we see here is extensive duplication of glomerular basement membranes. And this is really more consistent with what we typically see in the setting of transplant glomerulopathy and glomerulitis. We have this extensive duplication of the GBM, which suggests an ongoing form of endothelial injury, as well as these marginating lymphocytes, which are exacting that injury. Here again, you can just see more of this extensive duplication of these GBMs. And this is the C4D staining. It's a little bit less impressive than what we typically see in the setting of acute antibody-mediated rejection, but you can see that at least some of these peritubular capillaries are showing this linear staining, while others are more negative, a more patchy C4D. By electron microscopy, we could see here that there are no electron-dense deposits here. And I'll say for the record also that IgA staining by immunofluorescence was negative, providing evidence against recurrent native disease. But instead, what we see is this endothelial injury. The endothelial fenestrations are largely lost, and you have this subendothelial widening and the beginnings of a duplication here of the glomerular basement membrane. This is very characteristic of what we see in antibody-mediated rejection. We also could see these peritubular capillaries. The basement membranes around these capillaries were thickened and quite lamellated, and this again suggests that there's been recurrent endothelial injury here that has remodeled this basement membrane over and over and over again. So ultimately, this is a good example of chronic active antibody-mediated rejection. We did have C4D staining. It was not diffuse in this case, but it did involve between 25 and 50% of the peritubular capillaries sampled. We also had a really nicely developed transplant glomerulopathy, and this is a score that we call the CG score, and basically we're looking at the percentage of double contours that we see in the most severely affected glomerulus, and in this case it was well over 50% of the glomerular capillaries showing double contours. In terms of the Banff criteria for assessing chronic active antibody-mediated rejection, again we were looking for three things. One is morphologic evidence of chronic tissue injury. This can be as transplant glomerulopathy, which we've had here. It could also be peritubular capillary basement membrane multilayering. Now, in order to see this change, you have to do EM. We don't always do EM on our transplants, but we do typically do them on transplants where proteinuria is a significant presenting feature. And then you could also see new onset arterial intimal fibrosis without other causes like hypertension. That can be a morphologic form of antibody-mediated rejection. And then again, we're looking for evidence of antibody interaction with the endothelium. Probably the easiest way to demonstrate this is with positive C4D staining, but a significant proportion of patients with chronic active antibody-mediated rejection may show minimal staining. And again, one of the markers of activity that we use in this case would be the presence of active microvascular inflammation. So a G score plus a PTC score at or exceeding 2 is considered to be evidence of activity. And then that third is, of course, the clinical demonstration of donor-specific antibodies. We need all three of these for a definitive diagnosis, but 2 out of 3 would be consistent with chronic active AMR or suspicious for chronic active AMR. Okay, moving on to case number 4. This comes from a 72-year-old man with end-stage renal disease from diabetes and hypertension. He got a deceased donor kidney transplant 22 months prior. His medications include FK506, mycophenolate, and prednisone, and he had a recent increase in creatinine from 1.2 to 1.5 in the setting of positive BK viremia. So this is what his biopsy looked like. You can see here that there's quite a bit of interstitial inflammation. There is some tubulitis here as well. And this you would look at and think, my first thought would be, acute cellular rejection. But when you take a little bit of a closer look at these nuclei, you can see that there are some internuclear inclusions here that have this sort of smudgy texture. Some of the nuclei appear to be undergoing some apoptosis, and you have some sloughing of cells here. So anytime you see this type of cytopathic change, you should definitely be concerned about the possibility of a viral infection, most notably here, polyomavirus. I never rely just purely on the finding of inclusions. They can be nonspecific, they can be hard to see. So we always do an immunohistochemical stain or some kind of confirmatory testing. In this case, an SV40 stain. I like the SV40 stain. Notably, the SV40 will stain any polyomavirus, including BK and JC. So I like to pair that with serum demonstration of BK viremia. But here you can see that these nuclei stain very darkly for polyomavirus here, and that the staining detectable by the immunohistochemical stain is vastly more prominent than what we see just in terms of looking at inclusions. So this is an example of BK virus infection involving the cortex and medulla. Just a couple quick words about the diagnosis of BK. We have basically abandoned looking for decoy cells in the urine and urine PCR because they're very nonspecific. Blood PCR certainly correlates a lot better with the presence of BK nephropathy. Again, nuclear inclusions are nice when you see them, but we really need to confirm their significance with an SV40 stain or some other form of viral detection. And you really need to sample medulla for adequacy in order to exclude this because BK is an ascending infection. In terms of its prevalence, it can involve between 1% and 8% of the biopsies that we see. It typically presents between 6 months and a year, but it can occur earlier or later. And it is a really important cause of graft failure and can be asymptomatic. One of the questions that I often get from my nephrologists is, can you have BK and rejection at the same time? And the answer is absolutely. And unfortunately, it can be a difficult diagnosis to make because of that overlapping morphology with acute cellular rejection. The only way to know for sure would be to have a positive SV40 stain and some endovasculitis, which would be like a grade 2 rejection along with positive BK. But often in practice, what we'll see is the viremia will spike, you guys start to go down on immunosuppression, and then the creatinine starts to rise. And it can be very difficult to say whether that's because of the BK or because immunosuppression's been lowered and now rejection is creeping in. So one of the things that I like to do is I look at that interstitial inflammation. I see where the parts of the core are that are affected by the interstitial infiltrate. And then I look to see whether that correlates with SV40 staining in those areas. So if I have, focal localized SV40 staining in the medulla, but I have a lot of cortical inflammation, at that point, I would consider the dual diagnosis of a grade 1 cellular rejection as well as BK nephropathy. In terms of the classification of polyomavirus nephropathy, this is a relatively recent addition. This was published in 2018 by a group led by Volker Nicolait. And basically, we classify polyomavirus nephropathy based on the percentage of positive tubules. So that's a tubule with a positive staining cell with an SV40 stain. And then we combine that with the degree of tubulointerstitial fibrosis. And what they ultimately found was that there are 3 classes that are worth breaking down. Class 1 was associated with graft failure at 24 months, and only 16% of cases. That doubled if you had a class 2 to 30% of cases, and if you had a class 3 polyomavirus nephropathy, 50% graft failure rate at 24 months. And class 3 was largely driven by severe infection rates, so a lot of BK staining, as well as moderate to severe fibrosis, whereas class 1 polyomavirus nephropathies have only very focal involvement in terms of staining and either absent or mild fibrosis. All right, case 5 is a 56-year-old man with end-stage renal disease secondary to type 2 diabetes. He received a living unrelated transplant 5 weeks prior to biopsy. His nadir creatinine had gone down to 1.4, but he now has a sudden increase to 3.2. Medications were FK506, mycophenolate, and prednisone at the time of biopsy, and his most recent tacrolimus level was 25, which is markedly elevated for our lab. BK serum PCR was negative. Donor-specific antibody testing 1 week prior was also negative. And this is his biopsy. We don't appreciate any significant cellular infiltrates here, but the tubules do look strange. This is the straight segment of a proximal tubule, and you can see that it shows a lot of prominent vacuolization. And this is what we would term isometric tubular vacuolization. You can also see that well with the trichrome stain here. You can see these proximal tubules have all this cytoplasmic clearing and vacuolization. But beyond that, his glomeruli showed some prominent ischemic changes. You can see here the glomerular tuft is retracted. There's this extra space out here in Bowman's capsule. And then the arteriole leading up to that glomerulus shows this intimal edema and even some entrapped schistocytes. And one of his glomeruli actually even showed a thrombus here. This is a fibrin thrombus at the vascular pole. And you can see here the glomerular capillaries show this endothelial cell swelling. And then there's what we call mesangiolysis. The mesangium here has been essentially dissolved. And this is a lesion in the spectrum of thrombotic microangiopathy. Some of his smaller arterioles were beginning to show what we'd call sort of beaded arteriolar hyalinosis, where the nuclei, which one of them is viable here, but sometimes the nuclei become hyalinized and you get this sort of beaded hyalinosis. And so ultimately, these are all the sort of stigmata of calcineurin inhibitor toxicity. In the tubules, we saw that isometric vacuolization. In the glomeruli, we saw thrombotic microangiopathy and ischemic features. And in the vessels, we saw that hyaline arteriolopathy, as well as that thrombotic microangiopathy. Now, TMA is a particularly problematic lesion in the transplant, as well as the natives, of course, because it can be seen in the setting of antibody-mediated rejection. It can be seen in the setting of calcineurin inhibitor toxicity, and then it is also probably an underappreciated underlying cause of native disease. Whenever I have one of these cases, an end-stage renal disease is attributed to quote-unquote hypertension, but the patient was never biopsied, I'm always concerned if I see a TMA in that case that this could potentially represent native disease. So it's really important to look at the company that's being kept by those TMA lesions to try to help figure out what's going on. Case number 6 comes from a 69-year-old woman with end-stage renal disease attributed to hypertension. Again, that's a little bit alarming. I always worry about those cases in terms of the potential for recurrent native disease. 9 years after transplantation, she actually develops nephrotic syndrome. Creatinine was stable at her baseline of 0.7 to 0.9 milligrams per deciliter. Her medications were FK506 and mycophenolate, and they went ahead and did a biopsy. So for being as far out as she is, her allograft actually looks good. There is some interstitial fibrosis here, but quite a bit of viable cortex. When we look a little bit more closely with the PAS stain, I think there are several things to appreciate here. First is we don't see an active tubulointerstitial inflammatory component. I don't see any interstitial inflammation that's significant. I don't see any tubulitis. The peritubular capillaries here are neither dilated nor inflamed. The glomerular capillaries are not inflamed, but the glomerular basement membranes do look a bit thickened here. And when we look a little bit closer with the Jones stain here, we can see this beautiful vacuolization and GBM spike formation consistent with membranous nephropathy. This is her immunofluorescence staining for C4D. So what's notable is you see this global granular capillary wall staining for C4D. Now, I previously mentioned that C4D is often positive in the glomeruli, and that is true. But the non-specific staining we see for C4D is not granular. It's this sort of semi-linear mesangial and segmental capillary wall staining that we often see. This granular staining is not typical of the sort of non-specific staining that we see. So whenever I see granular staining for C4D, I'm interested in doing the remainder of the full immunofluorescence panel for light chains, heavy chains, and other complement components. And in this case, she showed similar granular staining for IgG, C3, kappa, and lambda. So this is clearly membranous nephropathy. Now, C4D staining is notably negative in peritubular capillaries. Membranous nephropathy can also be a form of antibody-mediated rejection. Occasionally, you will form antibodies to some podocyte antigens, and it's indicative of a form of AMR, but here we don't see any C4D staining in the peritubular capillaries, which would provide partial evidence against this being an antibody-mediated rejection. And the other useful stain here, of course, is PLA2R, which I'll show you in a second. Here is the EM, though. You can see these beautiful subepithelial deposits and the diffuse podocyte foot process effacement and these intervening GBM spikes. Looking at that endothelium, just to assess whether this could be antibody-mediated rejection, we see that the endothelial fenestrations are nicely intact, and there's no subendothelial widening that would be particularly concerning for antibody-mediated changes. And this is the PLA2R, which is nice and strongly positive. So this is an example of what we would call a primary membranous nephropathy. In this case, I think that it's hard to know whether this is recurrent or de novo because that end-stage renal disease was sort of attributed to hypertension, but it could be either. And I don't think it really matters all that much which one it is. Both C4D and DSA testing were negative, which argues against this being a membranous nephropathy due to AMR. And the patient was treated with Retoximab, which we actually might have used for either antibody-mediated rejection or a de novo membranous. And then 6 months later, after initiation of therapy, her proteinuria had fallen to less than 1 gram. So definitely a treatment success. So I'm going to wrap up here. The take-home points that I just want to send you with would be that renal allografts can show really diverse pathologic findings that can coexist with rejection. Just because you have rejection doesn't mean you also don't have infection, medication toxicity, or recurrent native disease. So you really do need to keep all of those 4 categories in mind as you're reading these biopsies. Sampling is really important, and undersampling can really lead to a misdiagnosis and a false confidence that we understand what's going on in these allografts. So I do encourage 2 core biopsies whenever possible. And then just recognize that that histologic patterns of disease can be quite similar in multiple settings. Inflammation and tubulitis can be seen in polyomavirus nephropathy as well as acute cellular rejection. Glomerular hypercellularity can be seen in antibody-mediated rejection or recurrent disease. Thrombotic microangiopathy can be seen in lots of settings, including medication toxicity, rejection, and recurrent native disease. And so we really need this full host of special studies, including SV40 staining when needed, C4D staining, and all of those potential things based on what we're seeing. And I mention this because when I'm reading biopsies from half a world away, I do try to give preliminary diagnoses based on digital scans of H&E stained slides. But you can see that the pitfalls of that are pretty numerous because that interstitial inflammation and tubulitis might appear on the H&E stain slide to be most consistent with a cellular rejection, but then, a week later I get that tissue and we do an SV40 stain and it turns out to be a polyomavirus nephropathy. So I think from the point of view of being a consumer of biopsies, especially if you're relying on a preliminary read that's based on limited workup, that you do need to be cognizant of the overlapping patterns and what the pitfalls of relying on a prelim diagnosis are. So that is all I have for you. Happy to take questions. Thank you.
Thank you, Dr. Leal, for such an interesting cases. Now we'll start with the questions. I would like to invite all the speakers to be on, please. So we'll direct them the questions related to their topic. First question was for Professor Cunningham. Professor, the question says, effect of ethyl calcitide more on calcium level. Should we be worried about hypocalcemia?
Well, since the era of cinacalcet, we've had to think about hypocalcemia much more frequently, obviously. Both in dialysis and transplantation with patients treated this way. I'm perfectly delighted to see serum calcium running at the bottom of the normal range, by and large. But in fact, it's not necessary to do that. And if you drive calcium down too far with a calcium-mimetic drug, the inevitable result is that it's harder to lower PTH. So very often in dialysis, as everyone has experienced, you find yourself using both calcitriol and a calcium-mimetic to try and balance the two to achieve the serum calcium where you want it, and exploit the combined effect of the two on PTH. And that would apply with whether you're using cinacalcet or ethylcalcitide, and in general, it would also apply following transplantation, although less of an issue there, because you're really only ever going to use this in transplantation when the patient's hypercalcemic as well.
The question again is for you, Professor. In your opinion, are the nephrologists, apart from treating CKMBD optimally, are missing the opportunity to treat the dialysis patients-related osteoporosis and their factors and their fracture risk with anti-resorptive agents?
Well, that's a question that really requires at least an hour of discussion. And even then, we wouldn't have all the answers by any means. It's a difficult area. There's no doubt these patients fracture more than they should. Funnily enough, osteoporosis is not that common, but fragility, mechanical weakness is much more prevalent. So we have a real issue with bone quality in these patients, as well as bone quantity. Now, the trouble about using anti-resorptives fairly freely is that not all these patients have actually got accelerated resorption. And it makes no sense at all to treat a patient who's got a low bone density and fractured and has adynamic bone disease. To give them a bisphosphonate is not going to work, and arguably may do damage as well by making the adynamic bone disease even worse, increase the fracture risk. So in an ideal world, you would only use bisphosphonates when you have the access to the bone histology with a biopsy. In the real world, that's not going to happen because of limited facilities and high cost. So it's not going to happen in routine practice. So my take is set the PTH parameters more or less according to KDIGO. Use the levers you have, i.e. vitamin D compounds and calcimimetics. Get the PTH right. And then if there's still evidence of accelerated resorption, either on the basis of an X-ray or the fact that PTH cannot be brought down to the level you need to get it to, which is very unusual, in fact, if that can't happen, then consider a bisphosphonate.
Okay. The next question for Dr. Fernando. Can you highlight about the importance of COVID vaccinations pre and post-transplant, please? Dr. Fernando, are you there?
Yes, I'm here. Can you hear me?
Yeah.
Thank you. Yes, the vaccine, of course, is very important at this point of high community exposure during this pandemic. As I mentioned during the meeting, during my talk, we don't have much information on immunosuppressed patients specifically, but it should be safe as they are all non-live. It is recommended to give it 1 month before transplantation or 3 to 6 months after transplantation. Of course, the decision is individualized depending on the net state of immunosuppression and the induction therapy that has been used.
The second question to you, Dr. Fernando, is what is the role of plasma infusion or plasmapheresis in the management of COVID patients with kidney transplant?
I have not used plasmapheresis. Convalescent plasma, it's still not FDA approved that use during clinical trials, and it has been used in several case reports with no issues, no induction of rejection, and no HLA antibody production.
Are you using your center?
Yes, for some patients we have been using convalescent plasma, but not specifically for kidney transplant patients.
Yeah. Okay. And what is your opinion regarding antiviral in the management of COVID pneumonia in renal transplant patients with a GFR less than 50 or less or more than 50?
So the only antiviral that has been approved is remdesivir. We would consider it early in the disease when the patient is already hypoxic, but not mechanically ventilated in general. Remdesivir has a good, per the manufacturing company, it's not, you should be careful with the use when the GFR is less than 30 because it has cyclodextrin, which is toxic. So there is a theoretical concern of toxicity because of the cyclodextrin. But given that the course is very short, it's about 6 days, and the cyclodextrin amount is very small, it seems to be okay to use it, and it has been used in case reports. So I would use it when you consider it's indicated relatively at the beginning of the course of the COVID infection.
Professor Austin Stock, are you there? Professor, the question is for you. What is about using paltusotine in patients with advanced CKD who are not moderate to severe, with the moderate to severe hyperkalemia, and they are not on ACE inhibitor or ARBs?
Hi there, sorry, I had to leave for a little emergency and I'm back, so apologies for that. So if I can get the question correct, that what about patients who are not on RASI therapy and who are hyperkalemia? I think we need to be careful, and like everything else, there needs to be a multi-strategy approach. All patients, I think, who are prone to hyperkalemia should be on a low potassium diet. We've got excellent dietitians to advise on that. Unfortunately, prescribing a low potassium diet and getting compliance can be a challenge for patients in Ireland, and I'd say in your country as well. So there's an unpredictability of response. But beyond that, there are some strategies we can use before we embark on the use of patiromer or SCC. First of all, if patients have a coexisting metabolic acidosis, I think we can manage those reasonably successfully with sodium bicarbonate administration, as long as it doesn't contribute to negative problems with a volume overload. So a number of patients will benefit from that approach. Secondly, there will be patients who are by nature prone to volume overload, certainly our nephrotic patients, patients who get significant proteinuria, patients with coexisting heart failure, and they may benefit from a loop diuretic. But I think if you're looking for a safe, effective, proven strategy, I think the new potassium binders appear to offer that, a predictability in terms of response and a normalization of potassium. So to answer the question, yes, for patients who are hyperkalemic, who are not on an ACE or ERB, I certainly would recommend those therapies as long as the other strategic approaches have been tried and have failed.
Yes, thank you very much. And the second question for you is by Dr. Abraham. In UAE, we are using calcium resonium 15 grams once per day with lactulose to treat the hyperkalemia. Do you share the same experience?
Yeah, and it's interesting. We've actually been discussing that recently with our colleagues in Ireland, and I don't know if it's the same in the UK and Europe. So we use calcium resonium here in Ireland mainly for a short-term duration, but certainly not long-term. But there are a couple of patients on dialysis and a few with advanced CKD where we tend to use it. I haven't used it personally, but they might be on it once or twice a week with a laxative included. Again, my concern with that is that generally these are kind of case-based or personal experiences. There is no hard evidence on the long-term efficacy benefit and the side effect profile of this. We do know that there's an FDA warning with these agents in the United States. My view on that, I think, I would like to use a treatment strategy that is efficacious, that there's a proven evidence base, and that there is a good tolerability and side effect profile. So it wouldn't be my favorite choice. And so if I had the choice, certainly based on what we know now, I would use patiromer or SHC as a treatment strategy.
Thank you very much. With this, I would like to conclude our meeting today and thank all the speakers for their effort and hard work and excellent presentations and informations which they added to us. And I would like to invite all the attendees to put their cameras on, whoever are interested to be in a picture, a group picture, as a memory for this meeting. And we hope this will be the first and not the last meeting for the transplant. As I mentioned earlier, we have started in Dubai Hospital recently the transplantation, and our target to continue and go on. So waiting for the rest of the attendees who want to be in the picture. Okay. So shall we start then? Dr. Khat.
Let us know when to smile.
Yeah, please smile, yeah. Yes? Any more? Okay. Okay, then I think we'll start. Yes? Great. So, Mr. Ahmed, we'll start.
Doctor.
Thank you very much. Thanks a lot for taking this time to be with us.
Thank you very much.
Thanks a lot. Bye. See you.
Thank you very much. Bye.
Bye. See you. Nice meeting you all today.
Same here.